Advanced Medical Education from the University of Toronto. She is currently a fellow of the Royal College of Dentists of Canada, and she had a diplomat of the American Board of Oral Maxillofacial Radiology. Please welcome Dr. Maryam Baghdadi.
All right, thank you very much for that kind introduction, and for those of you who were able to make it at a 9 o'clock lecture. So today we're going to be talking about diagnostic imaging dilemmas, and we're going to do this through a case-by-case, in a way that we're going to just look at cases. And when I was asked to give this talk specifically, we wanted to sort of look at everyday cases that most of you see in your clinic, dilemmas that can come up with common lesions. So we're not going to be really covering any lesions that come out of the normal and out of the common things that you will see in your general practice. So what we're going to be doing today, we're going to start out with the importance of radiographic interpretation, and then I'm going to take you through a step-by-step visual algorithm that you can use on a day-to-day basis whenever you look at your radiographic images, and especially if you're looking at images that has a difficult appearance or has an untraditional appearance to radiographic appearances. Then we're going to go through 5 different cases that I called radiolucency non-vital, no clear cause, part 1, and then we're going to have a second one, part 2, and then we're going to look at midline radiolucencies, and then look at cyst versus follicles, and then hopefully at the end we can have a discussion and get some questions in. So what is the importance of radiographic interpretation for a general dentist? So we have to remember that unlike our medical counterparts, the dentist is responsible for interpreting their radiographic images. In medicine, for instance, who's reading our radiographic images? It's a medical radiologist. But in dentistry, you are going to be doing the interpretation. So ethically and legally, you are responsible for anything that appears on your radiographic images. Obviously, providing appropriate treatment and avoiding unnecessary treatment and unnecessary investigations, and hopefully any early detections of serious and severe conditions. Now, this is going to be the important part. I want to give you a visual algorithm, and this is going to be sort of a tool that you can use whenever you're looking at your radiographic images. This is going to come especially important when you're looking at images that have radiographic lesions or radiographic abnormalities that you're not quite sure what you're looking at, or you're not quite sure what diagnosis it is. So the first step whenever you're looking at your image and you identify an abnormality is you're going to start by localization of the abnormality. So what does localization mean? We're going to look at the anatomic location, so specifically where does this lesion occur? Is it in the maxilla? Is it in the mandible? Is it in the posterior part of the mandible? Posterior part of the maxilla? Is it periapical? Is it pericoronal? Is it above the inferior alveolar nerve canal? Is it below the inferior alveolar nerve canal? All of these things will help you identify what we call tissues of origin, and the epicenter will give you an idea of what this lesion could potentially be. Then we're going to look at whether these lesions are single or they're multifocal. Are they bilateral or are they unilateral? Because these are important points to think about. Bilateral changes in a radiographic image usually is something that is more a variation of normal. Also, bilateral, if we think about bilateral lesions, you only have a really short list of lesions that happen bilaterally, so that's going to help you, again, limit your differential diagnosis. Through localization of an abnormality, you're also going to be able to identify the size. So what is it occupying? How big is the lesion? What is the anatomic space that it's occupying? Will give you an idea about the size. Next, we're going to go and look at specifically the periphery and shape of this lesion. So is this lesion a well-defined lesion or not? If it is well defined, is it corticated? Does it have a cortex, or does it not have a cortex? If it's not well defined, it's ill defined, you can't tell the beginning and the end of the lesion, then are the borders of this blending, or is it invasive? Then we're going to look at the shape of this lesion. Does it have a particular shape? Is it round? Is it hydraulic? Does it have a cyst-like appearance? Does the appearance look like it's space-occupying an undulant like a tumor, for instance? After you've looked at the periphery, you're going to go inside of this lesion, and we're going to start analyzing the internal structures. Is this a lesion that is completely radiolucent, homogeneously radiolucent? Is it completely radiopaque? And what is the radiolucency or radiopacity that you're looking at? Is the radiopacity, does it have the same density as bone structure? Does it have the same density as tooth structure? Does it have the same density as calcification? So those are things that are going to help. When you're looking at radiolucency, do you think that radiolucency has the same texture or density as fluid or air? And then, of course, we have mixed radiolucent, radiopaque, where you have a lesion that has both components to it. After we've looked at the internal structure, we're probably going to do the most important thing here, which is analyze the effect of the lesion on surrounding structures. And this particular part is going to give you a better idea about the behavior of that lesion. How is it interacting with surrounding structures? So as dentists, we have almost, I like calling it a litmus test. That's something that is very sensitive to change, which are both teeth, lamina dura, and periodontal ligament space. So lamina dura and periodontal ligament space will change anytime you have a pathological process going on. Now, normal structures will not change lamina dura or periodontal ligament space. Tipping, bodily movement of teeth will also be a good, some good indicators. Tooth resorption. Now we want to look at the effect on vital structures that are surrounding these lesions. So looking at the inferior alveolar nerve canals, looking at the foramen, nasopalatine canals, maxillary sinus. How do these affect bone cortices? So the surrounding bone cortices, like the buccal cortex, the lingual cortex. And of course, does this lesion have any effect on periosteum? So if it does affect periosteum, there are certain things that can happen. So let's give a few examples. So for instance, inflammatory lesions we'll call laminated periosteal bone reactions, which are pathognomonic for inflammation. If you find a periosteal bone reaction that has more aggressive type appearance, like a sunburst appearance, then you're thinking more on the long of something like a malignancy. So osteosarcomas, for instance. So this is a visual algorithm that you can apply basically on any lesion that you see. And this comes, again, as I said before, in particular with lesions where you haven't seen before and with difficult cases. So let's go into it and we're going to talk about cases and some of the dilemmas that fall on my desk in general from general practice. So these are things that you're going to see every day. These are things that I've seen with general practitioners and specialists where they're not really sure what's going on, especially when they look like common lesions that you see every day. So one of the bread and butter things that we see as dentists and as specialists are your typical periapical lesions that have inflammatory origins. So if we look at this one right here, you can see rarefying osteitis, where you have periapical radiolucency related to a tooth that obviously has an obvious source of infection. Then we have the opposite side, or the flip side of that, which is sclerosing osteitis, which is a more sclerotic reaction to inflammation with a very clear cause. So let's talk about some of the dilemmas that can happen when we see appearances like this classic one. And we'll start out with case number one. So case number one is a 52-year-old male patient. They came with a chief complaint of pain on biting in the right mandibular molar region. Upon examination, the patient had pain on percussion tooth number 4-7. The tooth was not responsive to cold, but here's the problem. The patient has excellent oral hygiene, no caries, no restorations, and absolutely no periodontal findings. So if we look at our panoramic radiographs, so our best friend in dentistry, panoramic radiographs, and our periapical radiographs. So if we look at tooth number 4-7, you can see that we do have an area of radiopacity, or we do see an area of sclerosis surrounding the tooth. And if we go down here and we see our periapical, you can see that there is widening of periodontal ligament space with a radiolucency related to the apex. Now, if we were to look a little bit deeper here and think about this for a second, this is a second molar. Second molars usually have two roots. So this might be a variation here with a single-rooted second molar. And if we look a little bit closer, you can see within the pulp is linear radiopacities that you can see within the pulp chamber. Now, to my trained eye, that is pretty suspicious of a dens indentae. Now, dens indentaes are usually on the premolars, but they can happen on the molars. And one of the things that are really important about dens indentae is that they happen bilaterally. If you find it on one side, go to the other side to see if it's there. So what we did here is to almost confirm our diagnosis. We went to the other side, and lo and behold, it is a lot more clear on this side. So you have another molar with clear areas of enamel canals within the pulp, with a radiolucent lesion at the bottom. And this was completely asymptomatic. Patient didn't even know they had it. Again, to my trained eye, this might be very clear. But if you're still in doubt, the next thing that has to be done is advanced imaging. Advanced imaging in cone beam CT is really important if you are still not sure what's going on or you still can't find that source of infection. So this case over here, we did a cone beam CT. And what you're looking at here in the middle, you're looking at an axial view. On the sides, you're looking at reconstructed panoramic radiographs of each side of the mandible. And down here, you'll see your cross-sectional images of that same region. So if we look at the cone beam CT area in the mandible, you can see bilaterally large radiolucent lesions with an extensive amount of sclerosis around those areas. And you can see it very clearly down here as well. So what is the diagnosis here? It is bilateral dens indentae with periapical pathosis. So in this case, the patient was referred to an endodontist. After careful evaluation of the canals, they decided that too much tooth structure was going to be removed. The teeth were removed and an implant was placed instead. So what is the take-home message from this particular case? When clinical symptoms indicate inflammation with no clear cause, cone beam CT is going to be essential for you to look for that cause. Now, when it comes to dens indentae, why do we see radiolucencies at the apices of dens indentae? So dens indentae is a dental anomaly that causes abnormalities in enamel. And what happens with that is micro-leakage from the oral cavity into the pulp, and then causes a radiographic appearance of periapical pathosis. These are usually very chronic in nature, and that's why we see sclerosis. So the micro-leakage that happens in the pulp, these leakage areas are not visible clinically, and they are not visible radiographically. These are microscopic. So the only thing that we can use as diagnosticians is to look for enamel infolding within the pulp. And you can see these pretty clearly on periapicals or on high-definition cone beam CT of specific teeth. So dens indentaes usually occur bilaterally. If you find it on one side, go to the other side and look for another one. You'll usually see it on the other side. Now, our second case is a 42-year-old female patient who works in flight control. The patient was on and off antibiotics for about 8 months because of pain and facial swelling. The chief complaint was pain and swelling in the left posterior mandible, and her main issue was no one could figure out why she had it. This even came in as a working diagnosis of salidinitis of the parotid gland. So when we did an examination, the patient had pain on percussion related to 3.6 and 3.7. There was clear buccal soft tissue swelling, and again, get this, excellent oral hygiene, perfect, no caries, no restorations, or any periodontal findings. So if we look at this crop panoramic radiograph, you can see over here the two teeth that we're looking at, 3.6 and 3.7. It isn't very clear here, but the patient does have a little bit of radiolucency or decreased density around the two teeth. Now there is an impacted molar, an impacted third molar, and it could be a cause. If you're thinking about causes, it could be a cause, but we need to dig a little bit deeper to see what's going on here. So our trusty periapical radiographs, we always use our periapical radiographs because of the high spatial resolution it gives us for the pulp and lamina dura and periodontal ligament space. So these are two different images with different angles for us to be able to see if anything was going on. And you can see here, and again, you're going to look at your litmus test that I told you about before, which is lamina dura and periodontal ligament space. If you look at lamina dura and periodontal ligament space, you can see that it's completely lost at the apex here, meaning that there is a pathological process that is involving the apices and the roots of the teeth. So again, here another example of something that pretty much looks inflammatory, but a clear cause isn't seen. So cone beam CT is the next line of investigation. So here you can see it absolutely clear. First of all, we can see its location. It's related to the two teeth. You can look at that it's very ill-defined. It does have a blending border internally. It is mixed radiolucent, radioopaque. It has a moth-eaten appearance around the teeth. And you can see that it's caused loss of lamina dura and loss of periodontal ligament space. But one of the most important features that we see here is right over here. And you can see a new periosteal bone reaction, and that is indicative of an inflammatory process. So in cases like this, what is the problem and what is the thing that's going on in our mind here? This is something that needs to be differentiated between inflammation and something more aggressive like malignancy. And this was actually taken for biopsy just to completely rule it out, and this came back as more of something inflammatory. The other thing is inflammatory always causes sclerosis. How do I know there's sclerosis here? Because if you look at the inferior alveolar nerve canal, the inferior alveolar nerve canal usually is very lace-like. We like calling it lace-like throughout the mandible. So you can see the cortex, you can't see the cortex, it kind of goes in and out. If you can see it very clearly the same way we see it here, that means that contrast is being caused by an increased bone density around the inferior alveolar nerve canal. So this again was called inflammatory of unknown origin. The endodontist went in here, they went in and did the endo, closed it up and asked the patient to go home, and the patient started to feel much better. But get this, 6 months later, the patient comes back with identical symptoms on the other side. No change in oral hygiene, no change in caries situation. Large amount of facial inflammation, again, swelling, and if we go to the right mandibular molar periapical region, again, we can see the sclerosis, and what we did here, again, is a cone beam CT to look and see what was going on. So exact same presentation, radiolucency at the apex, sclerosis, we have a bit of a periosteal bone reaction and inflammation in the same region. Now, the patient was at this point extremely upset. Why is this going to keep happening to me? All my teeth are going to end up like this. I have perfect oral hygiene. What's the problem here? So the endodontist here went in here, and as they were going through it, as they opened the access, they found a hairline fracture in the floor of the pulp, a hairline fracture. And that hairline fracture was only seen with transillumination. Now, the reason is the endodontist now is thinking, this might be a cracked tooth, and we didn't know about this. Now, when we took a little bit more history for this patient, we realized that the patient has a very stressful job, working as in flight control, and looking closely in the patient's mouth, the patient does have wear facets and did give a history of bruxism. So what was the diagnosis of this case? Bilateral cracked tooth syndrome associated with osteomyelitis on both sides. So what is the take-home message from this? Cracked tooth syndrome, basically what is it? Is it a fracture plane of unknown depth and direction that may involve communication with the pulp and the periodontal tissue, which then was called pulp necrosis, and then will cause everything that we saw in bone, inflammation to the bone. These fractures are usually very difficult to see radiographically. Unless the fracture line is as big or larger than the voxel size of the cone beam CT, there's no way you'll be able to see it. So what do we do instead? We look for signs of inflammation radiographically, widening of periodontal ligament space, sclerosis, bone sclerosis, periosteal new bone formation, and very importantly, and especially in this case, I think what we did here was we took history a little bit later on, is you want to correlate clinically. Look for teeth. They're common in teeth with large restorations. They are common in endodontically treated teeth. Pain on biting is one of the hallmarks of it. Rebound pain, when the patient bites down and reopens, they get sharp shooting pain. Any history of trauma, and in this particular case, history of bruxism, evidence of wear facets, and a stressful job occupation. A very seasoned endodontist told me that he sees them especially with surgeons and people that work in flight control. So in this case, we have a healthy 35-year-old female patient. The patient is seeking orthodontic treatment to address crowding of the mandibular teeth. Upon examination, the patient has excellent oral hygiene, no caries, no restorations. I think this is a theme with all my patients. We took periapical images that were taken to evaluate the roots of the mandibular central incisors for orthodontic treatment, and upon examination, the teeth were all vital. So if we look at the periapical radiograph over here, so now we want to kind of use this visual algorithm that we talked about. What is the location of this lesion? It is periapical to the anterior teeth. Its periphery is well defined. Non-corticated, internally it looks homogeneously radiolucent, and the teeth over here all look normal. And then now it's going to be really important to look at effects on surrounding structures. So if we look at the periodontal ligament space of these teeth, one of the teeth you can see loss of lamina dura, but on the other tooth it's involved with, you can see normal periodontium and normal lamina dura. This is the only lesion we found in the patient's mouth. Again, to my trained eyes and to my experience, I can tell you right off the bat that this is periapical segmental dysplasia, early stage or a non-mature phase. However, now that we have cone beam CT, we have a lot more information that can help us out with the diagnosis. So if we look at the same area, you have a reconstructed panoramic image and you have some reconstructed cross sections. So if you think about periapical segmental dysplasia, it's considered a fibroosseous lesion. A fibroosseous lesion is with normal bone, is replaced by fibrous tissue and abnormal bone and cementum-like lesions. So what cone beam CT added to this appearance that we saw in the periapical is we're able to identify and confirm these radio-opacities that we couldn't see initially on our periapical lesions. So this is going to confirm, so if you look at these areas here, those are all cementum-like lesions and abnormal bone pattern. So this was diagnosed as periapical segmental dysplasia. What is the take-home message from this? Is periapical segmental dysplasia, so everybody in here knows, is very common, and it's especially common in our part of the world. So you're going to see a lot of these in practice. This isn't something rare. And they can appear as single lesions. We always think of periapical segmental dysplasia as multiple lesions within the anterior teeth in African American women. That, I want to say, it could happen in single teeth, anterior or posterior, and they are very common in Arab populations and in Asian populations as well. They're associated with teeth that are vital. The bone usually shows no evidence of inflammation like we saw before, and PCD is a radiographic diagnosis. We don't take biopsies pathology, I'm sorry, where's pathology? Sorry. But this is a radiographic diagnosis. Why is it a radiographic diagnosis? Because of the poor vasculation, or because of the vasculature of these altered dysplastic tissues and cementum-like calcification, they are at high risk of becoming infected if we introduce anything to these lesions. And that's why whenever we see them, we tell the patient that they have it, so when they see another dentist, they know, and we tell them to take real good care of their teeth so as not to get them infected. So in this case, this was a 62-year-old male patient who takes medications for hypertension. And the patient reports a palatal swelling that first appeared about a month ago. Upon examination, the patient did have history of trauma, very old trauma as a child, to the anterior teeth. And patient had palatal swelling, palatal to tooth number 2-1 and 2-2. Now, if we look at the periapical lesion, if we look at the periapicals and panoramic radiographs, again, the first line in a case like this, we can see that we're going to localize this, there is a large radiolucency in the maxilla that's a bit offset from the midline to the left, particularly at tooth number 2-1 and 2-2. It is very well defined, it is non-corticated and homogeneously radiolucent in the center. Now, effects on surrounding structures are going to be really important. Now, based on the history, I'm already biased right now to think that these are teeth involved in trauma. This is most probably a radiolucency or a cyst that has some kind of inflammatory origin, like a radicular cyst, correct? And if I'm already thinking about that, I'm already biased towards what kind of treatment this is going to have. Depending on who you speak to, with radicular cysts, many times the endodontist will go in, will go in and treat the teeth with or without apical surgery and just wait for it to go away. Now, in this case, what we want to look at is we want to look at this effect of this radiolucent area on surrounding structures. Now, a radicular cyst of inflammatory origins will cause loss of lamina dura and loss of periodontal ligament space. In this case over here, everything looks absolutely fine. So we need to make a diagnosis that makes sense, right? So we're going to think about other options. So in a case like this, cone beam CT is going to be really important to be able to identify a little bit more information about the lesion. So what we see here, we see an axial view and we see reconstructed views, and we can see a round radiolucency that is offsetted off the center, palatal to the teeth. And if we do localization, now we want to reverse here and look at localization. If we look at the nasopalatine canal, you can see that if we were to talk about an epicenter here, the epicenter looks like it started within the nasopalatine canal, which is going to change our diagnosis here completely. And this case, based on its location, is diagnosed as a nasopalatine cyst, which is going to be a complete different treatment than if it were to be a radicular cyst. Now, many people will say, and the reason why this came on my desk, because it was offsetted from the midline, it was on the side. And that's okay for nasopalatine canals. There are variations to the nasopalatine canal being on the side.
5 minutes.
I'm almost done. So the main question I get from practitioners is cyst or foramen? Always asking this kind of question. So whenever they say a radiolucency in the midline, they will ask the question of cyst or nasopalatine foramen that is enlarged. And now with cone beam, we get a lot more information that confuses people even more. So if we were to look at this same case that I just showed right now, the midline, it does seem like we have a small or slightly enlarged area, and then you can see this heart-shaped appearance, which is typical for nasopalatine canals. What I tell my practitioners is go in and measure your nasopalatine canal, measure its depth, measure its height, and measure its width. So in this case, what we're looking at is something that is, I think, sorry, I just have to get this over here. So in this case, what we have is about an 8 by 10 by 7 millimeters, by 7 millimeters of the size. So when we look at nasopalatine canals, the take-home message here is that the diameter of the incisive canal is typically 6 millimeters to 7 millimeters. Now, anytime you see a radiolucency that exceeds this dimension, further investigations are prompted to look for a cyst or not. Now, some of the things that are going to help you, look at clinical correlation, look at the clinical signs and symptoms. If you see palatal swelling, if the patient has pain, then we're also going towards cyst more than just a variation of normal. If the patient is asymptomatic, like most, by the way, nasopalatine canal cysts, 2 things should be done. Either 6-month follow-up scan is recommended, or previous scans of the same area should be used to see if there's any signs of growth. And I'm going to end with a very simple case, but something that I get a lot from practitioners, especially our orthodontists, when we're looking at impacted teeth. So if we're going to look at these 2 radiographs, the question always is cyst or follicle. And why is it important? Because the treatment is going to be drastically different. When we have cysts that are large, they're very easy to diagnose. But now when you're between, where you're in that size where it's not as big as a cyst, but it's almost a hyperplastic follicle, then we have a lot of questions. So in this case, the orthodontist was worried about a cyst on the right maxillary canine, but then as we took, what we did here is we said we're going to stop, wait for 6 months and see if it changes course, and the canine here continued to erupt normally, which means that this is not a cyst, because a cyst will cause pathological change in the eruption sequence of the tooth. So things like this, cyst versus follicle, if you're looking at these 2 images over here, I'll give you a second. Which one is a cyst and which one is a follicle? If we look at on the first radiograph on the very end, that is a hyperplastic follicle because it's causing absolutely no changes to periodontal ligament space and lamina dura. And we look on this side, you can see clearly that is causing tipping and it is causing loss of lamina dura to the affected teeth. So what is the take-home message for this particular case? Is follicle spaces that are greater than 3 millimeters should be investigated for cystic changes. An odontogenic cyst should be considered with any evidence of tooth displacement, with any evidence of expansion, and if uncertainty still remains and you're really not sure on your day-to-day practice, it's okay to wait. Wait for 6 months, or compare with previous images. So in this case over here, the surgeon had taken a periapical radiograph to take a look at their 3rd molar before they extract, and then they weren't sure if this was cyst or just a follicle. We were lucky enough to have the patient on our system, so we went back in time to see their original periapical, and you can see that there's a change within 6 months, which means that this is most probably a cyst. Somebody might ask, so who cares? I'm going to go in and remove this anyway. The issue is, when you're going to remove something that is suspicious of a cyst, you're going to probably have to go in there and clean that area out properly, send it for biopsy, so that we have an idea of what kind of pathology we're dealing with, and to do the appropriate follow-up. If it is a keratocyst, then the patient has to come annually to make sure there's no recurrence. And thank you very much. And I hope some of these cases will help you in your day-to-day practice and some of the common things that come through and some of the common dilemmas that come through. If anybody has any questions, I guess the floor is open to any questions.
Anyone has a question? Anyone with a question?
Thank you so much, Doctora.
You're welcome.
If you have one patient with a lot of symptoms, do you advise to take CBCT immediately and periapical instead of going through the OPG and all of these radiological and exposure for the patient into radiation?
That's a great question. So we get this question a lot about, should I go straight to cone beam CT before doing our classic imaging? And I always say, go with your classic imaging first. The reason is, a periapical radiograph, especially in localized changes, will probably give you more information than a cone beam CT. If you have access to a small field cone beam CT that has high definition, then you could consider that. But in day-to-day practice, periapicals will give you a lot of information. Specifically, it has higher resolution to things like pulp changes and periodontal ligament space. So start with that. If you can answer your question through that first, then you can go on to cone beam. Now, in some of the cases like we saw over here, they have, the causes are we don't know what the cause is, things are not very clear, then you could go directly to cone beam CT. In these cases that I showed here, a lot of them had started out traditionally, and when they couldn't find any causes, they kept going and did cone beam CT. But I would say start with your traditional imaging and then move on to advanced imaging.
Another thing,
Yes.
do you recommend taking an OPG as a routine baseline for most of the patients? Since we find these some incidental finding.
I love that question. Do we take panoramic radiographs as baseline for every patient? So if we go to the ADA guidelines for imaging, there's nothing called screening in radiographic imaging. The only screening we have in dentistry is actually bite wing radiographs. Now, panoramic radiographs should be done when needed and shouldn't be done sort of routinely. Now, taking a panoramic radiograph just to make sure there isn't anything funny going on isn't always a good reason to take a panoramic radiograph. Taking a panoramic radiograph should be based on patient's need. So if this is a patient that you're going to be treating, you're going to be doing any kind of intervention, then definitely go with a panoramic radiograph and you'll be able to see everything together. But if somebody's coming in with absolutely no changes and doesn't really need any treatment, then panoramic radiographs are less likely to add anything. So we have to remember that we're dealing with very small tissues, so maxilla and the mandible, and patients become symptomatic pretty quickly, whether that's pain, whether that's swelling. So once you have symptoms, once you see something, then panoramic radiographs are warranted. But again, you always have to ask for a pan when you have multiple things, not just, I just want to see what's going on here. It doesn't make a lot of sense. I know that's a long answer to a simple question, but I would eliminate routine panoramic radiographs and take it based on the whole scenario or the whole problem with the patient. Yeah. You're welcome. And definitely one thing to say is whenever you can do small field cone beam CT, go for small field cone beam CT at every turn, especially when you're looking at localized things, for two reasons. Number one, it's small field cone beam CT increases diagnostic accuracy by leaps and bounds because of the higher resolution of small cone beam CT, small fields of view, versus large field of view won't give you the resolution that you need for dental issues. So always go small field whenever you can.
Thank you, Dr. Mariam Baghdadi. We always enjoy your lecture.
Thank you very
So
much.
now with the honor of Dr. Mariam Baghdadi.
Thank you. Thank you, دكتور. مشكور ما قصرت. وفي صورة في الموضوع؟ Thank you. Thank you very much.
Thank you.
Thank you.
Good morning, everyone. It's my great pleasure to welcome you all today for the restorative and aesthetic session. For those who don't know me, I'm Dr. Noor Al-Gabandi, who I'm honored to lead this session alongside with Dr. Fatma Murad. It's my great pleasure to introduce my fellow Bostonian, Dr. Ahmed Al-Anizi, who is a prosthodontist, graduated from Mohammed bin Rashid University in Dubai. Then he pursued an implant residency program at Harvard of Dental Medicine. In 2022, he was awarded membership in prosthodontics by the Royal College of Surgeons of England, Dr. Al-Anizi. He's also a visiting faculty member at the University of West Indies, where he teaches implant prosthodontics, and also serves as a faculty at the Harvard Macy Institute. His passion lies in digital implantology, prosthodontics, and dental education. Today, Dr. Al-Anizi will be speaking about restoring smiles, implant approaches from aesthetic single tooth replacement to edentulous arch. Please join me in welcoming Dr. Al-Anizi.
Thank you. Thank you, Noor, for the introduction, and thank you for coming here today to listen to the presentation. I hope I can make your time worthwhile. Today's presentation is going to be about restoring smiles, and we are going to discuss different treatment approaches from aesthetic single tooth replacement to a full arch treatment. The objectives of today's lecture is discussing the different treatment protocols or strategies we implement in implant dentistry. And because all of these cases are going to be taking part with the digital workflow, I will talk about the digital workflow and a brief description about it so you can have an idea on how we implement this technology into our cases. So we're going to discuss two cases in the aesthetic area and two cases in advanced prosthodontics. And then we'll take a look at the aesthetic consideration that is necessary to implement when we are treating a case in the aesthetic zone, and go with you through the thought process that usually takes place, and share some of the clinical findings and techniques and limitations. In order to understand today's lecture, first we need to define what is the digital workflow and what is the impact of this technology. The digital workflow can be easily classified into 5 stages, which is the comprehensive evaluation, the data acquisition stage, the virtual planning stage, the CAD/CAM stage, and the guided surgery stage. And the first stage, you want to establish a good communication with your patient and really understand whether this patient is a candidate for dental implantology or not. You want to understand the patient chief complaint. You want to assess the patient dentition as well as the periodontal health and have a good occlusal analysis of the pre-existing condition and really just know if this patient is a candidate for dental implantology. Then once you have this out of the way, you can move into the data acquisition stage where you are going to collect data that will help you to digitize your patient. And the best way to do it is by intraoral scan, which is an optical impression of the pre-existing condition or oral cavity, a CBCT which will serve you as a 3D reconstruction of the patient hard tissue, a photograph, a 2D photograph, or a facial scan. Now the photograph or the facial scan will help you to generate a facially driven treatment plan, but which technique you should use, they both have been very reliable. Then you can move to the third stage, which is the virtual planning stage, and it is the stage that you spend most of your time in. You'll collect or you use all the data that you collected from the data acquisition stage, and you will strategically start placing your implant. Your implant should be ideally placed in a screw-retained fashion, prosthetically driven, and that's what you aim to do in that stage. You also will be able to select your implant height, width. You will be able to select your abutment, and you will be able to fabricate or generate your surgical guide. And once you fabricate your surgical guide, you can move into the CAD/CAM stage, and you can print this surgical guide or mill it. Nowadays, printing have been very reliable and very accurate, so we are mainly relying on the printing. Then you move to the guided stage where you take your surgical guide, and with a specific set of instrumentation, you will be executing your plan. This instrumentation is dedicated to each implant system, so each implant system has its own instrumentation. I showed you this because the next 4 cases we are going to discuss, they are going to, these 5 stages will be implemented in all of them. Now, this is the first patient of the day. He came to the clinic with an aesthetic concern, and he's missing tooth number 9, as well as we know that the patient is having high smile line. So from the get-go, we know this patient is a patient with high aesthetic demand and is an aesthetic case. And nowadays, implants have been very reliable and very good biologically and mechanically. But in the clinic, we often find a lot of aesthetic complication. And the reason for these complications is because either the restorative dentist or the surgeon did not implement a special consideration. And we'll talk about these considerations. So what are these aesthetic considerations that we need to implement in those cases? One of the first important consideration is the peri-implant soft tissue, which is basically the tissue that surrounds your dental implant. Ideally, you want this tissue to be disease-free, and if it's adequate, you need to have it. You need to know how to preserve it. If it's not adequate, you need to know how to create it. And this tissue needs to be adequate not only on the buccal or lingual aspect, but also on the vertical aspect. Second is you should always aim to start with the end of mind. So your restorative design is extremely important. Knowing what type of material you are going to use is also very important, and whether if you have enough restorative space for it or not. Knowing your proper 3D position and the virtual planning phase is also extremely crucial when you are planning cases, especially in the aesthetic zone. So ideally, you should aim to be screw retained and prosthetically driven to eliminate any aesthetic complication. Knowing your abutment selection, design, and high temp material is also very important. There are hundreds of abutments, and each abutment has its own indication. So you should be able to identify which abutment you are going to use for this case prior to the implant placement. Implant timing and implant pulverization is also extremely important. We have seen nowadays that the implant, when we place an implant in an immediate fashion, and we temporize this implant, we are most likely preserving the soft tissue architecture as well as the hard tissue. However, if we don't do that, if we make this case go into a delayed approach and extract the teeth and make it heal for a while, we tend to get a resorption or shrinkage not only in the vertical axis, but also in the horizontal axis. And this resorption will complicate your treatment and will jeopardize your aesthetic results. Your emergence profile is also very important. Ideally, your emergence profile should be within 30 degrees. Why? Because you want to prevent the food accumulation around your emergence profile. And if you have food accumulated underneath your emergence profile, you will develop perimucositis and then periimplantitis. Then you might run into marginal bone loss around your dental implant and maybe have a failure of your implant. And this is a histological and micro-CT analysis. And what they did in this study, they compared 2 types of abutment. One is a narrow abutment and the other is a wide abutment. So in the narrow abutment, they found out that the peri-implant biological width was not affected as much as when they compared to the wide abutment. So this is just to support that we should aim to have our emergence profile within 30 degree angle. So let's go back to the patient. This is our patient. And as you can see, this patient is having multiple of findings. So he has a deficient metal ceramic crown, and he has a fractured tooth number 9. He has tooth wear, diastema, and a deep bite. So we had a thorough discussion with the patient, and we told him, in order for us to replace tooth number 9 and 8, we have to put 2 dental implants. But in order for us to close the diastema, we need to have a laminate veneer on the laterals, which is 7 and 10. And the patient agreed to the treatment plan. We also told the patient, we will not be able to give you a provisional restoration, and the reason for that is because we wanted to protect our implant during the healing phase and give our implant enough time to osseointegrate. And the patient agreed to the treatment plan, but we told him, In order for us to preserve the soft and hard tissue, we will do something called sealing socket abutment or customized abutment or socket seal abutment. And the reason why we want to fabricate this abutment is to preserve the marginal tissue architecture as well as seal our extraction socket during the healing. And because we are going for an implant therapy, we should always start with the end of mind. So this is the wax up generated from a baseline situation. After acquiring our wax up, we move into making or placing our implant. So here our implant was strategically placed. We aimed for a 3 to 5 millimeter of apical engagement to ensure high insertion torque during our implant placement. We also aimed for at least 3 millimeter of a buccal gap to ensure that we were able to put our bone particulate in that location. And we made sure that our implant is about 4 millimeter in depth. And the reason we did that because we want to create enough space for our biological width to be there and supracrystal attachment. Then after finalizing our implant position, we were able to generate our surgical guide. And we bring the patient on the day of the surgery, and we proceed with atraumatic extraction. We make sure that the buccal plate is intact, and we make sure that the surgical guide is fully seating. We place the implant in a fully guided fashion. Then we proceed with fabricating our socket seal abutment. Then we remove the socket seal abutment. We put our xenograft, and then we put back our socket seal abutment. Patient comes after 3 months with a good preservation of the soft tissue architecture that we were able to achieve because we created the socket seal abutment. We take a digital final impression, and then we proceed with the fabrication of the prosthesis. Our prosthesis was a screw retained for 8 and 9 and laminate veneer on 7 and 10. We made our screw retained restoration over a custom abutment. And the reason why we did that, because we wanted to control the emergence profile, and we wanted to implement an EBC concept that was described by Gomez-Meda in 2021, which he identified the emergence profile into 3 stages: the critical zone, the biological zone, and the aesthetic zone. So the critical zone, mainly you want it to be as narrow as possible so you don't exert a lot of pressure on the marginal bone around your dental implant. The biological zone is the zone that will support your soft tissue for your emergence profile, and the aesthetic zone is a zone that you will have it with the junction of your proposed gingival margin. These 3 geometry will create for you a reverse S-curve that will promote your restoration to be biologic and aesthetic pleasing. This is the soft tissue on the day of insertion, and we try in our restoration. We place it and torque it up to the manufacturer recommendation. And in order to be successful here, in order to protect our implant, we should eliminate all the premature contacts, not only in the protrusive aspect, but also in the latrusive aspect. And here is our implants torqued and laminate veneer cemented. We take a PA to find out that our implants have been fully seated, as well as we take 1 year post-op of implant placement, and we see that we were able to execute the same plan that we had in the real life. This was the initial situation of the patient, and this is the final result. And this final result was aesthetic, was biological, was harmonious and functional. And we wouldn't be able to do this kind of treatment without implementing the 6 factors that I told you in the beginning of the lecture. So now let's jump to another case where instead of preserving the amount of the soft tissue, what we had to do here is we had to create the peri-implant soft tissue. And this is a patient comes to the clinic with a high smile line and high aesthetic demand with an anterior implant. So we take a look at the restorative space, and the patient restorative space is adequate both in the on the vertical and horizontal axis. We take a look at the soft tissue status, and we found out that the patient gingival the keratinized gingiva is both adequate, both in height and width. Adjacent papilla is present, and the mucogingival line is away from implant site, and there is no vertical deficiency. But when you take a look at the horizontal view, we see that we have a lot of deficiency on the horizontal aspect. And in order for us to be functional, to be aesthetic and biological, we need to correct this deficiency. And we need to correct it with either guided bone regeneration or soft tissue augmentation. Now, which technique you are going to implement, this can be answered in the virtual planning phase. So we take the patient data, the intraoral scan, the cone beam CT, and we put them in implant planning software. Then we generate a wax-up for the patient. So we should always start with the end of mind. We start with the crown first before we even finalize our implant location. So this was the wax-up, and then we take we try to place our implant in respect to that wax-up, and we were able to place our implant in a screw-retained fashion, and our implant was fully embedded in bone. So in this case, we don't need to go for guided bone regeneration to correct this deficiency. We can go with soft tissue management. And this is the provisional restoration design. Additionally, in this case, we wanted to push digital dentistry a little bit further, and we wanted to do a new approach where we design and print and cement our printed crown prior to the implant surgery, and then place our implant. This is technique sensitive and requires a high level of accuracy, and the technique we implemented was static computer assisted implant placement. But in order to really finalize our implant position, in order to finalize the crown, what we had to do is we had to integrate two different softwares. So here I integrated the implant planning software with the CAD software with each other. So if I move the implant, it will show in the real life in my CAD software. If I make any changes in my CAD software, it will show in my implant. This will allow me to choose the best optimum position for my implant, and also will allow me to create the best emergence profile and to make the best crown for this patient. And that way, we will be able to deliver the restoration on the day of the surgery. So we designed and fabricated the surgical guide, and we also designed and fabricated our provisional restoration prior to the implant placement. So this is the patient, comes on the day of the surgery. You should always inspect your inspection window. These windows are made to make sure that your surgical guide is fully seated. If my surgical guide was not fully seated, I will not be able to execute my plan as I planned it. And here we do a mid-crystal incision, and the reason why we did that, because it's the least vascular area, and because it minimizes the amount of inflammation that we usually have on the healing phase. Then we implement a fully guided protocol for our implant placement, and here the surgical protocol is a protocol that you can print in your implant planning phase, but this protocol is not ideal. It depends on your experience, because sometimes when you are drilling your osteotomy, you find out that the bone is weak, so you don't have to go all the way to the last drill. You can skip the last drill. So it requires a little bit of knowledge and a little bit of experience. Implant was chosen, and implant was placed through our predetermined surgical sleeve, and implant placement was controlled. The control was not only in the vertical aspect, but also on the rotational aspect. Any changes on my rotational aspect will prevent my prefabricated crown from searing that day. And this is the implant, and was placed in a fully guided implant placement fashion. Now we tried the crown, and we were able to achieve implant insertion without any modification in that case. So now look at the occlusal view of the day of the surgery, and look at the occlusal view on the virtual planning stage. Look how identical they are to each other. And this is a proof that digital technology can really help you to implement advanced techniques, and also help your patient to get good results. Then we started with a free gingival graft from the palate. The free gingival graft size was corresponding to the recipient site, but about 20 to 30 degrees larger. This is our free gingival graft harvest, and then we proceeded with our CTG bed preparation. After that, we de-epithelize our free gingival graft. We secured it on the buccal aspect of the implant, and we had a slight over adjustment that will be compensated during the healing phase. And we achieve hemostasis here with compression suture, Gore-Tex suture, collagen tape. Now I want you to take a look, special look on the mesial papilla here, and take a look at the mesial papilla 3 weeks after the surgery. We were able to achieve a new gingival height. We were able to achieve a new papilla heights, not because of my surgical skills, but because we created the right environment for it and because we trusted the biology. Final impression was taken 3 months after, and a screw-retained zirconia restoration was made over a tie base. The same tie base we used for our provisional restoration was used in the final restoration. And this was the initial situation, and this is the day of the insertion when we tried our restoration. We had no blanching because our emergence profile was controlled, and we did not even need to numb the patient. And a PA to confirm everything is on point. And look at the before after of the soft tissue continuity, and look how we were able to achieve good correction with only soft tissue augmentation and the restoration. So this was the baseline, and this is the final results, and the final result was aesthetic, biological, and functional. And we wouldn't be able to achieve this result without implementing all these 6 factors. Now we're going to move to the second part of the presentation. So now we're going to discuss now how this technology is going to help us in advanced rehabilitation, a full mouth rehabilitation. So this is our patient, and this is an FP1 case. And for those of you who do not know what's an FP1, FP2, and FP3 is the type of the prosthetic fixed restoration that you will have, that you will deliver to the patient. So if your final fixed retained prosthetic prosthesis was only teeth, this is called an FP1. If it's teeth and a little bit of gum, this is called an FP2. If it's teeth and a little bit of gum and bone, which will be categorized with the pink ceramic, this will be an FP3. So this patient comes to the clinic with a special medical history, tracheomalacia. The patient is having difficulty breathing, and he's having difficulty clearing the mucus when he swallows it. He had previously dentures, and those dentures created a lot of respiratory illnesses as well as developed some pneumonia. So we know that now complete denture is a contraindicated or relative contraindication in this case. So we take a look at the facial profile to assess the ridge display and how much ridge is he showing when he's smiling. These are important photographs that will help you throughout your diagnosis. This is the frontal view. Obviously, the patient is edentulous on the upper and lower arch. The patient has a large tongue because that will impair or affect your complete denture, and he has high muscle attachment. We take a look at the occlusal view. It's a well-developed arch. It's an oval arch shape, and the reason why I emphasize an oval arch shape because the shape of the arch will determine for you the implant location or the implant distribution. Oval shape arch is different than square shape arch, is different than a narrow arch. And we have a good band of keratinized tissue. Why is this important? Because the band of keratinized tissue will tell you if you are going to move the flapped approach or a flapless approach. This is the lower arch. We have high muscle attachment, and we have a deficiency in the keratinized tissue on the anterior aspect of the mandible. This deficiency is telling us that we will not proceed with this case with a flapless approach. Treatment options were given to the patient, and the patient chose implant-supported fixed prosthesis. And because the patient chose implant-supported fixed prosthesis, we should start with the restorative design first. And here we fabricated for him a diagnostic denture. We tried the denture in the patient mouth, and we then we did a facial analysis of the denture. Now we can see that incisal plane line is parallel to the interappropriate line, and the midline of the denture is in the center of the face, so we are happy with this wax-up to move forward. In this case, I did another set of denture, which is a flangelless denture, and the reason for that is because I wanted to confirm if this case is an FP1 or an FP2. Now, we tried the flangelless approach, the flangelless denture, and we found out he has enough lip support, so we don't need to generate lip support with the flanges in this case. And the teeth display are good, and the buccal corridor is also on point. So we are happy on how this denture looks like, and that's how we can, and then we move to the dual scan protocol. This dual scan protocol is basically, you take the denture and you put fiducial markers on this denture. Those fiducial markers will help you through your advanced imaging to make this denture clear or visible. And the way, those fiducial markers are usually radio-opaque, and the denture is usually radiolucent. That's why we need them. Then we take two sets of scan. One scan is the patient wearing the denture with the fiducial markers, and one scan without the fiducial markers. And we take those two data together and superimpose them in the implant planning software, as you can see here. Then we will be able to visualize and have a good idea on the restorative design that we created, and also in regards to the 3D construction of the hard tissue. Once we have done that, we can move into the virtual planning phase. This is the initial situation in the virtual planning phase. And this is the approved denture that we saw earlier. And this is the proposed teeth setup that we are going to use for our temporary restorations.
Sorry for the interruption, doctor. Just 5 minutes remaining.
Okay. So this is the implant planning. I'm going to skip that. We basically use a BLC implant, and we have 8 in the maxilla, 6 in the mandible. And we move to the virtual mock-up, and we made sure that our virtual mock-up is also on point. This is the implant planning. Our implant planning here was facially driven and prosthetically driven, and we chose here an FP1 with 4 segmented approaches. This is how everything is looking through the virtual world, and we were able to select our abutment prior to the implant surgery to eliminate any guesswork. Our implants are placed in the ideal position. Our virtual abutments are also selected. Here we did a sequential guide, and these sequential guides are basically your complete denture. You place them in the patient mouth, and and it's called a fixation pin guide. This fixation pin guide is responsible for you to place the fixation pin, the pins you see on the top, the blue ones. Then you remove your complete denture, then you do the drill guide, then you remove the drill guide, and then you place your guided prosthetic. And we'll show you right now on the day of the surgery. So this is the patient. We make sure that the guides are fully seating, and he's occluding in the same way he was occluding on the complete denture. We make sure that the fixation pins are placed in a special way, left and right, and then middle. You don't want to go from one side to other because you might introduce a lot of inaccuracy. Those are our fixation pins. Usually they are difficult when you go for a flapless approach because the mucosa will prevent those fixation pins from sealing. And we implement a fully digital workflow. Our implants are placed through the drill guide in a fully guided fashion and picked up picked up with the pickup material, then cleaned, and this is the patient on the day of the surgery. We move to the lower arch, and the same thing happens in the lower arch. However, it's more like a flapped approach. We put our multi-unit abutment, then we put our temp cylinders. We place our guided prosthetic. Then we pick up our guided prosthetic, and then we clean it up, and we place it on the patient mouth, and this is how the patient looks on the day of surgery. We bring the patient a couple of months after to make a new set of restorations, and we take a final impression using SRA level impression. We design the new prosthesis. And this was the patient before, this is the patient after, and this is the patient with the OPG. And we were happy with the result. Also, the patient was happy with the result. He was FP1 in the maxilla and FP2 in the mandible. So this case, I'm gonna be really quick on it. This is a different case. Instead of sequential guide, what we did here, we did a stackable approach guide. Okay, what we had to do is we have to fabricate a fixation pin guide, then a bone reduction guide, and then a drill guide, and then guided prosthetic. So it's additional extra guide that will help us throughout the surgery. And this is in the mandible, and this was the initial situation of the patient. This is the approved prosthesis that we generated in the virtual planning phase, and this is the surgical guides created in that fashion. So the patient comes, we make sure that the surgical guide are fully seated, and we opted here to do with the piezo-assisted alveoplasty. We placed our implant in a fully guided fashion as well, and we put our SRAs, and we pick up our guided prosthetic. This is the lower arch. We do the same thing. We open a flap, and we respect the anatomical landmarks and the vital structures. We place our base guide, and this base guide will help us to determine the amount of bone reduction that we are going to have. It also will help us to stack everything on top of it. And then we put our drill guide, we place our implants through that way, and we put our SRAs, we put our temporary cylinders, and we put our guided prosthetic, we pick up the material, and then we clean it up, we let the patient heal, then we deliver it to the patient. So the patient was delivered this prosthesis on the day of the surgery, and this is how the patient looked like on the day of the surgery, and this is after a couple of months. On that day of the surgery, we also implemented a reverse scan body protocol, where it's a relative new technology, but we don't have time to discuss it now, and a new set of privilegization was implemented. It was aesthetic and it was hygienic, because we wanted to eliminate any food impaction underneath your prosthesis. And we made sure that verification jig was on point. And this is the patient final restoration. And this is how the patient came in, and this is how the patient left with. That was the initial situation, and that was the final results. With that, I'd like to thank you so much for your attention, and thank you for your patience. And if you have any questions, please do not hesitate to ask me. I'd also like to thank all these people in this forum, some of them you know, and thank you very much.
Thank you very much, Dr. Lanazi, for your presentation. We all thoroughly enjoyed it. This is the time to ask any questions for the audience.
Well done on the enlightening presentation.
Thank you.
For the last two cases, you did all in X's. Did you face any troubleshooting during those surgeries? And how did you overcome them?
Yeah, this surgery usually are, they're not seamless as we see. Actually, we often find a lot of problems that arise during the implant surgery. Some of them I can recall from the first case was the guided prosthetic was not fully seating. Why? Because when we do the planning, yes, it's accurate, but it has a little bit of inaccuracy. So I was not able to insert the guided prosthetic easily, and I had to, press on it a little bit harder, and you run into a risk of fracturing your prosthetic on the day of the surgery. I hate actually placing the fixation pins when we have without a flapped approach, because those fixation pins sometimes you wonder where is this hole that you drilled, or where is the osteotomy. So that's why I plan for 5 fixation pins. So if I don't find one, I can rely on the other 4. And these are the main 2 things I can think of to answer your question.
Yes, I'm aware. sorry, yeah, I'm aware it's very technique sensitive, so whoever is interested in doing this, I highly recommend going through these kind of courses in order to overcome
Of course.
one of those challenges. Any other questions?
Thank you very much. Again, this is just a small gesture of our appreciation from
Thank you.
CBA for your participation today.
Thank you very much. So,
Up next, it is my honor to introduce our next lecturer, Dr. Samir Karimov, who will be presenting the art of anterior composite restoration. Dr. Karimov graduated from Azerbaijan Medical University School of Dentistry in 2005 and went on to complete an internship in restorative dentistry at the Medical University of Novosibirsk. Currently, he practices privately in Baku, where he specializes in aesthetic composite restorations and veneers. Dr. Karimov is also an accomplished lecturer, having presented internationally and led hands-on courses, with his cases featured in peer-reviewed journals. Outside of dentistry, he enjoys dental photography and spending quality time with his family.
it is orange. Yeah.
Okay, Assalamu alaikum, dear colleagues. I'm from Baku, Azerbaijan. My name is Samir Karimov. So before to start my presentation, I would like to express my deepest gratitude, Kuwait Dental Association for kind invitation. So before to start, I would like to share with you a small video about my country. Our country is located in Caucasus, near the Caspian Sea. And I myself from Baku, the capital. And I graduated Azerbaijan Medical University in 2005. And then I passed my internship in Novosibirsk, Russia. Then I continue my practice in Baku. In 2017, I started to work the German company, President Dental, almost 8 years. And they are organizing the course all around the world, especially about aesthetic restoration in anterior and posterior. And then recently we started with our team the courses about full mouth rehabilitation, especially the patient that they have a problem with the TMG, with the full digital workflow. And it's our team. It's like 4 doctors and 1 dental technician. And we started this project, Midpoint. It's all about the full mouth rehabilitation. So today's lecture is the art of anterior composite restoration. Actually, it's a big lecture, but I'm trying to be very, make it very fast because there are a lot of information that I want to share with you. But before to start this, I would like to give some information about the dental photography, because the dental photography is very, very important in our routine work. I can tell that now, currently, I cannot imagine dentistry without dental photography. And I started dental photography almost 12 years ago. I just want to share with you some of my practice and some tips and tricks. So where we're using the dental photography for documentation of the cases, for communication with the patient and also the lab. Also, we can use dental photography for the planning, for the publication, and also for the examination of the patient. The equipment, it's very important. When I started 12 years ago, I just used crop camera, Canon 6D, and 100 millimeter macro camera and the ring flash. Now I'm using the more professional cameras in my daily practice. Actually, in my course, I'm not, telling the doctors to use this kind of professional devices. Even the crop camera is enough. Just you need the flash and also, bouncers, light modifiers. So also I'm using the Canon 100 millimeter macro camera, Tokina, and Nikon 105 millimeter macro lens. Sorry. Also, we're using of course, the flashes is very important for us, the twin flash, and also the ring flash. The light modifiers, it's very important because in the photography, the light is playing a very big role. That's why we're using the bouncers if we want to do some close-up or intraoral photography. For the portrait photography, I'm using the soft boxes. The dental photography we're using in the dentistry for intraoral, close-up, portrait, laboratory. So if you want, you can do the artistic photography, cross-polarization and super macro photography. So the setting is really important, and I would like to share with you that with this setting, actually you can get easily all the photos. So we're not changing the ISO and the shutter speed, 125, sRGB, and white balance 5500. You're only changing the F. With the portrait photography, we're using the F10, F11. For close-up, F14, F18. Intraoral laboratory photography, more higher number of the F, like F22, F32, and for cross-polarization, F32 and 45. And now I'd like to share with you some of my photos. This is for intraoral photography. The intraoral photography is really important for us because in this photo we can see that a lot of details, like in anterior teeth we can see that the primary, secondary, and tertiary anatomy, all the parenchymata. And also, if you have patient have the wear in the incisal ledge, you can analyze the situation. Close-up photography also, of course, here the lips also playing role. Let's say this patient's like class 2 patient, we can analyze the gum level, if the patient have some gummy smile or not. And also, of course, we can do the smile design. Also, you can analyze the caries lesion. Later, I will show you this case, the big caries lesion in the patient and after the restoration. Also, we can analyze the rest position, that how much the teeth is exposed, like in here, in anterior. Like here, you can see the 3 millimeter central incisor. And then here, it's not visible. And when we're doing the total rehabilitation, we're doing the digital smile design. So for portrait photography, also important for us. For orthodontic, the orthodontist can use this one, and also we are using to do the smile design. Also, when we want to do some analyzing, the aesthetic analyzing, we're using the portrait photography. We can use also the laboratory photography. Most of the time, my dental technician taking the photo after the restoration, the ceramic restoration. And you can see the incisal effects and opalescence effects. So artistic photography, because when I just started the dental photography many years ago, for me it was so interesting, and I took many artistic photos. This photo actually won the first place in the international contest, This the incisal, the extracted central incisors, and I prepped all the inside of the tooth, and I left only the enamel. And with 2 polarized filter, I took this photo, and you can see all the enamel prism. And this photo I took while the tooth is touching the water. And I use 4, 2 in front and 2 the background, 2 continuous light. Also, you can use this kind of like artistic photography in the edge-to-edge position. This is the after cementation, the feldspathic veneers. This is extracted central incisor, and you can see the wear in the incisal edge. This is also veneers before cementation. Also, you can do some cross-polarization photos. So actually, it's really difficult to prepare the slice, and it's like a 0.5, 0.3 millimeter the slice. This is molar, and using polarized filter, and you can see enamel prism, the different color of the enamel prism. This is a premolar. Also, many years ago, I started super macro photography. It's not easy to do this photography. I need special devices, and I'm using the macro stacking, and I'm just taking a lot of photos, and I just stack it to get one photo. So here the device I'm using a professional camera Nikon, and stack shot device is automatic rail. So you can see this is the lateral, the palatal part of the central incisors. Here, to get this kind of photo, I took, I don't know, 300 or maybe more photos, to stack to get one the photo. In this photo, I use 465 photos, and I just stack it to get one photo. This is extracted the teeth. This is also premolar. This is the molar with the burr. And you can see all the diamond in the surface of the burr. This is the Ultra Pack retraction cord. This is the implant. It is Straumann. And you can see the magnification. I think the 10x maybe. Of course, it's a big the topic, but I just want to share with you some of my photos because I want to talk more about the anterior aesthetic restoration. So first, I just want to share with you the primary, secondary, and tertiary anatomy, what we have to notice. So this one, it's Ubassi, they're the very famous dental technician from France, Gerald Ubassi, and he made a lot of wax teeth and imitating the natural teeth. And I have this set of Ubassi, and I took a lot of photos, the centrals and the molars. This is the wax that made the tooth. And here I would like to share some of very important, let's say, elements of central incisors. So first, we have to analyze the primary anatomy. The primary anatomy is very, very important for us. So first, we know that the tooth have the 3/3, okay? The cervical third. So here also I'm just showing you the cervical third. So the tooth is not straight, okay? It's like there are some inclination. So the middle third. So when we're doing the restoration, we have to notice all these moments. the middle third more straight, and the incisional third, 15-degree inclination. Then we have the mesolabial ridge and distal labial ridge. So here, the mesolabial and the distal labial ridge. And we have to know that the tools have reflected area and shadow area, okay? The reflected area and shadow area, the line angles separating all this area. And if the line angles very far away from each other, then tools will look like more wide. If the line angles very close to each other, the tools will look like more narrow. So there also you can see the shadow area. Also we have the mesial angle and distal angle. Mesial angle most times more sharp, and distal angle more oval. And also we have an incisal embrasure. So this is the primary anatomy. Okay, this is the primary anatomy. It's very important for us. And without primary anatomy, we cannot imagine the centrals. Then we have this vertical groove. It's like a V shape. Here you can see the vertical grooves here. And cervical groove. This is the secondary anatomy. And we have the parenchyma as the tertiary anatomy. Here you can see the parenchyma of the surface of the tooth. Now I would like to share with you some clinical cases. Let's start. This is the class 4 restoration. This is a traumatic fracture. This is the intraoral view. And then we're going to prepare the silicone key. So we did here the direct mock-up and prepare the silicone key. Then we did the preparation. It's a beveling. The beveling should be at least in the frontal area, the buccal surface, at least 1.5 millimeter, and the palatal 1 millimeter, at least. It's an important moment, and many times the doctors, they're doing this mistake, because when we're doing the beveling, the dentin should cover 2/3 of the bevel. And then we can cover with the enamel. Many times we can face some lines in between the tooth and composite. That's why you have to notice this moment. Then we're doing the etching, the bonding. Then we okay.
This is an alarming test from the hall. It was expected. So hopefully that's ends soon.
Can I continue? So we build up the palatal wall, and then we're adding the dentin and enamel, and then we're starting to do the contouring. Later I will show you more cases about the contouring. This is the immediate post-op, and in immediate post-op you can see this line. This is the normal, because the tooth is dehydrated. That's why it's visible. And the color, the composite, should be a little bit darker than the tooth color, because tooth become dehydrated. So that's why we have to wait. This is the, again, immediate post-op. And this is the after 5 days. So all this line is almost invisible. This case also very interesting. This is also patient, the traumatic fracture. And I analyzed, I did the intraoral photography, and I did the composite button technique. I'm using this technique a lot of times because this is the one of the important techniques to do the shade selection. And also I am doing the shade tops technique. This is a different technique. And so after doing the shade selection, I'm doing the direct mock-up in order to take, to prepare this guide. This is the after preparation. You can see the rubber dome isolation. I build up the palatal wall. We have to use more transparent material. Then we're creating the mamelons. You can give some effect if you want to do some opalescence effect. You can add some white color if you want, and you can cover with the enamel. Then we're doing the contouring with a pencil. We're drawing the line. This is the after the finishing the case. This is immediate post-op. This is after 5 days. This is also, you can see all the parenchyma out of the surface. There's a different view. The photo with polarized filter. And you can see here the incisal translucency. This is the patient after the restoration. Also, because this patient came to me before endodontic treatment, and our colleagues, Dr. Karim, he did the ortho, and you can see with the braces, the photo with the braces. 15 months recall, almost nothing changed. This is before and after. This is 4 years recall, and you can see somewhere in the adjacent tools, but this tooth is it's like almost nothing happening. And this is the patient after 4 years. The next case, multiple lesion, caries lesion, the centrals. This is the close-up photography. The rubber dam isolation. So we did the preparation. Then we're using the matrix in order to build up the interproximal wall. Then this is the final result. This is the before, this is the after, and this is the result. And then next case, also trimetric fracture. This is two centrals. These tooth, actually, because of the trimetric fracture, the pulp is exposed, so I sent the patient to the endodontist, and this is after endodontic treatment. So then we're doing the preparation, beveling, isolation. This is etching. Here I use transparent matrix, and I build up the palatal wall. This is the dentin, enamel. Then using the occlusal paper, I just create the texture. So always use a pencil. This is really important. This is the polishing. This is the final result. So before and after. This is also the next patient with bad hygiene. And you can see many caries, the class 4, class 4, class 3, class 3. And this is the after restoration. This is the before and after. So now I'd like to share with you some discoloration cases. Actually, I'm doing most of the time. In normal cases, I'm using bilinear technique. So I'm using the dentin and enamel. In discoloration cases, we're using also the masking layer. It's like 3 laminar technique. I would like to share with you some the cases. This patient also, this is tooth. It's like we call it Russian red tooth. Okay, this is the tooth endodontically treated, and also you can see we have to correct the midline. So first, I'm doing the shade selection. I'm just opening the midline and adding the material. So I need this in order to take in pressure from the palatal part. So I'm polishing the palatal part. I'm taking the pressure, preparing the guide. Then I'm doing the preparation. At least you have to remove 1 millimeter from the buccal surface. This also carries in the adjacent tools, the mesial part, the etching, bonding, and then we build up the palatal wall. Then we have to use the masking layer in order to cover this discoloration. Then we're adding the dentin, adding some effects, covering with the enamel. Then we're doing the contouring. And this is the final result. This is before and after. This is a close-up view. Also, the next case, also the discoloration, the centrals, after end of treatment. Isolation with rubber dam. So we prepare the guide. Here I use the second guide in order to check the thickness of the enamel, how much I have to add. So you can see I remove 1 millimeter from the buccal surface. This is a preparation. The sandblasting, most of the time I'm using the 27 or 29 micron of aluminum oxide. Etching, bonding. So we're using the adaptive layer, we're creating the palatal wall. This is the interproximal wall. And we're adding the dentin. Okay, we're covering the discoloration with the masking layer, and this is the after restoration, this is immediate post-op. We're doing the contouring also. The polishing. This is the immediate post-op. This is after 8 days. This is before and after. So this is also a very interesting case, a posterior open bite. This is the before orthodontic treatment. Again, here also Dr. Karim, it's like did ortho, and this is the after orthodontic treatment. But the problem is, in these tools, have a big, very big, the composite material, the film material in the palatal surface, and very thin enamel. You can see that the color is very dark. Also class 4 defect in the tooth number 11. So we're doing the preparation. I just left only enamel in this part. Etching. So we're using the fiber post. We're covering the discoloration with the masking layer, creating the palatal wall, adding some effect, the halo effect, and also we did to create some effect here, the adjacent one. This is the polishing, contouring, polishing. This is the after restoration, before and after. So now I would like to share with you two cases about the composite veneer. This patient came to me after ortho treatment, and the patient complained about the space in between the centrals. This is portrait photography. This is intraoral photography, and also here we did electrosurgery in order to correct the uneven gum level. And we wait 3 weeks. After we start to do the isolation, this case is non-prep case, so I did only the sandblasting. I did the sandblasting in order to remove the aprismatic enamel on the surface of the tooth. This is really important. Then we're doing dynamic etching, creating the palatal wall. This is the finishing of the layering procedures. Then we start to do the contouring, the secondary anatomy, tertiary anatomy. This is the polishing, and here you can see the result, immediate post-op. But you can see also the black triangle, okay? So this is really important that I would like to share with you some article about the black triangle. This article published by Dennis Tarnow, 1992, in the Journal of Periodontal. Dennis Tarnow just make a lot of research, and he just checked the distance from the interproximal contact point to the crest of bone in many patients. Almost if the distance 5 millimeter, the papilla will fill, 100% papilla will fill the space. If the space is the distance 6 millimeter until 6 millimeter, only 56% papilla will fill this space. And if more, of course, it will be less percent. So here you can see after 45 days that the papilla fully fill the space. This is the final view. This is the happy patient. And some artistic photography. This is a 15 months recall. This is 3 years recall. So next case, and that's the final case. This is also the patient came to me after ortho treatment, but this is the situation before orthodontic treatment. And this patient had a lot of the caries lesion and also hypomineralization spot on the surface, the white spot on the surface of the tooth. So also here I did a little bit electrosurgery to correct the gum level. This is the isolation after 3 weeks. It's a preparation, the sandblasting, etching, the bonding. So here I use the B4 clamp in order to do more refraction. This is the, after layering the centrals. Then we start to do the laterals. Then after that we're gonna do, we start to do the primary anatomy. This one is the 3/3 correction. So we're using the disc, the fine disc. We're doing the correction of the line angles, then the mesial labial reach and distal labial reach. Doing the correction, 3/3 correction, using the flame-shaped burr. So we're changing the position of the burr when we're going to the middle third and incisal third. Then we're doing the secondary and tertiary anatomy. So this is the polishing. This is the result, the final result, immediate post-op. And again, you see that the black triangle. And this is before and after. And this is after 5 months. Papilla almost filled the space, just a little bit the black triangle left. We have. This is the final view. This is the before and after. Okay, and then I would like to tell you that the harder we work with something, the greater we will feel when you achieve it. Thank you for your attention.
Thank you so much, Dr. Samer. Now we have time for questions. Is there another mic?
Thank you so much, Doctor, for this amazing presentation.
My pleasure.
Just wanted to ask, what do you use to mimic the effects of the enamel, the translucency of the enamel?
Actually, I'm using some effects, like opalescence effect, or I can mix some color. In order to reproduce the incisal transparency, like opalescence effect, I am using two color, the clear composite with the little bit blue. I imagine this little bit blue in order to get some nice and natural opalescence effect.
And what composite brand?
It's a Zenith.
Zenith?
Zenith.
Okay. And do you always use the modeling resin? Is there like an alternative to the modeling resin?
Most of the time, yes, I'm using these effects, or there are some compounds that have a special opalescence effect, and you can use these effects also.
Okay. And last question, what matrix system do you use?
Sorry?
What matrix system do you use interproximally?
Matrix system?
Yes.
I'm using sectional matrix system.
Yeah, but what brand?
Actually, they're a Russian brand, the name of Tor.
Okay, perfect.
Yeah.
Yeah. Thanks so much.
My pleasure.
Any other question?
Hi, and thank you again. I just wanted to ask, what setting do you use the burrs when you're finishing and polishing, like the speed and RPM and all of that?
Actually, this is really the individual. There are some doctors that are using different kind of burrs, but most of the time I'm using the flame shape burr to do the three shape correction. Also, I'm using the disc and very narrow the burr, to do the interproximal correction.
And the speed as well when you're using
Speed, it should be 8,000 to 12,000 RPM.
Okay. And do you use water when
No water.
Okay.
Because when you use the water, you cannot see the effects, okay? You can remove more. And also, you have to use only electric handpiece or contrangle handpiece, not the turbine.
Okay. Thank you.
That's good questions. Any other?
Thank you, Doctor. I just wanted to ask, when doing class 4 restorations with, let's say, very fractured tooth, almost fractured to the cervical part of the incisor, let's say, when you're building the palatal wall freehand without an index, how do you make sure when you're putting the transparent strip, you're not pushing it that hard and you're making sure there is no gaps and the tooth is not indented very much from the palatal side? How do you make sure you do that and there is no gaps between the strip and the tooth surface?
Yeah, it's a really good question. Actually, I'm doing the freehand, the palatal build up so rarely. Most of the time, I'm sending the lab preparing the guide, so the printed model. So now we're using the digital technology, so the lab preparing the printed guide and I'm preparing the guide. But if I have the case like the fracture is not so like big, very big fracture, then I'm using transfer matrix and I'm using with my finger. I'm just pushing my finger, just placing the transfer matrix, I'm adding the material. And in order to avoid the gaps, you have to preheat the composite. And I'm preheating the composite, I'm using the also modeling resin. Modeling resin. So when you're using these methods, you're going to get very, very less gap that if you're not using these things, okay? So that's why most of the time I'm preheating the composite, I'm using the modeling liquid in order to do the palatal build-up. But again, most of the time I'm doing, I'm sending the lab preparing the guide. Okay.
Any other questions? Sure, I have a question.
Okay. Thank you so much for your attention.
You have a question? All right. Dr. Samer, there's another question as well.
Hi, so first of all, thank you very much for the engaging presentation. My question is actually, since we had a lot of engagement with some of the high magnification photos you posted, and to me, the entire presentation was very visually appealing. So for dental professionals who just want to start out in dental photography, what would you recommend as equipment, basic equipment they should have to start them off in their journey?
Yes, it's a good question. Actually, I always recommend to use right now the let's say crop cameras, not professional cameras, but crop cameras. Most of the doctors, they're using the Nikon 7500, or you can use the old one like Nikon 7200, or you can use now mirrorless camera, the Sony and Nikon, but they are a little bit expensive. The lens, 100 millimeter micro lens for the Canon camera, and for Nikon 105 millimeter macro camera, and also of course the flashes like twin flash and the ring flash.
Thank you so much.
My pleasure.
Thank you, Dr. Samer, again for the engaging session. Please just accept our gesture. Sorry. Thank you again. Our next speaker is Dr. Karim Korbani, who is an assistant professor at the Department of Restorative and Aesthetic Dentistry at St. Joseph University of Beirut in Lebanon, and he is also a head of the laser unit at the same university. His scope of investigation embraces aesthetic rehabilitation involving mainly laminate ceramic veneers and novel related materials. Primarily, Dr. Korbani is involved in all aspects of digital dentistry, mainly in 3D printing. That was the main subject of his defended PhD in 2021, opening the door to chairside printing of final restorations. Today, he will be focusing on enhancing smiles through his advanced technique in aesthetic anterior tooth restoration. Please join me in welcoming Dr. Korbani.
Good morning, everyone. Dear colleagues, thanks for being here this morning. I would like first to thank the Kuwaiti Dental Association for their kind invitation. I'm so glad to make it and could travel, depth the situation in Lebanon nowadays. It's so critical, but finally we did it. I'm Karim Korbani, assistant professor at St. Joseph University in Beirut. I have my private practice focused on aesthetic dentistry, as well as I'm a professor at the Department of Aesthetic Dentistry. We are focusing a lot on digital dentistry, laser dentistry, and their application in our daily practice. Thank you. So, during our discussion today, I will share with you what can we do on a daily practice as GPs and as specialists, and how to hire our knowledge going with the evolution of dentistry. You know better than me that dentistry has, during these decades, found a huge evolution in the materials, techniques, and nowadays with the technology. So we as a dentist, nowadays, we cannot say that AI will replace our hand. No one can replace a dentist hand, because all the technology and softwares will apply into patient's mouth, and we still need to do some artistic work, clinical work. We have to use our eyes, hands to perform perfection and aesthetic. The era of cosmetic in general, mainly in dermatology, ophthalmology, is the trend. Botox, fillers, even though the smile design. So, how to proceed and create a roadmap very clear to avoid failures in aesthetic dentistry. During my presentation, I will mix a bit of direct versus indirect techniques, and this is on a daily basis applied in our practice. So, the aesthetic guidelines are, the basics are the same, even for direct or indirect technique. You have to respect the shape of the tooth, the texture, the shade, the length, and so on. So aesthetic is based on biology, on teeth structure, and on function. If we succeed all these, then we can create the outcome with our aesthetic final restoration. Our objective is not only aesthetic, our objectives, even with direct or indirect technique, is to create a good marginal seal, create a perfect emergence profile, create a shape, ideal shape of the tooth with a good function and guidance. While we are facing many obstacles, mainly how to improve and train ourselves, and mainly now with the digital dentistry, we have to go through a learning curve. Then we have to learn more about adhesion, how to prep, how to take impression, and mainly to have a good communication with our dental lab. Saying that, with no doubt, a smile is fully integrated in the lips and in the facial frame. So we have to learn ourselves to look for a smile with a full face, not only in the mouth of the patient. So the frame analysis has to be at rest, at smile position, lateral smile position, see the incisal position with the lips, evaluate the pink aesthetic, inclination of the teeth, and finally work on the shape, length, and dimension of the teeth. So incisal edge position, you know better than me that the patient, young patients are exposing more. So for example, 30 years patient is exposing around 3.5 millimeter of the incisal edge, while patients getting older are showing less and less. Our focus as dentists is on aesthetic, on expertise, and on patient satisfaction, and finally how to get our income. While a patient is always focusing on the aesthetic, how fast is the treatment, and the budget. So the communication between the dentist and the patient, and the dentist and the lab from the other side, has to be proportional. We have to create a good communication with the lab and with the patient. What do we need to create a nice smile? So Dr. Samir talked a lot about the photography. I'll go fastly about this topic. So do we need SLRs, big investment to take photos and create smile design? For sure, SLRs and professional cameras are giving us excellent results. But still, with some other devices like professional dental cameras or even mobile dental photography, we can create and get good result. Here are cases. These cases are taken with the mobile dental photography. We can see all the details, even though SLRs are above this quality-wise. But it's still a big budget for a GP and for a young junior dentist. This patient came to our practice. He's 30 years old with wear, complaining with the shade of his teeth, the shape and the wear, and the length of the teeth. So a full set of photos, I will not repeat what Dr. Samir focused on, is mandatory. Here we went for a conventional technique. We're going to see conventional versus analog versus digital. This case was done fully conventional. So we proceed with a full handmade wax-up, conventional technique at the lab, creating the emergence profile, the length of the teeth. Then on this wax-up, we created our silicone index, and from there, with the BIS GMA material, we did the mock-up into the patient's mouth. At this level, we can discuss with the patient and evaluate the shade, the phonation, the shape, and even the surface texture. After approval, or what we did into the patient mouth, we get the patient's approval. We're gonna start our prepping through the mock-up, and this will be a guided preparation. Galib Gurel talked about this technique early 2005. So the aim of this technique is to reduce and be very conservative and keep our preparation in the enamel. That's why we create our grooves, 3 grooves, gingival, mid part of the crown, and then incisal, in a way to keep our prep in the enamel. And we are preparing here through the mock-up, and this is considered a guided preparation. The incisal edge reduction is around 1 millimeter. And here we start creating with a depth cutting burr, 0.4 millimeters, the 3 grooves on each crown. 1 gingival, 1 on the middle part, and 1 incisal. So here are the grooves. And with this technique is predictable. So if we have on the mock-up, let's say 0.7 millimeter, the lab technician can give us, if he respects the mock-up, the same thickness on the ceramic. The prep on the gingival part is like our burr is 45 degrees. On the middle part, we are parallel to the tooth. On the incisal edge, we are a bit inclined palatally. And the thickness, with the lithium disilicate, we can go up minimum thickness 0.3, 0.4 millimeters. On the incisal edge, the thickness should be a bit more higher to create even a cutback and more aesthetic, or to give enough space for the translucency of the material. And here is the case finished. This was done with lithium disilicate, high translucency material, 0.7 millimeter, with practically little to no prep. So nowadays, we are into the digital dentistry. Who's a digital dentist? Who's using intraoral scan? Who's using an intraoral scan? So, the new era in dentistry and the new technology is the digital dentistry. How to be digital? We start with a CBCT, a face scan, an intraoral scan. We need a software for the design. And then after the design, we take it from there, either with a subtractive technique, which is the milling, or an additive technique, which is the printing, and printing is a new era in the dental field. And both of these techniques can be applied chairside. So we can send to the lab, or we can work chairside. So based on our intraoral scan, we can create a smile design and then go subtractive or additive. So at the beginning, we were doing 2D smile design. The 2D smile design is more basic to have an idea, while a 3D smile design is more accurate and can be reproduced later on. So after taking the intraoral scan, the face scan, we can do our 2D and 3D smile design. We're going to see how to do a 2D smile design fastly. Only 3 photos are taken. One is a full face photo. The second is a frontal one. And the third is with a retraction. Then we can create from here a 2D smile design. And this 2D smile design is a basic and it's not very accurate. That's why. After this 2D smile design, which is more to push the patient and give the patient an idea how he can get a better smile. From here, we can start a 3D smile design based on a face scan and intraoral scan. With an elaborated software, we can create different shapes, different smiles for the same patient, and this 3D smile design is very accurate. So, from this 3D smile design, first it was the initial case, 2D smile design only taken with the photos, we can create this smile. For the 3D, we took face scan, intraoral scan, and we used a digital software for the 3D. This 3D smile design could be printed, and then a silicone index is taken on it, and finally we can finalize it with the mock-up. The mock-up will help us to evaluate the shade, the shape, the phonation, the function, and all the details. So this is a teeth-driven smile design limited to the lips and the teeth, while we talked about a facial-driven smile design because the teeth are fully integrated in the face. That's why nowadays we are taking what we call a face scan, and this we started using this face scan in 2018. So we take a scan of the face, an intraoral scan later for the patient, and then we can, with our software, position the teeth in different planes, frontal plane, bipupillar plane, occlusal plane. So we have a real simulation into the patient's face and mouth. After fixing this and finalizing the 3D smile design, so with the software, we finalize the 3D smile design, we print the models. After printing the models, we create the mock-up. We can take the shade with the digital devices. Here is the mock-up. And after the patient acceptance, we can start our preparation through the mock-up to keep our preps in the enamel and be minimum to no prep, so very conservative. This is the mock-up. This is the before and the mock-up. So the patient has a deviation in the lower lip, but we're talking about the uppers and what we can do. This is after preparation. You can see we kept our prep in the enamel. We are non-invasive. We are very conservative. And here is the final cementation session. Usually after removal of the mock-up and the temporary, I etch my preps with the laser, erbium YAG laser, for 15 to 20 seconds, then followed by a phosphoric etch, bond, cement. We're going to see all the details how we cement. So laser, etching, bonding, and cementation. So this case was predictable. We created a roadmap and we knew before starting what will be the final result. This is based on intraoral scan, face scan, smile design, mock-up, and finally the result will be the same. This is the polishing of the margin, checking on the margins, the occlusion, the function. So this is the final result. Another case with another face scan here. OB scan. So this is the steps before starting any case. We take the face scan, then an intraoral scan, and we take it from there. So this is the daily practice for a smile design is starting with a face scan. So even though with the evolution of the technology, the AI, the human scientific intelligence still here. We still need to do the shade selection, the material selection, and to work properly with the cementation. The shade selection, I don't know, plastic versus human teeth. We are taking a shade guide plastic comparing to a natural tooth. In many cases, we have failures in this field. That's why we have accessories to these techniques. And we have to know the component of our tooth, the translucency, the fluorescence, the opalescence, and knowing that the opacity is different with the thickness of our restorative material. So that's why we can use like digital shade guides, and mainly the important point is the natural dye material. We have to take the shade of the prep. This will help a lot the lab technician for the final aesthetic outcome. So many articles are talking about the accuracy of the shade matching between shade guides and the final result. But this is based on the material also. So in aesthetic dentistry, we have two categories of materials. We have the silicate and we have the zirconia. We all know that silicate or lithium disilicate is highly translucent, so higher in aesthetics, while zirconia material are stronger, strength is higher, but aesthetically they are a bit lower, even though zirconia material is evaluating with its translucency. So on the ceramic, while bonding a ceramic, we all know that we have to prepare the tooth, etch the enamel and the dentine. On the silicate or the ceramic, we have to etch with fluoride acid, silane, and then start our cementation. So the thickness of the material will affect a lot the opacity. Thicker is my veneer, less is the aesthetic, but we have better better opacity to block if we have dark dentine or dark enamel. This study is very important. 2022. This is, who knows that ceramics is responsible of 60% of the final shade. So our cement is affecting only 15% our final result in color. And the dye shade is affecting 25%. So mainly it's the choice of the material. That's why we have to take the shade of our prep and let the lab knows about that. So for the cementation, we have to treat the ceramic, the tooth, and finally to cement. How to prepare our ceramic? We sandblast with 50 microns aluminum oxide, 3-bar pressure for 1 minute, each tooth. Then with fluorhydric acid, if it's a lithium disilicate, it's 20 seconds. If it's a feldspathic, it's 1 minute of fluorhydric acid. Afterward, we wash for sure. And to avoid the salty surface from inside the ceramic, we can apply our phosphoric acid for 1 minute just to remove the salty layer from inside the ceramic. After that, we silane. The silane, you know, it's a coupling agent. We apply the silane for 1 minute and then we dry the ceramic. On the tooth, we sandblast or we use our laser, but we can sandblast with 29, like Dr. Samir mentioned, 29 microns aluminum oxide with irrigation. This machine is working with air and water, so we don't have the dust. With high suction, we can sandblast the tooth, followed with the phosphoric acid, and this is how we sandblast the ceramic or the zirconia with 50 or 53 microns aluminum oxide. A big question, which material to cement with? And what is the difference between these materials? No doubt now it's the era of the universal bond. This universal bond, the advantage is that you can apply on wet or dry dentine. This universal bond is really very thin and easy to use. It can be used with total etch or selective etch technique, so less sensitivity. So it's the era of universal. What the difference between the material or the cements? We all know that we are using for veneers light cure cement. Why? Easy to handle. We decide whenever we want to start the polymerization. It's easy to clean, and it's more stable in shade with time. So the difference between these light cure materials is the viscosity and the different shade and the opacity. Which is important is to focus and get trained on one material. Don't use different at the same time. So once you get used to your material, the setting, polymerization time, how to clean, how to get a good shade with the ceramic, then you can continue using the same brand. So stability of the shade is a must. The bond strength is also a must. How to manipulate, is it too flow or too thick? And if we have different shades. We all know that we have what we call try-in paste. The try-in paste is a gel with the same color of the final cement. So this try-in paste, we can use it before starting our teeth and ceramic preparation with the aluminum oxide to see what could be the final result before cementation. Here is a big question. Who's doing zirconia veneers? Someone is doing zirconia veneers? Is it feasible? Here, Maha, 30 years old patient, came to our practice like 5-6 months ago. We started as usual with a face scan. Then an intraoral scan, then a 3D smile design. Based on this 3D smile design, we printed the models, we prepared a silicon index, we did our mock-up, we prepared through the mock-up to be very conservative, and here we were such like not touching the enamel, we were really non-invasive. Incisor reduction, buccal reduction. And here is stained zirconia veneer. This brand created a powder that the lab is putting inside the interface of the zirconia and firing it in the furnace. And this layer is etchable with fluorhydric acid. And then it is treated like a lithium disilicate or a regular ceramic. And here is a stained zirconia veneer. Thickness is like 0.4 millimeters. And here is the final result. Our patient was very happy, and I think I did the case in February, so it's nine months ago, and still no debonding. We talked about the 3D printing. 3D printing on a daily practice in aesthetic dentistry could be very, very easy to use, and it's helping us in mock-ups, 3D printed model, temporary, and even though nowadays, permanent or semi-permanent veneers or crowns. So this patient came with these composites. We decided to start with the face scan, intraoral scan, 3D smile design, placing respecting all the planes, frontal, bipular, occlusal plane. And here is the design, printing of the design. And then it's a full procedure of post-processing. So we remove from the printer, we wash this material with ethanol, and then we put it in a processor for 7 to 8 minutes. And this printer can print 80 units in 15 minutes. So it's very fast. And here is the final case. These are considered semi-permanent materials. Another case done with 3D printing, hybrid ceramic material also. This was an additive case, so we added to the teeth without cutting or preparing on the teeth, and here is the final result. Bego, Varis Smile, they have a semi-permanent material. Voco, I think they have, and Seromco, they have these kind of semi-permanent or hybrid composite material. We can use it for inlays, onlays, crowns, and veneers. And here is the final case. So we talked a lot on indirect technique. Now I still have few minutes, I think. So Dr. Samir talked a lot about direct. I don't know what to say, so I'll skip a lot. So as I mentioned, the roadmap in aesthetic dentistry is practically the same in direct and indirect technique. Direct and indirect. So the question is, how possible is to make our restoration invisible? We saw already amazing cases with very good results. So we have to respect the golden rules, the proportion, The pink aesthetic, the proportion of the width of the teeth. We have to know about the nature of the teeth structure, the translucency, the opacity. So let's make it a bit easy and see how we can be fast and good at the same time and get, let's say, invisible results. Jean-François Roulet raised a question. Jean-François Roulet is the editor-in-chief of the Journal of Adhesive Dentistry. He raised the question, what if they were no adhesive dentistry? So you can imagine working aesthetic dentistry with no adhesion. So all the aesthetic dentistry is based on adhesion. So as we mentioned, it's the era of the universal bond. I talked about the advantages of universal bond that we can use as on wet and dry dentine. We can use with etching and as a self-etch. So this universal bond is making our life easier. Here a case we took, the restoration was on tooth 21. So 21, we took a silicone index. After that, we removed the previous composite, beveling, etching. We started with the palatal shell on the silicone index translucent, and then proximal, and then finally incisal. So the material of choice, which material we're going to use? So it's the era of nanohybrid material. The essential part is to get used to our material, because every brand has its own specificity in handling, in opacity, translucency, and the difference will be the thickness of the layer between dentine, enamel, and translucent in different brands. So for example, this Neospectra, these composites has a chameleon effect. It can cover 80% of our restorations with only one single tube. To upgrade, and if we have more specificity in the anatomy and the translucency, we can add some dentine opaque or enamel translucent on the edge. Isolation for cementation and in adhesive dentistry is a must posteriorly as well anteriorly. Talking few words about the light cure machine, we have to control our machine, try to test it at least once per year. Our power has to be between 600 and 1000 milliwatt. We have to avoid the under-curing and over-curing to avoid the shrinkage and the post-op sensitivity. And we have to control during our restoration how opaque is our tooth, and this will affect the thickness of the layer of our dentine layer. Then at this stage we will add some opaque, and we have to control and compare with the adjacent teeth the translucency on the edge. At this stage we can add some translucence material. Here is a freehand composite build-up, also done with only a matrix. In other cases, easily we can take or a digital impression and print the model after smile design or design of the restoration, or just a small mock-up and take our silicone index, or even take an alginate, send it to the lab with a small wax-up, create our silicone index, and proceed with the restoration. We can also take our shade with using small dots of composite on the tooth without etching and bonding, or before etching and bonding. Choose our opaque, dentine, and translucent. Always create the palatal shell, then layer after a layer, finalize the shape, the morphology, and the texture. Another case, silicone index into the patient's mouth, removal of the old composite, palatal shell, finalizing the case. Here also, we try to take the shade before starting, removal of old composites, silicone index, step by step, enamel palatal, then dentine, and we finalize. I'm not going to go into details of the texture and the polishing. So with one tube, we can create such restorations. If we have more translucency, we can add a little bit. And this material, if we increment, we reduce the translucency and we have more opacity. I will go through, and this is the case before, the case after. Another case with the silicone index, enamel palatal, then opaque dentine, translucency, and with the white spots to imitate the adjacent tooth. I think we're done. I'm here to discuss with you any question.
Thank you very much, Dr. Kurbani, for the informative presentation. Now is the time for any questions from the audience.
Thank you, Dr. Kurbani. Just a question about how do we prepare the inner surface of the zirconia veneer?
This brand, it's the only one who created like a kind of gel or powder. They spray it into the intra-surface of the zirconia and then they fire it. After sending us this veneer, we can apply our fluorhydric acid for 20 seconds and then wash it and then silane it and treat it as a lithium disilicate.
So we can't use any kind of zirconia. I'm here, Karim. Dr. Karim, here.
Okay, sorry.
So you can't use any kind of zirconia.
No, this is iodide. They created this. They were the only ones.
Specifically this one?
Yes.
Otherwise, it will detach.
Yes, because you don't have a chemical bond between the resin and the zirconia intrasurface of the zirconia.
Sandblasting will
it's
not be
enough. It's not
Yes,
enough.
Thank you.
But I think this is coming for zirconia with the other brands. You know, when someone starts somewhere, everybody will follow and improve.
But why should we go to the
Zirconia, what is the advantage? It's a thickness because the strength is higher. Second, cost-wise is less costly for the lab than lithium disilicate. Third, almost the labs are doing the lithium disilicate pressed, so they mill the wax and they press the ceramic. So you have two steps, and the risk of misfitting is higher. So with the zirconia, you are just milling the zirconia. It's fully milled. While with lithium silicate, you can mill, but the labs are using more the pressing techniques.
Any other questions?
With the ceramic, yes. And zirconia, you can do it. Ceramic, zirconia. Zirconia, ceramic. Ceramic, zirconia, tooth. Yeah. You can. They have special staining techniques. You cannot know if it's a layered or a stained technique.
No more questions? Okay, then we will conclude.
Thank you.
Thank you so much.
Thank you. Thank you. خلينا
Dr. Maha has been invited to speak at numerous international conferences, including EDEC Dubai and IRIS Dubai, and brings over 11 years of private sector experience. She currently serves as a partner and the medical director at Dr. Nail Al Hazim Center.
Test, test. لا. Is it okay? Okay. So it should be المفروض mirroring فيطلع المفروض اللي هني. Just a second. Here? السلام عليكم. يعطيكم العافية ومشكورين على الحضور اليوم. Thank you everyone for coming. My lecture is going to be in English. And do we have only English speakers here in the lecture hall? Only English speakers. Okay, فأخذ راحتي إذا بحول عربي. مزيدي only English speaker. Okay. So, the lecture topic is success in cosmetic dentistry, a destination or a journey. I like to ask you, what do you think? Who thinks it's a destination? Who thinks it's a journey? Raise your hand, don't be shy. Okay. So why is it a journey? I agree with you, it is a journey. Success is a journey because it's the steps that we take along the way is what put us closer to success every time. And I'm saying closer because it's not a fixed point. Success change all the time with the change of the landscape in dentistry, with the innovations in technology, in techniques, in materials. That's why us as dentists, we should keep up with the change. We should evolve in the process. So why change? Many of you will say, I'm in the practice for many years, I'm making good money, I have good patients flow, so what's the need for change? Why do we have to change? We have an ethical obligation towards our patients to change. We have an ethical obligation to provide them with the latest innovations in materials, technology, techniques, to give them a better outcome, to give them a better experience. That's the first reason why we have to change. The second reason is, if you are resistant to change, if you think you're the best, you don't have anything new to learn, then you are destroying yourself. Why? Because stagnation is the enemy of growth. Your patients will realize that with time. They will seek a more modern dentist to provide them with the latest techniques and technology and to have the better outcomes and results. So you lose your patients with time. Change is good for our mental health because we're stuck in that small room doing the same thing every day. Sometimes it gets to us. So change and staying up to date with the latest technologies and believing that there's a room to grow, this by itself gives us a motivation, ignites this passion for dentistry every day in us. I believe that there are two kinds of success in dentistry, in cosmetic dentistry. There is short-term success and there is long-term success. And I'm going to give you this example, and after that I'm going to elaborate more on the two terms. We have two dentists, dentist A and dentist B. Both are delivering good clinical dentistry. Both are active on social media. With time, dentist A noticed that he's losing patients with time. On the other hand, dentist B is growing gradually and steadily. So what did dentist B do differently than dentist A? If both are delivering good clinical dentistry, both are active, and they're on the social media platforms, what did this dentist do better than this dentist? Priorities. Different priorities, different core values. Dentist A is the one who noticed drop in patients. His priority was money and fame. He did not care about his patient satisfaction. He did not care about his patient's experience. He did not care about the word of mouth. He just delivered a beautiful smile. He got beautiful pictures of his smiles. He posted it on Instagram. He's getting patients from sponsored ads, but he's not getting patients from word of mouth. So this is what brings us to these two terms, short-term success and long-term success. Short-term success prioritizes immediate outcomes and rapid financial gains. so loss of patience and financial decline with time. Long-term success prioritizes optimal clinical outcomes and patient satisfaction, steady growth in number of patients with time. So patient satisfaction is the key word here. Money and fame are byproducts, never, ever goals. Fame and good reputation. Do not mix up these two terms together. You can have 1 million followers on Instagram. You can have 1 million views on TikTok. You can be following trends and be happy about it. But good reputation only comes from word of mouth and respect from your colleagues. And this is what we should aim for. Do you know this phrase? I think everyone knows it. Happy wife, happy life. After almost 12 years in the private sector creating smiles, I totally get it. And I think any cosmetic dentist in the room will get it when we say that we're almost married to our patients. So when they're not happy, we're never going to be happy. So how to achieve patient satisfaction? Satisfaction is linked to expectation. When we meet the expectation, if we exceed the expectation, we achieve patient satisfaction. I think you're seeing the emails from my daughter's schools. Okay. Holistic dentistry. To achieve patient satisfaction, we should take the care to our patient into a different dimension, into taking care of the human being as a whole, physically and emotionally. So, to meet our patient's expectation, we have to be excellent in communication, we have to be excellent in diagnosis, excellent in treatment planning, excellent in execution of the plan. In this presentation, I'm not going to talk about this last part, the excellent execution. There are many dentists who are going to talk about it, the clinical part. I'm going to talk about the first 3 parts, which I think are very crucial, the treatment planning and the diagnosis in any success journey. Smile architects. I love this phrase. I love it because it combines art with science. I love it because it focuses on planning, on providing the blueprint to build the beautiful smile. In the dental practice, we have much more great executors than great planners. Chris Kochman. I know that not many people agree with him, but I agree with him in this one. In the dental practice, in our journey, dentists in general invest a lot in being good clinicians. During dental school and after that in conferences and hands-on courses, we focus on how to be minimal. We focus on how to bond our teeth perfectly, on how to place the implants, on most of those things. Not as many focus on the treatment planning part, which is the most important part in my opinion. In order to be excellent in treatment planning, we should diagnose in a comprehensive way, we should plan in a comprehensive way, and we should plan it in a multidisciplinary way. And preferably, it should be a multidisciplinary practice where all the specialties are under one roof. But this is not enough. If all the specialties are under one roof and they don't have, there's lack of communication between the specialties, we didn't achieve the goal. It should be an interdisciplinary mindset. And the cosmetic dentist should have this general thinking, should have this interdisciplinary mindset where he connects the dot, where he brings all the specialists together to create this beautiful treatment plan. Treatment planning should be independent of patient acceptance. We don't plan for acceptance. This is not ethical. We plan, we give our patients, we provide our patient with a comprehensive treatment plan according to their health needs, according to their psychological needs, regardless if they're going to accept or not. Acceptance is patient's education. When you educate the patient, when you really spend time in explaining your treatment plan, in bringing the patient on board, in making the patient perceive the value of the treatment. That's patient's acceptance. But it shouldn't be in your mind when treatment planning the case for the patient. So this brings us to this topic, the first visit. I am emphasizing on the importance of treatment planning and on diagnosis, and I believe that this happens in the first visit, which equips both you and the patient with the information and the confidence needed to proceed with the treatment plan. And I'm going to talk about the first visit etiquette. Before talking about what to do and what not to do in the first visit, I call it first visit etiquette. It's like magic when you walk into the room for the first time and see the patient. I know that you have a long day, you're seeing patients all day, in and out, taking impressions, attending to needs, attending to complaints. But once you go to this door, wanting to enter this room to give the consultation, you have to be in a certain state of mind. You have to block all distractions. You're here for this patient behind that door. So you have to master the art of changing hats. You have to separate your anxiety and stresses from this moment and walk into this room with a big smile on your face, greeting the patient with their first name. And it's very important, not walking in and then looking at the screen, hello, Fatma, شلونك? No, just knock on the door. I have this knock on the door that I do it every time, and I feel that it resets my mind. I just hit the door. So, and throughout the treatment, the patient knows that I'm coming when I hit the door, because it's resetting my mind and their mind that I'm coming. And I walk in, I tell my nurse, either tell me the name of the patient before I go in, and leave me a note by the door before I see the patient. And when I greet them, I make an eye contact, I sit down. I don't talk to them standing. It gives them an impression that I'm in a hurry, that I have to be somewhere else, that I'm not giving them my full attention. So these are like few steps that I call the first visit etiquette that I feel that help me, and maybe it will help you. So to get the best out of the first visit, we have to be good listeners, we have to be comprehensive in our examination, and we have to be good communicators. And when we say listen, we have to give our patients our full attention, to be active listeners, to establish an eye contact, to use our body language to show them that we are really interested, we're genuinely interested in them, and to ask the right questions. And when I say the right questions, for example, I always ask my patients, hello, why are you here today? How can I help you? أو شلون أدلعك اليوم? يعني just to break the barrier. And one time I had this young gentleman who obviously needed our intervention to aesthetically and functionally and biologically fix his smile. But when I asked him, why you're here today, Mohammed, he told me, because my mom told me to come to you. I know that I'm gonna put him on board and explain to him the treatment plan and convince him later on, but his motivation was his mom. So make sure that his mom is present in the delivery day. Motivational interviewing. Have you heard this phrase before? Motivational interviewing is a modern kind of communication where it's a patient-centered, collaborative communication approach. It helps patients clarify their motivation for treatment, to find it in them why they need to change, instead of criticizing them and telling them, well, you need to fix this and that. No one likes to hear this. But when you lead them and guide them into acknowledging the problems that they have and how to fix it, it usually makes them more on board and more committed to the treatment plan during and after in the maintenance phase. It sets realistic goals. It makes decisions that align their values and self-image. Examples of questions that you can ask. To find the patient's goals and motivation, as I said before, you can ask, what brought you here today? What change are you hoping to see? To address fears and concerns, you can ask, are there any parts of this process that make you feel hesitant? في شيء مخوفك؟ شنو الشيء اللي مرددك انك تدش بهالخطوة؟ Expectations is very, very important to know their expectations. What are your expectations about the outcome of this treatment? What does success look for you with this procedure? We need to see what's in their head, where they see themselves. Because if we don't know their expectations, we're going to be blind. What are we planning for? Again, we're going back to only nailing it clinically. Good occlusion, good bite, biologically everything is successful, golden proportion, whatever, but the patient is unhappy. This is not what they wanted. Or maybe they have unrealistic expectations that we needed to ground it from the beginning and lower it from the beginning and tell them what we can do and what we cannot give because of the limitations of the treatment. So again, back to listening, do not interrupt, and show empathy, do not bully. I had many patients sitting on my chair crying, usually young females, because they were bullied from the previous dentist. ليش هذا روحك كذي؟ بنية بعمرك كذي أسنانها؟ You think by saying this, you're really motivating your patient? She's on my chair, you lost her. So please be kind, be empathetic, and instead of criticizing them, praise them. Praise them for their courage, for coming forward and trying to fix the problem that they have. في صوت فما أدري هو من Comprehensive examination. We talked about this before, that we need to look at the big picture. We shouldn't be biased. That's why we have to have a general dentist mentality in the first appointment. Usually, we like to look for the things that we like to do the most. I like to place implants. Let's start with this one. I like to do ortho. Let's start with this one. I like perio. Let's start with this one. No. We should look at the big picture. We should have a comprehensive mentality when treatment planning the case and when diagnosing and examining. And we talked about this, that we have a moral obligation to provide our patients with a comprehensive treatment plan regardless if they're going to accept or not. And technology will not do your job. We use technology in treatment planning. We use technology in the execution of the plan. Technology are tools. Digital dentistry provides us with tools that will make our journey easier, that maybe will grant us a more accurate result, but it's not going to do your job. زين أنا ما قاعد أتحرك، ليش قاعد يطلع صوت؟ هذا؟ Okay. Again. Okay. So you have to be a good communicator. نقدر نعدل هذا. A good communicator means that we have to explain the treatment plan in details, every single step. We explain the pros and cons and the challenges in every phase of the treatment. We have to explain the risk of failure. So this is the realistic expectation that we're talking about. We're going to place an implant in this position. Our periodontist or surgeon will try his best to augment bone, to do sinus lift, but there is maybe a chance of failure of the implant in your case. So we have to prepare our patients for failure. Align their expectations and be honest. Don't worry about patient's acceptance. If the patient comes to you and he needs an orthognathic surgery to fix his gummy smile, and he thinks that just by doing veneers and gingivectomy you're going to solve the problem, no, be honest. No, I'm not going to solve this problem for you. We can reduce it to this extent, but if you want to eliminate your gummy smile, we have to seek a consultation from an orthodontist and orthognathic surgeon. Don't worry about patient acceptance. Just be realistic now. Because if you initiate this case, you deliver the veneers, you do the gingivectomy, and then the patient is unhappy, doctor, you promised me you're going to fix this problem. Are you going to be happy? No. Happy wife, happy life. Patient's education, we have to put the patient on board. We have to educate the patients about the steps of the treatment, how to be committed to the steps. What happened? Okay. نفس المشكلة مرة ثانية. That's Zaina, by the way. IT. Okay. So, when to say no? Yeah. When to say no? When to say no to the patient? We say no to the patient when there is no need for treatment. When we weigh the risk and benefits and we see that the patient, the biological price will be higher in this case, that the patient will benefit from ortho more than cosmetic dentistry. He just need bleaching. So say no. Do not give the consultation thinking about your empty schedule or that you need to make money or pay your bills. Be honest and trust me, this patient that you say no to will bring you 10 patients more because they're gonna leave the clinic valuing your honesty and they're gonna tell their family and their friends that this doctor gave me an honest opinion. He did not use me for his financial gain. So that's when we say no. When the patient have unrealistic expectations, like they bring me a picture and they say, I want to be like that. I explain to them that you cannot look like that because this and that. No, I want to be like that. Even after you explain and educate, so do not touch this patient. They have unrealistic expectations. They're someone else's problem. Okay? When patient is not ready emotionally, that's also when we say no. I'm going to tell you a story. I had a patient who came to my clinic. She was very happy and bubbly and wanted to start as soon as possible. She had multiple problems, implants. She was a full mouth case. And she was very pushy to start the treatment. Like, doctor, when can we start? When can we finish? I'm planning on expanding my family. I'm planning on getting pregnant. So can we finish in a month? I told her, no. Your treatment plan will need at least 3 to 4 months to be finished. And I explained to her all the steps after the examination, a very thorough examination. And then she told me, I did not put this wallpaper, my daughter did. Okay. So, again, she was very pushy to start the treatment. She was very eager to start and finish because she was planning on getting pregnant soon. And I told her, no, that your treatment plan will take some time. So then she told me after explaining that, doctor, you're too kind, you're very nice, you're a true human, and you reminded me of a doctor who used to treat my daughter. So I said, thank you. And then she continued, before my daughter went abroad for her treatment, بنتها تعالج في الخارج كانت. So the normal question that I should ask is what? How's your daughter now? I hope she's feeling well, right? Being a human being, right? So she told me, well, my daughter passed away 2 months ago. Her daughter passed away 2 months ago, and she's here for a full mouth rehabilitation and planning on getting pregnant. This mom is in shock. This mom is not dealing with her grief. And just right after she acknowledged that, she cracked on the chair. She started crying and sobbing hard like in a way that I haven't never seen before on the chair. So imagine starting your treatment on that patient. So then I told her, holding her hand and trying to comfort her, that we're gonna try to help her fix whatever it takes to relieve her pain only, but I'm not gonna start the cosmetic plan now. She's not ready. She's looking for a distraction. She's not dealing with her pain, with her grief. she's not ready emotionally. I told her, no, we're gonna postpone your treatment maybe for a year. I'm gonna see you during that in follow-ups, after your scalings if you like, after seeing the periodontist because she needed perio consultation, but I'm not gonna start the cosmetic plan now. أذاننا هذا. Okay. It's not connected again? ولا ليش؟ Just a second. Okay. So I was in a lecture by Dr. Chi. I think many people here knows him. So he said this phrase, don't be a hammer and treat every patient like a nail. So don't, like if you're a cosmetic dentist, every patient that knocks your door, I'm gonna do cosmetics. No, customize your treatment plan according to the patient's need. Maybe they need 2 teeth, maybe they need nothing, maybe they just need ortho. Customize your treatment plan and don't be a hammer. A team sport. Dentistry is a team sport. You cannot do everything by yourself, even if you're the best cosmetic dentist in the world. You have to be in harmony with your team. You have to have excellent communication with your team. You have to respect each other. Take feedback, be humble, take criticism. That's how you grow. And acknowledging always that, remember, that we need to change, we need to evolve, that we can be better. This will help us deliver better dentistry to our patients. And, of course, your core value should be aligned. I cannot have an endodontist who wants to make money and do endo for every consultation that I send him. And what we have in our practice is the opposite. Thank you to Dr. Abdullah and Dr. Saleh. Many times we convince them to do the endo and they say no. So thank you, my team. I really appreciate you guys. The other factor in the journey, the other human in the equation, in the road to success, is you. You have to take care of this human being as well. So, the secret ingredient. I'm gonna tell you this small story. In New York, there was this math teacher. Her name was Angela Lee Duckworth. This math teacher used to teach 7th grade math. And this math teacher noticed that not her smartest students were the best achievers in the test. And she noticed this along the years, that not the smartest, not the highest IQ students were the best achievers in the math test. So this made her wonder, what is the secret ingredient? After that, she left teaching and went to study psychology, and exactly the question, what makes successful people successful? And she, after going to military schools and corporates and studied, and she realized that it's not the IQ that's what made successful people more successful. It's not the emotional intelligence. It's not the appearance. It was something else. It was something called the grit, perseverance. Grit is to hold on to your dreams. Grit is passion. Grit is fighting for your future, day in and day out. Not for days, not for months, but for years until you make your future a reality. That's what grit is. In 2013, in the beginning of my path in the private sector, I worked in one of the renowned clinics in Kuwait. And I'm proud to be part of this team then and now. The thing is that in Kuwait then, most of the successful cosmetic dentists were males. And it was very hard for me to prove myself in a male-dominant practice. And I was so eager to work and I wanted to see my schedule full. So whenever I was asking the call center, why isn't my schedule full? And this male doctor who started right after me, he has patients. And they say, Doc, what can we do? Whenever the patient calls, he asks for a male dentist. He doesn't want a female. He doesn't trust a female dentist. And this was back in 2013. So this ignited something in me, like tahaddi. So I said, I'm gonna let them call, request a female dentist, and request me by name. And I knew that I had something different to offer. I had a different perspective. I had a talent. I believed that I was special, and I wanted to show them that thing. Today, alhamdulillah, in 2024, my schedule is full 3 months ahead with consultations. Do you think if I believed this man's perspective about female dentists then, and I just gave up, it is what it is, what can I do? I cannot change the community. I will be here today? No. So do not let anyone tell you what you can and you cannot do, especially yourself. And I believe what really gave me the grit is that I was lucky that I was doing something that I love. And I found what I love very early in life, which is creating smiles. Steve Jobs said, the only way to truly be satisfied is to do what you believe is great work. And the only way to do great work is to love what you do. 2 words here, to feel satisfied and to love what you do, to feel fulfilled. And what really gave me fulfillment is that I was using my hands to create something beautiful. I love art since I was a little girl. And not only that, I'm seeing the impact of that thing creating happiness on my patient. So this was my why. This was what drove me. This is my core value and what made me withstand the pressures of our practice. We have pressures. It is really tiring, especially that we have to be consistent. Consistency is the key. I cannot go one day deciding that I'm going to do this excellent prep and the other day, no, I'm not going to use my loops. No. I cannot go one day in a good mood greeting my patients and the next day, no, I don't want to deal with them, I don't want to see them. You have to be consistent. You have to do this every single day to be successful. So how to be consistent and not reach burnout? So we have to stay balanced. We have different roles in life. We have to remind ourselves that we are not only dentists. We are mothers, fathers, daughters, sons, friends, sisters, brothers, whatever. We have different roles in life, and we have different needs in life. We have physical needs, health needs, spiritual needs. We have to have time to do our hobbies. We have to stay balanced so that we can perform better, so that we can last in the marathon, so that we have stamina. So success in cosmetic dentistry is not a race. It's not that I'm going to go from this point to this point, so I have to run fast. No, it's a marathon. You have to have stamina, so you have to stay fit. You have to attend to your needs, physical, emotional, in every way. So we have to separate the 3 times, and that's something that I do and I found helpful. We have patient time, clinic time, and your time. Call it me time. I never let them overlap. And maybe my team knows, Saad Mohammed Yadri, that I hate it when they come to me when I'm with my patients talking about materials, about an order, no, this is not clinic time. This is my patient time. I don't want distractions. My family knows that they do not call me if it's not an emergency during this time. My mom knows. So you have to separate the 3 times in order to be happy, to stay balanced. And again, it's a marathon, not a race. It's a journey, not a destination. So we have to take care of the 2 factors in the equation. If I want to sum it up, we reach almost the end of our presentation. Our patients, patient satisfaction, We have to align our core values. And I always say, وَعَلَى نِيَاتِكُمْ تُرْزَقُونَ. هذه الكلمة لها معنى عميق جداً. شنو نيتك لما تقعد مع المراجع؟ نيتك أن أنت تستفيد منه، تحلبه بتطلع منه فلوس، ولا نيتك أن أنت قاعدة تطالعه كنا بنتك، كنا أمك، كنا أبوك، شنو فعلاً يحتاج وتخليه يطلع يدعي لك من وراك. فلازم نستحضر هذا الشيء، الإحسان، أن تعبد الله كأنك تراه فإن لم تكن تراه فإنه يراك. فهذا اللي بختم فيه إن شاء الله محاضرتي. And I have to conclude with this picture. I'm very grateful to be part of this team. I love them. They're my second family. We disagree sometimes, we fight sometimes, but we love each other. ليش؟ لأن هدفنا الأوحد هو مصلحة المريض. Thank you very much for listening. Now I'm going to take questions.
Yeah, thank you, Dr. Maha, for
You're
your
welcome.
inspiring and enlightening
Thank you.
presentation. Do you have any questions?
لهالدرجة المحاضرة وايد واضحة أو مملة؟ مشكورين، يعطيكم العافية. Yes, he's supporting us. Thank you, Dr. Mohammed, for attending. So, thank you very much. Allah يعافيك.
Dr. Maha, if you just thank you everyone for your attendance, and with this session we're ending the cosmetic and restorative session. We'll see you in the next stages. Thank you.
خليني أخلي تلفوني. اوكي شو
عندك شيء فيديوهات بدها صوت شيء ولا
كلها
في فيديوهات شيء؟
كلها فيديوهات
مع صوت؟
وايد يشتغل؟
حيطلع فيديو يعني على الشاشة مع صوت؟
ايه
افتح هيك وهي فيديو حيشتغل اوريدي حيطلع صوت لحاله. تمام؟ اللي سمعت عن سماع اسمه صفر شغال هو بس خلاص احكي
بس هو يلمسني لازم يجي
عادي
Hello.
هو لازم يجي هيك.
Hello everyone. Thank you for coming. Thank you Dr. Mohammed Kamal for joining us today. So Dr. Mohammed Kamal is a German and European board certified oral and maxillofacial surgeon, fellow of European Board of Maxillofacial and Head and Neck Surgery. Dr. Kamal is duly qualified in dentistry and medicine and a licensed physician and dentist in Kuwait and Germany, and has been trained at several top-ranked international universities. He is currently working as an assistant professor of oral and maxillofacial surgery at Kuwait University Health Sciences Center, Department of Surgical Sciences, focusing on the correction of facial deformities and corrective jaw surgery. Dr. Kamal is well published in several internationally renowned medical journals reporting on various clinical and basic science research projects, and his work has been presented and published in several medical journals and international scientific meetings.
All right, thank you very much, Dr. Asil, for the kind introduction. So I'll be talking about 3D technology in addition to additive manufacturing in the field of maxillofacial surgery. We want to know how technology has impacted our career. If we have cases like this, I'm talking about only complex cases now. If we have cases like this, patient coming in with anteriorly positioned maxilla with a gummy smile and a class 2 relationship, high mandibular plane angle, this is a difficult case, especially if you look and you find out that there is also an underlying asymmetry of the maxilla and the mandible. So if you want to go ahead and implant this, you have to make sure you are using the best diagnostic modalities in order to, let me see, it's not working, in order to evaluate the case and come up with a good treatment outcome. Look at this case. On repose, okay, we have exposure of the teeth. During smiling, we see the exposure is more than 1.5 centimeter and the maxilla is anteriorly positioned, and we have to do a complex treatment planning in order to achieve nice results. If you evaluate the CT scan and look at the skull in a 3D dimension, you find out that we have notable asymmetry, and we cannot go ahead and do simple repositioning of the maxilla and the mandible. If we have a case like this case comes in with a facial asymmetry that is present in the maxilla and the mandible, both of them in three-dimensionally dislocated position with an asymmetry that makes it difficult to plan without using technology. This is a maxilla, if you want to imagine how it looks underneath. And if you look at 3D imaging of how the patient comes in repose, you can appreciate the asymmetry, but during smiling, that is even more aggravated. You can see how much significant asymmetry she has in the maxilla and the mandible and the chin. Here, exactly, it's the same if we look at the soft tissue and the skeletal bone. This patient comes in, he has an anterior open bite, he has an aesthetic concern, he has chubby cheeks in general, he has a neck that is short, and his main complaint is sleep apnea. And if you evaluate here, the patient has also dislocated maxilla and mandibles, and the positioning are not optimal, and we need proper planning if you want to advance all of this soft tissue, and additionally you improve the airways. Let's look at the 3D before and after, before the surgery, on repose and on smiling. This is how the patient comes in. Look at the neck, how short it is and how set back it is. Before, in the past, we used to do conventional planning. Conventional means we take an impression and we mount them on an articulator. The best you can do is to have a clean articulator like this. But we did not have much digital technology. During residency, we used to spend the weekends trying to reposition the upper and the lower jaw. And in order to do that, that used to take us lots of time without focusing on the soft tissue or how that effect is going to have a global effect on the face in general. Now, this is the workflow that I use. I use 3D facial scanning, intraoral scanning, CBCT with a full skull field of view, then special software to do the planning. I have my own form and format in order to do a clinical examination, and then 3D printer in-house, and then you are ready to go to surgery and do the procedure. The objectives are the same: to achieve proper occlusion, but again, in a three-dimensional format, we have to have it in an aesthetically pleasing position. When you do the maxilla and the mandibular repositioning, we have to think that as a complex, we're gonna keep moving that in a three-dimensional shape. So for that, we need to think if it is good to keep with a conventional hands-on planning, in which you have the cast, you feel them, you position them, you know how much you want to move them, or do you go fully to digital? Or do you go somewhere in between, in which part of it you do it manually, part of it you do it digitally? If you look at this table, I'm not going to go through it, but at every point in terms of visualization, precision, time and efficiency, for me, in my hands, three-dimensional technology and three-dimensional virtual planning wins, and we're going to see how is that. So until recently, we used to have a CBCT. Look, we're advancing the maxilla for this patient. We're doing Le Fort. Look here on the side. We're going to do Le Fort. The whole soft tissue will move. That means the soft tissue changes in the face will change after surgery, even if you're doing a single maxillary advancement. And this, if you go back to the art books, this is how it is. You evaluate the face. We have to evaluate it in a three-dimensional way. And there is an illusion. There's an element of illusion and the differences between shadow and light that what gives you the reflection of facial aesthetics. Let's go back to geology. In geology, we study also topography of the ground. So the topography of a mountain, we can do it in 2D surfaces. You do lines. Each line has an elevation. So you have line 800 meter, line 8,800 meter, and this is how we quantify or how we visualize a 3D structure into the format. But nowadays, even in geology, there's a 3D using remote sensing. We can have ways to reconstruct these topographies in three-dimensional format, and the same is in our face. Because if you have a patient looking at you straight ahead and you just move the light in different directions, we will have a different perception of facial aesthetics. If you look at all of these 16 pictures, they look like 6 or 7 different people, but it's the same person. It is just how the light is illuminated on the face and how it is reflected. And makeup artists know that very well when they do their art on the face. They focus on the shadow and the light in order to reach the desired outcome. In our field, we used to do, even that we did not used to do. In the 70s, there was some papers describing how to do it in 2D, but 2D evaluation of the face is difficult. Nowadays, we are lucky we have advanced technology in which we can evaluate things in a 3D. And if you look in a 2D world, it's different than a 3D world. If you evaluate a patient, like this patient, in a 2D world, the patient is looking straight ahead, then everything is made flat in front of you, and then you will measure the facial thirds and the facial proportions and all the anthropometric measures on the face that we learned. In a three-dimensional format is different. It depends on the head position. What is the natural head position? Is this my natural head position or this? Or is it straight ahead? And who defines if that is what is straight ahead? There has to be a mirror in front of me in order to know what is my natural head position. But if you have a natural head position, the three-dimensional evaluation or evaluating things from a three-dimensional view is totally different from a two-dimensional view. That's why it's time to abandon the two-dimensional view and come up with the new facial proportions just related to the three-dimensional view. Eliminate the frame and look at things in a three-dimensional way. In that point, you can have an accurate proportion and understanding the correct proportionation of the face without being dependent on the position or on the quality of the camera or anything like that. So now we know, doing the procedures, utilizing this technology, that we have soft tissue changes in the face. Some of them are favorable, some of them are not. This patient came to me complaining about her nose before the jaw. We did the class 3 surgery. She did not wanted to do it for years because her concern was the nose. We did the surgery. The nose did change The nasal changes did occur, but in a favorable way. So we understood what changes are going to take place. We controlled that during surgery. We tried to control the framework, the skeleton, the cartilage framework of the nose during surgery in order to achieve good outcome. The result for her is now acceptable. And same thing with this patient. So class 3, and we wanted to go ahead, maxillary advancement. That's the same patient that I didn't show with the shadow. It was just CBCT. Look at the result post-op. All right? I did not do facial scanner before because I didn't have it. I did it post-op. And you can see that we have major changes in the perinasal tissue. The whole centrofacial anatomy changed after maxillary advancement, and all the soft tissue, there is no injection of fillers in the cheek or anything. The nose, if you can look, the tip of projection is better. The nasal dorsum is now more straight. The nose has changed its shape because we understood what will happen, and we tried to control it during surgery to make it favorable rather than being unfavorable. So we understand now. Doing orthognathic surgery, it's not about moving the maxilla or moving the mandible and putting them into class 1 occlusion. Moving the maxilla and the mandible, it's an art where you have to align everything in a three-dimensional space. You have to advance the maxilla and the mandible together in a three-dimensional way and understand which kind of soft tissue changes will occur on the face. And believe me, those soft tissue changes are more significant than what we think. I'm using 3D surface imaging scanners in order to evaluate the soft tissue of the face. We have different kinds of soft tissue scanners of the face. There is a structured light, passive stereophotogrammetry, regular active photogrammetry, and then you have the mobile applications using the true in-depth camera from the iPhone X and forward. We have true depth camera, and there are softwares can take videos and construct 3D imaging from it. So these are the cameras from 5 to 7 years ago. We can see them. Prices, did I put them? Yeah, 13,000, 20,000 euros. So you can see it's expensive. These cameras came out this year. They are available in Kuwait, both of them. Now that camera, you have to take it, go around the patient face in order to capture the 3D imaging of the face. This camera, you don't have to move. The patient sits in. 6 cameras are simultaneously working. Single click in 2 seconds, you will capture a 3D image of the face. So the concept is the same, getting an accurate 3D image of the face. The one I have is this. I have the Vectra, which is also has 2 options, either 6 cameras and single shot, or single camera and you move around the patient to take the shots. It's all about what is the best in your hand. If you want the more affordable one, you can buy this. This camera, you can take 3 shots, right, left, forward. It has a laser on it. You focus the laser on the nose or on the cheek. It tells you there is a way to take pictures, and then it will be combined in a software, and then you have a 3D image. Or you can use mobile scanning applications where you have to buy them. These are 2 applications, for example. That application is called Bellus. Now, only the ones who have it from before have it, but now it is suspended. This one is available now. It's a French software. That one using the front camera of an iPhone, this one using the back camera. So you turn around the patient and then allow the images for about a minute so that you can construct a 3D image of the patient. That system used to be for free. Every image you do, you can export it for $1. And I think that is the reason it was too cheap. This one, I think you pay $1,000 a year, and then you use it for unlimited usage. And I have a publication comparing all of these cameras together, and it seems both of them work if you get your hand on a good camera to have a 3D image of the face with high quality. Then I have the 3D imaging of the face. I have the CBCT. I have the intraoral scan. I can combine all of them into a software where I can do the planning and come up with a treatment plan. Moving the maxilla, moving the mandible, creating the splint in between. That is the splint. You send it to the lab. The lab can printed. I don't send it to the lab. I print it myself. Sometimes I send it to the lab. And the 3D printer that we have is, for example, this one, very easy to use. It's enough to print surgical splints and surgical guides. You can print skulls. You can print mandibles, either for preparing for surgeries or for usage during surgery to align the upper and lower jaws together. And this is how it is. This is what you need. In fact, I print everything using the same printer. The cast, the cutting guide. And by cutting guide, for example, I'll tell you what is a cutting guide. For example, this patient comes in. She wants to have her chin advanced. So look at the left picture. I'm advancing the chin now using the software. The chin will come forward. Did you see that? So this is a simulation for the patient, and this is a simulation before and after. So that's how I'm going to advance the chin. Look at the picture on the left and the right. The left is pre-op. The right is simulation of surgery. Okay. Now she approves the case. I'm going to go ahead and create a cutting guide. Cutting guide, I want to advance the chin, 6 millimeter, tilt it a little bit, move it up, move it down. You're going to be playing with this. This is an art now. Now we're talking about an artistic handling of the STL file of the skull in order to achieve excellent outcome. Now, this is a patient that came in. What can we do? There's basically nothing. It's straightforward. You have to go back. You have to take the maxilla, take it up, take it back. There's a cranial base. Some people say it's not possible. No, it's possible. Trim the posterior part of the skull carefully, and this is a simulation. So this is simulation. This is not real. This is not real. Simulation. Look at the skull. It will go up and back to the skull base and remove every piece of bone carefully. It is safe to do that if you use the right steps. Mandible comes forward, the chin comes forward, and this is a simulation. Now the question comes, do you tell the patient? Do you show the patient? Yes, of course. I put it on an iPad. I ask the patient to sit. I show them. This is a skull. These are the movements I'm going to do. This is a simulation. What you're going to look. The question comes, is this going to be my face after surgery? And my answer is no. It will be better. My results, I guarantee it, it will be better because there is an element that is missing here. This is a software that does prediction. Now, if you have sagging of the soft tissue and pulling, during surgery, I can control that. There is a dimension that is not available here. During surgery, I can play with the muscles, pull them, raise them, suture them together, cross them to the other side. So always the results, I think they are better. Let's look here. So this is actual result before surgery, 3 months after surgery. Actual results. This is not a simulation. Patient came after surgery 3 months. I told her, come, we'll take a picture. Actual results. Actual results, smiling. Before surgery, 3 months after surgery. This is actual result. And you can use this technology in order to take the pre-op and the post-op, superimpose them on each other. Superimposition, superimposition. I'm looking at different part of the face. Blue means volume increase. That means if the chin is blue, that means the chin came forward. Yellow means the yellow volume decrease. Look here, there is volume decrease تحت الحجاب. Okay? Now, I didn't remove the hijab, خليته شيء natural. معناها تحت الحجاب there is volume decrease. So here, the volume decreased. The chin, volume decreased. In the front, volume increased. But look at the periorbital area. After surgery, the soft tissue changed, there is a decrease. There is a slimming of the face. And we saw that before. And if you superimpose, you can see الشفاف وهو post-op, الشادو مبين شلون الchin يلا قدام, how much it came forward. Sometimes it's hard to see given the shadow and the light when you evaluate the patient, but when you superimpose, everything will be clear. This is the case, Dr. Muhammad Qali, remember this case? You did the SARPI. We didn't do we did a MARPI. We didn't do surgical expansion of the maxilla. Dr. Muhammad Qali did MARPI procedure, non-surgical. After, I don't know, 4, 5, 6 months, we did correction of the asymmetry. Let's see, how do we did it? So the maxilla up, back, mandible, forward, correct the chin asymmetry. Simulation, simulation. This is not real, this is simulation. Simulation, I'm gonna move the maxilla up, tilt, move everything in a 3-dimensional shape, the mandible, the chin, everything, and this is a simulation. The patient تشوف الصور, we tell her the actual results should be, قولوا لي انتوا الحين, these are the actual results. Before surgery, 3 months after surgery. Actual results. Understanding the muscles, how I'm gonna move them. These are the actual results before and after surgery. Some areas I suture them more than the other in order to achieve good and better tightening. And if you look at the ما اشتغل الفيديو هذا. So let's look at the smiling before and after. Okay, actually before, after, 3 months after procedure, and we can see that there is significant change, and the soft tissue dynamic, you didn't see it in the simulation. Simulation كل شيء كان جامد. هني with the smiling, even though it is, she is in smile, the picture is not moving, بس تشوفون how dynamic it is, a picture, when you evaluate the soft tissue properly and the color and the depth. نفس الشيء تشوفوا الأصفر معناته decrease in volume. حتى هني ضعفت وهيها ضعف هني وهيها ضعف من تحت، من قدام we have increase in volume and projection. So orthognathic surgery is a 3-dimensional thing. هذا السليب apnea. خلينا نشوف شنو صار. sleep apnea simulation. Simulation. Maxilla forward, mandible forward, chin forward. شوفوا الشن الحين من تحت ما تغير وايد تحت، قاعد تشوفون شلون ما تغير الشن وايد، اللغلوق اللي تحت. خلينا نشوف الصج، دقيت عليه امس العصر الساعه 3 يا اللي صورته. فامس he came. So this is before surgery, this is 3 months after surgery. This is actual results from yesterday. After surgery 3 months. Okay, look at before, look at after. And look at the changes, even here has changes. منطقة pre-auricular area is slimmer. Orthognathic nowadays هذا smiling آخر واحد حاطه زين. Orthognathic surgery now it's an art, it's a science, it's an art, it's a 3-dimensional art that came to play, and I can enjoy it now because I have the technology that is available. We see it in the conferences, but now we can take it and utilize it in order to come up with great outcomes. There is something else called additive manufacturing. Now 3D printers. شنو عندنا من 3D printers؟ شنو نقدر نطبع؟ هذه الشغلات كلها مطبوعة بال 3D technology. زين، كلها مطبوعة 3D technology من metals, titanium, the implant, the bars, everything, even the acrylic is 3D printed. So many things that could be done. We can use titanium. We can use different kind of titanium, so solid titanium, titanium mesh, additively manufactured titanium. كل واحدة لها advantage، بس إن ميزتها إن نقدر نشكل الشكل اللي نبيه. additive manufacturing يعني نقطة نقطة تلزق ببعض إلى أن we have the right shape that we want. وأكل milling. Alright, let's go over the additive. أكو شيء اسمه peak implant. I will not talk about the peak implant. Peak معناتها polyurethric ketone. It's a polymer, but biocompatible. In this case, I'm not going to be talking about it. We can use the peak in order to replace defects. أو إذا بنحط malar implants, angle implants, cosmetic. يعني عندنا حلول يا إنه filler hyaluronic acid، أو نحط custom made implants، أو نحط مثلا silicone، whether silicone any part of the body. بس أنا ما أحب السيليكون لأن encapsulation حوالينا is not very good. You can create this in a 3-dimensional and put it in and fix it in, or you can use it in titanium as well. فالتكنولوجي هذه could be used in any place. Okay, let's go forward. Let's look at this. So how does that work? You have powders of titanium, and then you have laser. The laser centers them, melts them together, and they form a 3-dimensional shape. تيجي طريقتها laser والباودر تروح مع بعض. In reality شلون صاير شكله؟ إنزين عندنا موتور كذي، إنزين or a machine, and then you have the powder and you have the laser centering. خلني أطوف الفيديو شوي. قاعد تشوفون شلون تحته قاعد يصير ال 3-dimensional shape. هذا شكله اللي على اليمين آخر شيء. شوفوا شلون طريقته. It's being built والextra powder تتجمع و gets recycled again. So 3D technology now could be used. Now how can we use it in our field? إحنا عندنا مشكلة. With atrophic maxilla, we all, periodontists, surgeons, prosthodontists, we all suffer with these cases. Patient comes in with Coward and Howell advanced class, and you have complete bone loss. What can you do? Either we go and do complete bone grafting, the upper left picture, take bone from the hip or from calvarium or other parts of the body and reconstruct the maxilla altogether. This needs healing. In a population where everybody smokes, if he's not a smoker, he's diabetic. If he's not diabetic, he's not compliant. يعني ما أدري, I haven't seen the perfect patient for this case is still in Kuwait. يعني يا مدخن يا أنه شو اسمه doesn't want to carry the cost. Always there is an excuse to make this procedure difficult. Okay, it's not about the difficulty of the procedure. لا مساكين كلهم يقبلون. Okay, take bone from here, but everything else in that person is wrong. Smoker, diabetic, hypertensive, kidney failure. So this procedure is very cumbersome to the patients. Or you can do the zygomatic implants. هاي zygomatic. الحين هاي zygomatic اللي قاعد تشوفونه. Zygomatic, put it in, and then you follow the bone. يعني شوفوا تحت هاي الحالة شلون. Follow the bone to put it in a bad position. Now, you have complications of zygomatic implants. You have sinusitis, very commonly sinusitis. المشكلة الأولى هي sinusitis لأن الزيجوما داشة بالساينس. Whatever we do is we are going into the sinus. If this is a sinus معناتها عندنا implant طالع هني بنص الساينس. Okay, it's engaging in the floor, it's engaging بالزيجوما, but everything else it's in the sinus. Again, in your patient population, smoker, وما ندري 3 أنواع سجاير وفيب وشيشة و something else. With all of these smoking habits, the risk of sinusitis أعلى بعد من اللي كنا نشوفه برا. Now, subperiosteal implants هذه concept قديمة. Always we had the subperiosteal implants, but it was not custom. It was just adapted, sometimes take impression in the procedure, melt, you go to the lab, bend the titanium. But nowadays, it's different. It is custom made, in which you try to follow where there is bone in the maxilla, create areas where you can fix it with the screws. Then, يعني نبدي prosthetic rehabilitation تحتها step by step. وعندنا superstructure يا إنه يكون يعني Dolder or the other one, the meshed one, in order to have either porcelain fused to metal or the required prosthetic component after over it. شكل الامبلانت طبعا انا قاعد اتكلم عن الامبلانت اللي تحت شغل البراس احتاج براس to evaluate them to talk on that. But the implant here is segmented into 2 parts. كل بارت تصير كذي. فالبارت المنطقة الحمراء هي الوينجز تثبت على المكان اللي عندنا عظم, and then using the biggest screw possible, after knowing the direction of the screws, we fix them in. Then you have the basal looped frame, arms and posts, and based on that we can design our implants. كل implant شكلها غير الثاني. احنا نلحق الباترس, احنا نعرف هذا بالتراما بالأورثوغناتيك, هذا من كتب التراما. باترس of the face, الأحمر, البنفسجي, هذا قوة الأماكن هذه أعلى من الأماكن الثانية. الأماكن اللي بالنص you can go with your finger break the bone. The other areas, they are difficult. لازم with a hammer in order to break it. So we know some areas are difficult. You can put the zygomatic, that's why we put the zygomatic implant there. So you can put the PSI implants in this area and fix them there. وطبعا عندنا 3D evaluation نقدر نعرف هذا الأحمر نقول وين طريقة السكرو تدخل بالعظم in order to achieve the best stability. All right? So you can have a hybrid or double structure fixation on non-resorbing bone اللي هو piriform aperture with zygoma. عندنا CNC milt connections, the tolerance multi-0.02. عندنا crossfit screw connection with superstructure, either Stromer or السكرو هذا ال SRA. قد تكون Stromer, Noble Biocare or Astra. فأصمم أنا اللي فوق أقول له شنو اللي أبي الكونكشنز. أقول لهم مثلا Stromer, إنزين, and then we fabricate شو اسمه temporary team من الشركة. Then we have a platform switch, equigingival platform. Sometimes we go seprogingival على أساس يكون easier to clean. وطبعا polished and ready to be implanted. ونسوي finite element analysis. نحسب الفورس على كل abutment. مو أنا, الشركة تحسب وتدز لي report. Okay? Then this is how it is. They send it, you sterilize it, and then you do the surgery, you fix it in. خلينا نشوف حالتنا احنا اللي سويناها. إنزين, هذه الحالة مثلا عندنا severe bone loss, multiple attempt to do bone grafting to the maxilla. It didn't work. So we did CBCT. We're going to trim this area, the red one, and then we have to do the scanning protocol. This is important. You're not going to see that anywhere, so I want you to pay attention to this, because we're going to take and put fiduciary markers على أساس نقدر نسوي عليها CBCT or CT. والمشكلة هني إن how do you have good quality scanning. هني أنا حاط 5 أنواع مختلفة. كل الأنواع ال5 الموجودين بالماركت حاطهم على نفس الدنشر in order to scan them and know which one is better. بالCT scan كلهم زينين, بس intraoral scanning لا. You do the markers, you put them, there is 2.0 millimeter, there is 2.3, and هذول كل الأنواع اللي عندي إياهم, and then put them in a denture, and this is how it is. يعني بالنهاية we need good accurate scan. بس شوفوا السكان اللي فوق مو باين, الأبيض صاير شكله متغير, الأخضر أصلا صاير flat مو طالع. In reality, not all of the fiduciary markers are good. Some of them are good, some of them are difficult to scan. طبعا here I'm going to show you how to خلينا نشوف هذا اللي نمشي وياه. في صوت ولا ما في؟ Okay, so this is how we're going to scan them. Straightforward. So you put the fiduciary markers ونوزعها, and then you go ahead and scan them. So we know about this. Let's go to the next video. This is where we scanned all of them. شوفوا اللي فوق على اليسار. هذا اللي على اليسار آخر واحد صغير شفاف لونه شكله البير شفاف. وعندنا ثاني واحد شفاف. ثالث واحد لونه أزرق. الرابع واحد لونه أزرق. خامس واحد كنا لونه أبيض. each one of them is different. The color is different and the size is different. وكلهم قاعدين يباعون هذا fiduciary markers. Yes, but some of them are not capturable. إنزين. Some of them you cannot capture them no matter what you do. This one حطينا بودر عليه هذا عشان نصيده. شايفين الأبيض هذا شنو؟ هذا powder. Powder Johnson powder حطينا على الدنشر in order to scan them because شفاف ما راح ينصاد. In our test, the best was the CF23, 2.3 millimeter blue markers were the best. So that's why. شوف الحين هذا خلصنا منه، خلينا نشوف الأخير. حتى أحسن اثنين هما 2.0 أبيض لونه بيرل، بس إنه الخطأ نسبة الخطأ أعلى من هذا. هذا أحسن واحد بلو solid راديو اوبيك من برا ينصاد عن طريق الانترا اورال سكانرز اللي قاعد نستخدمهم اللي متوفرين عندنا. الثاني لا شويه ديفورمد، هذول احسن اثنين. الباجين بعد لا طالعين اللي يطلع شكله مثلث اللي يطلع شكله فلات. So I recommend you get this one and nothing else. I've tried them all in the market. واللي يبي يشوف يمرني الجامعه خليهم يشوفه ويجربه بنفسه، انا حاضر. Then we send the data to the company abroad. I use CAD skills in Belgium. Then we know هذول البنفسجي trajectories. These are where I'm going to put the screws. هذا هناك في عظم, so I do a trajectory for screw insertion. 3 معناته 6 3 3 6 and then do a design. Okay, يعني نصعد بالارم الى فوق. الحين نقدر نحط براغي نحسب اللينث مال كل برغي كم ويلنا cook recipe انه 11 ملم 13 11 13 7 9 كل مكان له طول برغي معين. الست يكون عندي بهالطريقة. انزين الحين وصل لي من المصنع، يوصل موديل ويوصل الامبلانت. امبلانت واحد ينحط on the right side وواحد ينحط on the left side. يتثبت بالعظم بالبراغي وفوقه نحط التمبرري and we fix it with in this case Straumann SRA screws. زين الحين هذا simulation of the surgery. انا ما بيحط وايد دم هني. ف if that's a patient sleeping you open incision you put the implants you make sure they fit and usually they fit good. وفوقه ناخذ التمبرري نحط التمبرري. زين alright now it fits good. Now your assistant doctor or the second surgeon in surgery can go ahead and make the holes and fix it. alright وكل واحدة فيهم لها طول. ف we know the upper left side according to the drawing 11 millimeter. ثاني واحدة 15 millimeter. Third one is 11 millimeter. So we know exactly what's happening. We know exactly how to fix each piece of bone. وخلينا نشوف إذا عندي post up picture. Let's go wait a second. إنزين this is okay. هذه post up at the end of the procedure. هالحالة يعني توه قاصينها. إنزين look at it. Fixed SRA. We took fat from the right to the left, so the soft tissue هذه كلها متغطية بالبكل fat pad. جبنا بكل fat pad من اليمين لليسار ربطناهم بالanterior nasal spine. Now the denture is fixed. إنزين بهالحالة دكتورة لميا تأكدت وياي بالعملية شافت كل شيء دشت حطت شو اسمه بعدين cover شو يسمونه هذا polymer. So patient's ready. And we have multiple cases. This is a more complex case. I'm not going to go through it, but I'm going to show you complex case. Maxilla and mandible and class 3 بعد مو بس كذي. It's a class 3. بس it is possible. If you do trimming تحت هذا يلنا trimming guide اللي تحت لون رمادي الأحمر يعني we're going to cut it. And this is how the patient is going to look. We do the evaluation of the bone. الحين نعرف وين في bone. عرفنا وين اكو bone. And then we can go ahead and do simulation. الحين هذا العملية الجاية هذه راح تكون اللي راح نسويها. We have the implants upper, lower. We know how they look. We have the denture upper, lower, and we have the screws for all of them, and we are ready to go. This is not possible to do without teamwork. It is absolutely not possible to do. I talk about this because I'm an artist. I'm in love with art, both digital art or non-digital art. So that's digital, that's the same person. إذا قاعد أسوي ابن سينا سويناه أول شيء digitally, taking everything digitally, assessing digital, and doing the sculpting digital على الآيباد وهذا. بس الحالة اللي سويتها using clay الطين وشغلة على شغلة وشغلة على شغلة to achieve the same outcome, it is different. شغلت هذا ولا لا؟ أوكي، الكلاي اللي سويته حق نفس الكاركتر انا مسوي هذا بس نفس الكاركتر اللي انا اشتغلت عليه بالكلاي is totally different. The way I evaluate is different. The way I evaluate the light is different. Although both of them are in my mind. Both of them مسويهم de novo. واحد digital واحد مسوي بيدي. The feeling for doing this is totally different than doing that. And this is always the case. Van Gogh هذا ابن سينا ترى مو شخصية ثانية. But this is Hippocrates, and this is the art that I recommend you all to get into. For orthognathic surgery, me and my colleague Dr. Mohammed Qali were launching a course for complete planning and techniques. It's a 6 hours stretch of a workshop. There is hands-on evaluation as well. We're going to go over how to evaluate and plan for orthognathic surgery. And soon also we are publishing our first book on orthognathic surgery. It's a comprehensive book to be sold on Amazon, both in Arabic and English. So this book is going to come out to light in the near future also with my colleague Dr. Mohammed Qali. It's going to have lots of QR codes and videos. Each chapter is explained in person-to-person format using QR codes with so many pictures in them. So thank you very much. It's been a pleasure being here among you guys, and it's been my utmost pleasure sharing this knowledge with you. You can take a picture of this. It has my own personal phone number. You can give me a call at any time should you have any questions. Thank you very much. I'm good on time? Yeah.
Yeah, you're good on time. Thank you for the informative lecture.
Any questions?
Any questions? No questions? Okay, Dr. Mohammed, we just want to present you with a certificate, if you don't mind.
Okay, good afternoon, everyone. Our lecturer for today is Dr. Ala Al-Musawi. He had a diploma of the American Board of Oral and Maxillofacial Surgery in 2006. He took his DDS from the University of Missouri, Kansas City in 1999. He had an internship in oral and maxillofacial surgery at University of Illinois at Chicago. He had his residency program in oral and maxillofacial surgery at the University of Illinois at Chicago. He was an assistant professor at Kuwait University, and he currently is a full-time consultant oral and maxillofacial surgeon at the MOH. Please welcome Dr. Ala Al-Musawi.
Assalamu alaikum. We have some technical difficulties until it works. First of all, thank you for the introduction. Thank you for giving me time to talk. It's been a while since I gave a lecture. Some of you here are students of mine 10 years back, maybe, and some of you don't know who I am. The subject that Dr. Muhammad was talking about is what made me go into oral maxillofacial surgery. The subject that I'm talking about was the least of my interest when I went into oral maxillofacial surgery. And here I am presenting on myofascial pain. The thing, myofascial pain, that was very appealing to us here on planet Earth is the increase of the patients after COVID. And it was not because of COVID itself. It was not because of the vaccination that everybody's trying to bring down and say that this is the reason. The reason for myofascial pain increase after COVID is because of stress. قلق. احنا دخلنا في مرحلة من حياتنا كان عندنا severe قلق. Staying at home, controlled by the government, when you can eat, when you can leave, when can you do this. People were scared of what's going to happen, what's next. And in my own clinic, I saw a 100-fold increase of number of patients that are complaining of myofascial pain. مقفايدة؟ This is PDF. Can we do it here? USB. ما قاعد يشتغل ها؟ Sorry for that. مو قاعد يقرأ. هذا بس الحين how can we send it to a laptop too? أنا سألته a couple of times and he said it's okay. tablet شنو كان؟ iPad, Apple. Anyhow, so we went through this issue. Patients were referred to my clinic more and more and more, complaining of facial pain. We don't need to see the slides. I can talk about it and it's enough. And the patients were complaining of more and more description of what they're feeling. They were having time more to speak about what's causing their pain. So they were going into details of what causes their pain and when does it happen and when does it start and when does it end. So I got interested even more. Patients were complaining of issues that before we did not see. They were complaining of symptoms that we did not hear them talk about, like squishing in their ears, like numbness on their face, like crawling things on their cheek. And it was ultimately all because of myofascial pain. The thing is, everybody compares, or they put them all together, patients that have temporomandibular joint disorder and patients that have myofascial pain. And they're completely different from each other. Myofascial pain is something temporary. Most of you guys have it. Some of you have it in other places beside the face, like your back, me, as an example. And then some of you will have it temporary in a time slot period, and then it disappears in your life. Temporomandibular joint disorder, or TMD, what is called temporomandibular joint disease, is when you have issues within the temporomandibular joint complex itself, which is the joint. And not all the patients that have myofascial pain have this issue, and vice versa. So when we examined these patients, the ones that came after COVID, most of them were having qalaq, and that was causing their pain. The patients that come to the clinic, usually that have myofascial pain, they are between the age of 14 and 34, and usually they are females, more than males. The reason for that, females more than males, I think is two things. One of them, females, they have a little bit delicate tendons, and that causes issues within the joint itself. Male patients, they don't have it. And females are qaliqeen more than males. They think about things more ahead. Males think about what they're going to do the day. Females, they think about future and all these things, and there's other things that come into play. So they are more thinking about life and all these things, and causes them to have more of muscular pain. So when we examined these patients, we saw that the best treatment for these patients is, number one, to calm them down. Pain is the way Allah subhanahu wa ta'ala gives you an alarm that there is something wrong. That's why you guys get panic when you have pain. And when you have pain in your facial complex, it's even worse, because when you have pain in the facial complex, it's very close to you. It's close to your brain, it's close to you personally. When you have pain in your toe, it's very far distant, so you don't really care about it that much. But when it's in your face, it's even scarier. So you go into this, back into, being qalaq at night, whether this thing is going to happen or what's going to happen. A lot of the patients that come to me, they are scared that this is cancer or other things. They heard patients before, they had pain in their face, and then it turned out to be a tumor. So anyhow, so we went, the thing is, with the pain itself, we found out that most of these myofascial pain is coming from two muscles. Of course, the patients, they complain about many pain, musculature in their complex, in their head and neck, but most of the pain is coming from two musculatures, which is the masseter muscle, which is the strongest muscle that closes your jaw, and the temporalis muscle. I should have had a slide that shows this, but you guys can go back to your imagination and just hear that. A masseter muscle is the strongest muscle that is within the jaw itself. The temporalis muscle, it is the biggest muscle that closes the jaw. And those two muscles, they are the ones that are getting affected more and more. Why do these patients have this pain? We did a study in Chicago and with the other colleagues, and we saw these patients, they have muscular spasm. And it's not necessarily clenching. Most of you guys will think about clenching, that the patient makes sounds with their teeth while they're grinding their teeth. But some of the musculature spasm was without clenching, without the teeth hitting each other. So, and the spasm was there, and the pain was ultimately manifested. I tell my patients, it's like you running the marathon at night. When you go to sleep, the muscle spasms more and more and more. Before, we thought that the brain stops when you're asleep. But now we found out that the brain waves are much higher when you are asleep. Your brain thinks in many dimensions when you're asleep. And that's why you have dreams and other things, and some people talk in their sleep. When you are awake, you are focused on the things that you're seeing in front of you. When you are asleep, the brain waves are so high. And if you have issues that are causing you to have nervousness, then the brain waves will have muscular spasm. And some of them are manifested in clinching. Some of them are manifested in grinding. Let's see if this works, inshallah. Yes. أهلين يا دكتور والله. It's responding here. Yeah, I'm sorry, it was not responding. Now it is. Anyhow, so we isolated the issue. The muscle is causing their pain. And some of these patients, they're coming to me and they're referred by you guys, by my colleagues that are not surgeons, for removing their wisdom teeth. And the wisdom teeth is innocent, without any infection, without any symptoms, without any issues. Patients that come to you and they're complaining pain in this area, it's not necessary, and you take an OPG and you see an impacted wisdom tooth, not necessarily the cause of it is the impacted wisdom tooth. Remember, if the wisdom tooth is severely impacted, then it's completely covered from being infected. And if the patient is not complaining from pain in that tooth itself, or when you touch around it, there is no pain, then the pain that they were complaining of is not necessarily pain from the musculature itself, from the tooth itself. But there are other issues. And then we think about what other issues can cause the pain. It's either muscle or nerve. And usually it is myofascial pain, and this is pain in the masseter muscle. So the guy that I trained with in Chicago, that was before the introduction of Botox in our armamentarium. We used to go and open up the area where the masseter muscle attaches itself to the zygomatic bone, and we used to cauterize it, completely burn the masseter muscle off the attachment to the bone. And you can imagine how painful that is after the surgery. It was very painful to the patient, but they recovered well. The pain was getting better after the surgical insult. When Botox was introduced, we started to use it cautiously. We were not very keen in using it because it's a temporary measure. The guys to use it for plastic surgery and other things, they jumped on it very quickly. It had a bad reputation in the beginning that everybody's using it and it's just for cosmetic reasons. So we were using it, but with very reserved use. And because of the temporary outcome of it too. I was not a believer in Botox when it first came out. But then, during the time when I started getting more and more involved in trying to control these issues, we used to get the patients, there were 14, 15 cases a month. And then during COVID or after COVID, they became 14, 15 patients a week. And then there are days that we were seeing only temporomandibular joint patients or only myofascial pain patients. So it was increasing more and more. So we had to go back and see. I had to go back and see, what can we do? How can we control it? So we started to use Botox more and more. The thing that I saw with Botox is that these patients, almost 100% of them became better from the first injection. Let's say 90% of them. I gave them the second dose, which is a week after, or sometimes 2. Almost 10% or the whole 100% became better. And for 6 months or 4 to 6 months, they were not coming back to the clinic. They were disappearing. 80% of them, we didn't see them again. 20% of them came back. Those 20% of them, when we treated them, 10% of them disappeared again. So I found out that in this case, yes, Botox is a temporary medication, but it was an ultimate permanent treatment for these patients. So I started to believe in Botox more and more. And it was much better than the alternative, which is the masseter tendinectomy, cutting the tendons of the masseter muscle. Now, of course, do we give Botox for every single patient that has pain in their muscle? No. The ultimate treatment for patients that have myofascial pain is and will remain forever the physical therapy, علاج طبيعي. And the ultimate physical therapy that you can provide for your patients is the physical therapy that he, or most of the time she, can provide or perform on herself by herself. Because you can send it to a physical therapist, and they do these great jobs with radiotherapy and heat and all these things that I don't really believe in. But the maximum opening of the jaw, that is the best physical therapy that you can provide these patients. So what we can do is teach them. I have taught patients to do physical therapy for themselves. I have taught housemaids to do for the elderly ladies. I have taught husbands, they love it, to do to their own wives, or vice versa, wives to her husbands, how to do the physical therapy. Because what I need is them to do the physical therapy twice a day for 3 weeks without non-stop. And there is nobody that is with his good mind that will go to a physical therapist twice a day, every day for 3 weeks. But they can do it at home. So physical therapy is the treatment for myofascial pain. But Botox helps. For those patients, I have had patients that are handicapped, that they cannot do the physical therapy. I had patients that they cannot perform anything that is painful to themselves, and they are in severe pain. أذكر واحد جابوا لي إياه في المستشفى دار الشفا، كان شايب جايبينه في عربانة، يعني he was in a gurney. كان كنا ربيانة من كثر he had so much pain, and he was demented. He cannot even tell you. But أهله يابوه لأنه كان يدرون, when they touch his face كان يصرخ ويصير عنده عوار. Finally. Of course, for the first time in my life, my daughter actually, Sarah, made these slides. That's why she's eager for them to start. And thank God now it is starting. So these patients, they could have severe pain that is detrimental to their life. They could have, going back to that old person, the old man, he was in his 80s. Now, in that case, I used Botox, heavier dosages, in the masseter temporalis muscle. The next week, he was a completely different person. Still demented, but not in a shrimp form. It was a normal person, and they were so happy. So Botox was very helpful. So we should go through many of these things. Okay. So when talking about pain, of course, Nutter, I tell my students, anatomy is the doorway to everything if you are thinking about surgery. My Nutter book was on my desk for the whole time of my studies during as a student or as a surgeon. Allah yarhamah. Nutter was a great guy because he was an artist, just like Dr. Muhammad, but he was an anatomist too. So he drew things in a way that we can never replicate it. So patients, when they have pain within the joint itself, within the complex, when you touch it here, they will feel like there is like needles or screwdriver going into their joint. They're completely different than the patient that they have pain that is all around the angle of the mandible. This is myofascial pain. And they're completely different than the patients that they have pain within the wisdom tooth area. Those are completely different patients, and you should recognize them. So we have talked about this. Some patients do have referred pain because of their muscular spasm. They do have referred pain. So they have muscle spasm, but the pain is somewhere else, like around their ears, but very, very rarely. Most of the patients, they do complain of neck pain too, and shoulder pain, and ear pain. 90% of my patients that come to my clinic are referred by the ENT, أنف وأذن وحنجرة doctors, because they go there. They think it's something wrong with their ears. And the good ENTs in Kuwait, they refer them out. They know that this is not their issue. The issue is somewhere else. And you guys have to know this. We are the dentist and the oral maxillofacial surgeons. We are the authority when it comes to facial anatomy. Nobody surpasses you in facial anatomy. حتى plastic surgeons. هذا كان عندي أنا committee في الوزارة وإحنا عندنا صار هواش في الموضوع. Nobody is an authority in facial anatomy more than you, and of course more than us as an oral maxillofacial surgeon. So we should decide what's injected and what's not, and they should follow. They didn't like that. They still look at us differently. So we have talked about these things, alhamdulillah. This is the masseter muscle when we used to go in and cut the masseter muscle. Even my daughter asked me, why did I have falafel, surat falafel for lecture? She doesn't know either. I was introduced to botulism, which is a food poisoning, when I came to Kuwait in the 90s. I was craving falafel. I had a falafel sandwich, and I spent 3-4 days in the ICU with botulism. That was my first introduction to Botox. Because from botulism, alhamdulillah, we don't have it anymore now. From botulism, مطاعم صاروا أنظف, we got Botox, and this is what we have. And I always use the actual Botox. There's other companies that come out, but nobody's like Botox. So this is the distribution. We said the biggest muscle and the strongest muscle, the pain is always there. And if you ask your patient to point at the finger, to point their finger at where's the pain mostly, they always will point at the middle of the masseter muscle. They will always put their finger right there. And you know that this is myofascial patient. Of course, when we do the injections, I do give a very heavy-duty Botox. It's much more concentrated than the guys from, of course, dermatology. They knew that this thing is helpful. Even neurosurgeons, one of my friends is using it. They know that it helps. But the thing is, they don't know the anatomy well. So most of you will go to a dermatologist. They know how to put the needle in their skin. And the skin does not penetrate all the way down to the musculature of muscles of mastication. They don't know this. They don't understand it. So they give a little bit of injections in the skin, and the patient doesn't get better. They gets a little bit better, and then it gets worse, and then they come back to me. So what I do is I'm the only one probably in Kuwait that injects from the inside, intraorally, because I cannot get to the masseter area, especially to the attachment to the zygoma, without injecting intraorally. And they go and some of the doctors, they are baffled why we do this. Of course, when we give this heavy duty or heavy dosage of Botox, the muscles of facial expression, and these are the things that give you beauty, and these are the wrinkles are caused by them, and this is what we use for cosmetic reasons. They're overlying these huge muscles of mastication. Those are very thin and very weak compared to their neighbors that I am injecting. So some of that Botox does seep out and touches a little bit of that muscles of facial expression. And the thing is, the most complicated thing that happens is when they smile. The patient smiles, he smiles, or she smiles, like she's not interested to smile. So the smile يخج شوية. ما أعرف شلون أقولها بالإنجليزي حتى. So there's one older lady, I gave her injection, and then she told me, I had a reception, it was عرس بنتي, and everybody was telling me why you're not so happy, you don't look happy. قلت لها تبين أكتب لك رسالة that I caused this? She said, تقول لا خلهم يورلون, أنا عوار راح. So this is what happens with Botox injection. Of course, we all know that Botox is only they say 6 months, but it is 3 to 6 months. I have one patient of mine that she comes every 3 months for the past 3 years or more, before COVID. So صار الحين 5 years. Every 3 months ما نعطيها موعد. أدش أقول ها صار 3 أشهر أطلع ساعتي تقول إيه. And we have to give her the Botox again because she is a severe clincher. She clinches to the point that she breaks acrylic thick night guards اللي احنا مسوين لهم إياها. Since we opened up the night guard issue, night guard, I tell my patients, is akaza. We don't give akaza for every person that has limping issues with their legs. I don't like to fabricate a night guard to every single patient because they have to be living with it for the rest of their life. And ما أدري أنتو شو أنا, I would not like to put something in my mouth every day and it's plasticky and then sleep with it. Especially if they have a partner, it's not appealing. So night guard, we use it when it's at most necessary. How am I doing on time? I'm okay? Good, excellent. So FDA, Botox, everybody asks why Botox, it's only used for cosmetics, why are you using it for muscle spasm? Originally, Botox was created, or they came up with it, is for patients that have nystagmus. They have issues with their eyes. Ophthalmologists or ocular plastics, they were using it to paralyze the muscles that are causing skewering of one of the eyes. So that's the label use of Botox. Everybody else is using Botox off-label. I do use it for patients that have severe salivation from their lingual gland, salivary gland. I do inject in it and it calms it down. And there were dermatologists injecting it in sweat glands, and it were reducing the severe sweating from armpits and all these things too. So it's all used off-label. We are all using it off-label. Complications are so rare. The most thing, alhamdulillah, I do inject, ما حد شفت أحد صار عنده botulism like me in the 90s. But there's very little. The complications are temporary. The ones that have issues with their smile, usually from my practice, it's only 14, 15 days, and then it becomes better. So complications are rare. Of course, other treatments, which are, as I said, the gold standard is physical therapy, treating these patients, not the Botox itself. Of course, Botox is used now for facial cosmetics, and the issue is the same, but I use it in much lesser dose because the muscle of mastication, the facial expression are much thinner and much weaker muscles. So we do play with it. Patients that have a gummy smile, I use it for them, but it's always temporary. After 6 months, they do have a gummy smile again. And the gummy smile, most of the time, like Mohammed said, is due to the position of the maxilla, and we impact the maxilla. But in certain cases, there are patients that have animated lips. انتوا تعرفون واحدة منهم أكيد, especially بنات عندهم أكثر من صبيان. When they smile, their lip is fine. When they over smile, تشوفون اللب مثل ستارة الرول, تروح فوق وتختفي اللب, يختفي اللب تماما. And this is not because of the position of the maxilla, but it is the position, the animation of the muscles. And that's why we inject Botox in the facial expression muscles that will calm that effect of muscles taking the lip way up high. So Botox versus surgical, أنا أقول حق المرضى صار like سحر. يعني قبل I schedule you for surgery, now you come in as you are talking. I inject you with Botox, تروحون البيت, no symptoms at all. The effect of Botox is for the muscle spasm is 4 hours to 4 days. So most of the patients, they get improved by the end of the night. And remember, the muscles of facial expression are always there, and if you mess with them, they can be devastating to the patients. So be careful as a patient, or be careful even as an injector. I know now, especially in England, wherever I go, I see injector clinics. هذا ما في أمريكا it will not fly, but في England أكو clinics that announce that they are injectors. Their doctors are injectors. ما أدري شنو هذا. But they are involved in injecting Botox or fillers. And by the way, our population, they think they are the same. Botox and fillers, they think that it is the same. When they see these رمضان مسلسلات وتشوفون الممثلات كل واحدة شفتها طالعة من السكرين, they think this is Botox. اكو شياب اقول له ترى اقدر اعطيك بوتوكس, يقول انا بوتوكس ليش؟ انا قدام عيال اقول له لا, بوتوكس is not a filler. كل our population. او عيوزه ذاك اليوم اقول لها ابى احط لك بوتوكس يمكن يصير احسن, عيالها قاعد يضحكون وراها, يقول ايه هذه, ايه حط لها بوتوكس نزوجها. So they think it's a filler, and you have to distinguish between a filler and a Botox to them all the time. And a filler is not a Botox. We use it because, you know, muscles of facial expression. By the way, these are the only muscles in our body that attaches to the skin. We don't even have animals that have that. It's only humans that have it. And that's why every single thing that these muscles do, it explains something. خلص يمكن شو اسمه اشتراك. Every single muscle movement in the face expresses something to your fellow human being that's looking at your face. You could smile, and your smile could be a little bit crooked, and he knows that you're lying. Or you can smile, and your smile is so high, and he knows that you are sincere, and so on and so forth. Our brain calculates all these things. So when it comes to cosmetics, we have to think, what are the muscles that are causing the wrinkles, like the crow foot and all these things, and what are the muscles that are going to pull while we are knocking out another one. And these are the ones that pull and give you that youthful look, but it's always temporary. One thing that you should take from this lecture too, or I should mention it, is some people, like went back and said it's botulism. Botulism is so bad, by the way. It's so bad they named it after the bacteria. أنا ما أعرف why the poisoning food that is named after the bacteria that causes it. But when Botox is injected in a continuous fashion, especially if it's used within 3 weeks or 4 weeks continuously, some patients do develop antibodies to it because it's a toxin and your body wants to get rid of it. So if you inject a lot and it's within the same period of time, it's shown that if it's within 3 months, it's fine. But if you do it within these 3 months, multiple insults with Botox, they do develop antibodies, and they will be immune to Botox. Some of them temporarily, most of the time. I'm not going to talk about the cosmetic issues because this is not the issue that we have done. Side effects, أكو واحد من 100 مريض يقول لك صار عندي عوار في مكان أو صار pain, or sometimes a small little hematoma, especially if we are aggressive. I still use the very small TP syringes that are really rarely cause any issues. So هذا issues that could happen. I think we managed, even though the slides were not working. And thanks to Sarah, we managed to have slides. But if you guys have any questions, I'm always available. And thank you very much.
Now the honor of Dr. Ala Al-Musawi. Please, Doctor. There will be lunch in Masila too. You can go now. Okay. At 2:30. Okay.
We can see multiple changes. We can see hair nose. This is before and this is after. This is 10 years. We can see hair nose is tilted up, which means that she had kind of rhinoplasty. Eyebrows change in the position. The shape of the face was round, and now here is oval. The chin augmented. Cheek, mid-face changed, which probably mean that she had minimal invasive facelift, buccal fat pad removal, some kind of botox on the masseter. Also Clooney, he denied recently in the BBC interviews that I have not did any kind of facial cosmetic surgery. In my opinion, if Clooney has had any facelift surgery, it's likely been minimal, like mini facelift surgery. So that would allow him maintain his aging appearance while still achieving a somewhat youthful look. So it's important to note that unless public figure, they didn't say that we did some kind of a procedure, cosmetic procedure. Any speculation remain just like that, speculation. So what is a facelift? Facelift is a surgical procedure performed to reduce, not remove, reduce sign of aging in the area of the face and neck that will give the patient youthful look. It's not just surgical procedure. It's a comprehensive process, intertwining physical, mental, psychological elements to achieve enhancement and personal well-being. Anatomy, it's part of our job. So if you don't know anatomy, don't put your hand on any case. So understanding facial anatomy is crucial for successful of any surgical procedure in head and neck. That allows surgeon to precisely planning the incision and how they manipulate the soft tissue. The anatomy of the face started with the skin, down deep the bone. Between them, fascia, ligament, muscles supplied by nervous system, vascular system. So understanding the relationship between these structures also is crucial. That will optimize your result, will reduce the risk of complication during the procedure. Understanding of skin type, skin texture, skin thickness, skin elasticity, all of these influence the surgical approach. Post-operative care, also its impact in the surgical outcome. We have this classification introduced by Fitzpatrick. He classified the skin from 1 to 6. 1, the European people with very white, blue skin color, red hair, they are tendencies to have minimal scar appearance. Opposite is the black. They are high risk to perform scarring. So you have to understand the skin type and how you deal with this kind of cases. In our face, there are two compartments of fat, and then we have a deep and then a superficial. The superficial one is infraorbital, nasolabial, cheek, which is medial, lateral, middle, and then a superior jowl, inferior jowl. The deeper one, buccal fat, deep cheek, medial suborbicularis, oculi, and lateral one. These fat are separated by septum, and the septum with aging become less taut, so it will sag. So this is an important part in aging process. Fascia. In our head and neck, there are two types of fascia, superficial and deep fascia. In facelift surgery, we always deal with the superficial one, okay? It's a fibrotic connective tissue, provides support to the muscle, facial muscle, and protection to the vital structure beneath. SMAS, known as superficial mucoperiosteal system, this is the target in facelift surgery. If you reach this structure, then you are in perfect plane. With the age, SMAS will become loose and lost its elasticity, and that led to form wrinkles, jowls, skin sagging. In our face, again, there are ligaments. We have two kinds of ligament extended from the bone to the skin or from deep fascia to the skin. It provides support. It's our target during the surgery. We have to remove them so we can pull the tissue to the normal position. And understanding the anatomy of the position, it will help in minimize the risk of facial nerve injury. This is the zygomatic ligament, which is positioned 5 centimeters anterior from the tragus. As I said, the relationship is important. You have to understand the anatomy, where is the facial nerve during releasing the retaining ligament. Example, zygomatic facial branch of facial nerve lie just inferior and beneath the zygomatic ligament. Facial nerve, we have to have a knowledge about the facial nerve, from where it exists, usually the branches, course, and what supplying structure. That knowledge will be essential to avoid any injury. Two common structure, mostly or commonly injured during the surgery. Understanding the position, marking the position will decrease the risk. Greater auricular nerve, we can mark it by McKinney points or air points, which is 6.5 centimeter to the sternocleidomastoid in the middle. This is the area of the greater auricular nerve. It gives a supply to the ear and external canal. Another risky structure is the external jugular vein, which is also in the middle of the sternocleidomastoid anteriorly and move obliquely. I guess, Shabab, most of you know who's this guy. He's a football player, famous Modric. What happened to his face? This is before and this is after. We can see the aging, how aging affects his face. So what happened to him? Changes occur related to the volume loss. Why happen? Because of fat atrophy, okay? And skin elasticity reduced because reduction of production, elastin, and collagen. Bone resorption, which is an essential bone resorption that happened to the face with aging. It's a natural, so it affects the contour of the face. Reduction of the muscle tone also led to muscle atrophy. All of these, with the action of gravity, will form jowl, skin fat shifting, and wrinkles. So what is the stigmata of the face? What's happened to the face? So here we can see in the upper third, it's increase in length because of back shift of the hairline and down drifting of the eyebrow. Wrinkles in the forehead, wrinkles in the glabella. We have hooding of the lateral eyebrow. We have tonsils. Also, there is a tear trough, loss of elasticity, changes in the nose, tonsils to the tip of the nose, widening of the ala, long or lengthening of the nose, deepening of nasolabial, increasing and thinning of the lip, jowls formation. We have also bands of the neck. So there is a lot of changes happen to the face. So understanding these changes, okay, it will be a key factor for better treatment option. For preparation of any surgical case, usually it starts with an initial consultation. It's a fundamental step. You have to listen to the patient carefully, understand their motivations, their desire, and based on that, you can understand the realistic of the patient. Is it real or is it over? Okay. After that, we go through the evaluation, clinical and radiographical in some cases, like cases with the fillers. I always do ultrasound, MRI to detect this area. And then we design our treatment, schedule the surgery. Who's candidate? The ideal candidate, good health, expectation realistic, they have significant laxity of the skin. Okay, so any patient away from these is not ideal. Now, some cases contraindicated, and you have to take care of these, like cases of uncontrolled diabetes mellitus. They have risk of wound dehiscence. Patient with cardiovascular, and they are on anticoagulant. Patient cannot stop the anticoagulant. They are contraindicated. Cases with vascular collagen disease, like a lupus, no surgery. There's a relatively cases you can do, like a smoker. You can stop for 3 weeks. Patient on anticoagulant, but they can stop it, so you can stop it for 3 weeks. Patient on herbal supplement, they have to stop it because it increases the bleeding tendency. Patient with Accutane, which used for acne treatment. Never put your hand on this patient until they stop it for 1 year or 1.5 years. Okay, it's highly risky because it works on the pilosebaceous unit. Evaluation, so patient should evaluate it from the frontal, lateral views, document general outline, including forms, shapes, height, width, asymmetry by comparing right to left, facial proportion, aesthetic harmony, how patient it look on your eyes. Is it natural? Is it a beauty or not? Is there any injected material on inside her face or no? Is there irregularity? Is there a history of infection in the face? All these should be documented. Sign of aging, as we said before, we have to document. This is a useful classification by Didot. He classified the neck deformity and what exactly the most appropriate cervicofacial reticectomy surgery. So we can see normal. Here there is some laxity in the skin, so just need for tightening by surgical or non-surgical methods. Here we have fat, so we need to do liposuction. In this case, there are banding, so we need to do plasmoplasty. In this case, we have a problem in the chin, so it's a skeletal problem. So we have to do orthognathic or genioplasty. In this situation, the last one, there is an abnormal position of the hyoid, which is low, inferior, anterior. So we need to do suspension to the hyoid bone. This is one of the cases. I performed an orthognathic to her. She presented complaining of submental. I don't like my submental fullness. So during the examination, the problem is not in the skin. The problem is in the jaw position. So I did an orthognathic, and this is the immediate result post the surgery. So we have to consider exactly the patient problem and what they concern and how to deliver it in a proper position. Utilizing forms, this is my form. Utilizing the form will help you in systematically evaluate the case without losing data. It's a time efficiency, accurate data collection. Photographs, it should be documented as a baseline for the patient, feature at the time of a presentation and the progression during the healing. Now in the second stage, we have to call the patient back, we review the data, tell the patient that this is the situation, this is the diagnosis, and this is the treatment plan, and we have to explain how the treatment plan for this patient. The treatment plan for this patient, it should be started with explanation what type of surgery I will provide, what kind of facelift. We have a multiple type of facelift. What is the indication? What is the incision site? So this is one of my cases. I did the minimal invasive, so it was just for the lower part. So I design it to the patient before we go to the surgery or before decide to go for the surgery. And I always asking the feedback. She told me, I don't like this area. I don't need scar. I need it hidden by the hair. I told her, yes, we can do it, but this is one of the options. Depend on many factors. So discussion is important, okay? And after that, if you decide to take a surgery, you should note everything in the charts. It's a medical illegal, okay? Write everything. Patient said blood, patient said like this, I said like this. Right, because when it's go to the court, everything is done, okay? So it's an important to document and consent the patient for the surgery. We have several types of facelifts. However, I will just concentrate on what I usually do, which is the modern surgery, and this is the trend in the field of facial cosmetic surgery. We have the traditional one, which is the old and the basis of other facelifts came, SMAS, deep, and mini facelift. So step by step, we start with the surgical marking. Typically begin for the incision, okay? Patient should marking the incision line in a standing position, not in the supine position, because of the accuracy of the incision line. And we know that when a patient is supine, the gravity will affect the accuracy of the marking. There are an important marking, we have to design it. We have the surgical marking side, okay? We have to place on the vital structure, like greater auricular. We have to design the course of temporal nerve, which is Pittingai's line, 0.5 from here to 1.5 from here, and you place a line. And you also place a line for the entry in deep case from lateral canthus down to the angle. Jaw line, you have to also circle the area of the attachment of the ligament, mandibular, and zygomatic. So all of these should mark before take the patient to the OT. Incision design can be varied depending on the individual anatomy, gender, amount of skin that need to excise, and type of facelift. Now, as a standard, when we do our cut, it should be oblique to the skin and perpendicular to the hair. So we will preserve some follicles that will help in the future regrow and hide the scar. Starting in the temporal, we have to design. We have in the temporal hair, and we have in the temporal tuft, okay? So decision depends on many factors. One of the factor is amount of skin. If we have too much amount of excess skin, then we have to do it here in the tuft, because you don't want to pull all the hair back, and it will give a natural look, okay? So a patient like a male and have a beard or long sideburns, we usually cannot put the incision down here, so we take it to the temporal area. If receding of the hair, and you measure from lateral eyebrow to the hairline, if it's more than 4 centimeters, that means there is a hair receding, so you have to perform the tuft temporal, okay? Now, after we finish from the temporal, we go down to the pretracheal. We have 3 places of the incision. We have the helical attachment, tracheal, and loop. Okay, so here we just follow the natural curvature of the helical, and then we go to the tracheal. So tracheal, we have 2 types of incision. We have a pretracheal and we have posttracheal. So decision of making pretracheal or posttracheal related to also factors. When you put it on the posttracheal, it should be on the apex, okay? Not inside, because the fold will give a natural shape. So you have to put it just in the apex. Now, all females indicate for the posttracheal, pretracheal for the male, because you don't want to pull the beards to the ear, okay? So this is commonly why we put anterior or posterior to the tracheal. Now, after we complete the tracheal incision, there's a transition movement from tracheal to the ear loop. So we have 2 types of incision. You just follow the curvature, or you do right angle, okay, like a step. I usually prefer the step. It will preserve the natural depression of this structure. And then after that, we go to the loop. There is a sulcus. Between the sulcus, we have to do the cuts. So we 2 milli from the sulcus down, so we will preserve the sulcus. And then posteriorly, we have 2 types. We have onto the concha or on the sulcus. again, depend on the excess of the skin. If it's too much skin, you have to put it inside the hair. Too much, we have to do it as a trichophic, or less, then you have to take it to the occipital. Again, here we have to place it, the scalp incision, we have to place it in the hidden area, which is the maximum curvature of the pinna. Flap preparation, we have to inject our anesthetic solution, tumescent solution, so it come just below the skin in subcutaneous area, and you inject your tumescent. It will help in hydrodissection. It will make dissection easy, and it will control most of the bleeding. So usually we inject 75 from right side, 75 ml left side, and 50 in the submental area. Using a blunt liposuction will help in easy infiltration of the anesthetic solution, and also it will dissect the area. After that, we start with flap reflection. So with a sharp 15 blade, we start to dissect 2 to 3 milli, and then we complete it with the facelift scissor. From the tragal, we have to go until 5 centimeter. Down, we have to go until 1.5 centimeter from the commissioner. And then we have this mass. And this is our target area. Okay? I will not talk now about this mass because I have to talk later. And then skin redraping. It's, I always say, measure twice, cut once. It's a very critical stage. If you do any mistake in this stage, scar will show. So this is what make a difference between surgeon results. So take your time, measure, do your cut minimally, and be sure that you are doing all of these in perfect way. So it needs highly and advanced skills and knowledge. So after we finish with the SMAS, so we redrape the skin, we see any dimple, we correct it, and then we start to pull the upper part, the temporal part, we do a back cut, suturing, then we go to the posterior, the same back cut, suturing. Now after that, we will see that the ear is hidden beneath the skin. So there is a critical point. So we have to follow the helical rim, and we stop just on the caudal of helix. Don't go down, because if you go down, you will make a long incision down here in the neck. So it's an important. And then after that, you do your meticulous shaping and then suturing. Now, the facelift types, we have superficial or the traditional, which is the basis of facelift techniques. It's introduced by Lexer in 1916. So he just do an undermining, incision, undermining, extensive undermining, redrape, cutting, suturing, and that's it. Okay. But the disadvantage is it's ineffective for the deep tissue sagging. Patient will be stretched, so it will give distorted of facial shape. It's return easily with the time, so we lose the effect of the technique. SMAS, this is the common facelift procedure. It's developed by Miles in 1976. The target, as we said, is the SMAS. We lift the SMAS, we tight the SMAS, so all the soft tissue will be tightened. So how we manage the SMAS? We have 3 types of management to the SMAS. So SMAS, we do application, we fold on it and then suture it, or we do imbrication, we cut, pull, and overlap suturing, or we cut and then bring the two edges together. I always prefer this mastectomy, which is this. So we just cut and then we remove some mass. Why I like this? Because sometimes with a case of infected filler, there is a distortion of this mass. I need to get some soft tissue. So I can use it with correction of the defect inside the face. So as I said, this is this mass, and we can plan our cuts. From here, we just palpate where is the zygomatic arch. Down, we do our line like a 7 or inverted L, and then we go down to the angle, or we sometimes extend if we need to get some platysma. So this is the shape, and this is the cut. We cut our mastectomy, and then we just release mass like 5 to 4, 5 milli, just to have ability to pull the mass back. And after that, the vector, which is important. So the vector of movement should be parallel to the nasolabial, so we have to pull up. We don't make it in the wrong way, otherwise it will not lift the nasolabial. So this is the first suture, 2.0 vicryl, pull everything up, and this is the multiple sutures. Then you have to close it, and we can see after we finish the procedure. And this is the patient. She presents with fullness, submental cheek, all of this area sagging, and this is here after 4 months. Modification, we have a lateral mastectomy. Instead we go from the preauricular, we go directly anterior from lateral canthus to the angle where the mass is changed from fixed to mobile. And the target is this area and the anterior border of the parotid. So you just do incision, pull, and then suture. This is the case. We can see multiple. So this is the direction. This is the incision part. This is the direction of vector. This is my entry point from SMAS. This is the other side, and we can see the fullness of the submental and jowls. This is the adequate thickness of flap, skin flap, which should be like a 5 millimeter translucence and appearance. Now this is filler I removed. This is the lateral mastectomy, and this is the time of redraping. Now we can see the patient. This is immediately post-op, and this is like 10 days after I removed these sutures. You can see how changes in the jawline. Extended mass, it's extensive surgery. We go above the arch, dissect until the lateral canthus, anteriorly to the nasal, down to the mid of the neck. It's really extensive, and the advantage it gives 2 vectors, so you can pull in 2 vectors. It will improve the face. However, its chance damage to the temporal nerve is so high. Deep plane. This is mostly trend now. Everyone's saying I do deep, 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 deep. So this is the deep. It's actually the same to the lateral extension, but we dissect down. So the way is the same. We do the incision, reflecting. We marked our direction of the entry between the flexible or mobile spasm. This is the mobile one, and this is the fixed. If you do like this, you will see it's here is fixed, but here is the mobile. So the target is this area. It's introduced by Sam Hamra in 1984, And as I said, he addressed the mobile one. So as we said, it's incision, then dissection, subcutaneous to the plasma, and then platysma, and we deep dissection, release the cervical, and then we go to the elevation and suturing. Now we can see the difference. This is this mass, and we can see the higher or extended, the traditional, and we can see the deep plane entry. So we go directly down to here. The important part here that in deep plane you have to release all ligaments in the face, facial and cervical. If you didn't remove it or release it, then probably the action of movement or traction vector will be not an optimal. So as I said, we have to release all of these retained ligament. We have to pull all segments, mid-face segment in one vector, 60 degree, and we pull the platysma back to the mastoid fascia. Now this is one case of deep plane. We can see the entry point from the lateral canthus to the angle. This is the incision, and this is the Bettingey's line, where is the temporal facial nerve course. Neck, adequate thickness of the skin flap, and here is our area for the incision. We can see the incision, starting of the incision of the SMAS, and we just go deep above the facial muscle, above the zygomatic major, above the orbicularis oris. If you go deep, then risk of injury to the buccal is high and zygomatic. So after that, we dissect vertically. We don't dissect horizontally, we dissect vertically to prevent any damage to the nerve. And after that, we use a dissection, finger dissection. We go to the pre-zygomatic fossa down to the nasal facial fold. So we move all of these. We be sure that it's free. And if there's any ligament, especially the temporal one, we can detect it, we remove it, and again, we be sure that all the segment is free and released. After that, we take, we do the cut for the platysma, so we cut from down. We cut from down, pull back, and then suture to the mastoid. And then we suture with the 5 to 6 sutures to the fixed SMAS. This is the case, and this is the final result. We have a mini facelift. Many facelift recommend for young with a minimal excess of skin. It's minimal invasive. We can do it under local with a sedation. And we can do it for targeting one area up or down. Now, it's less complication, but the efficiency, how much is the efficient of the procedure is still, but most of people, they are doing the mini facelift, and I recommend it in such cases. Now, complication, every surgery has a complication. We have the most common complication is a hematoma, 15% can happen. We have massive, we have minimal. You done? 5? Okay. We have minimal or massive. Massive, we have to take patient to the OT. Minimal, we can do it in the clinic. Nerve injury, most common, the greater auricular. However, if facial nerve injured happen, there will be for mandibular, and then followed by the buccal, temporal, and then buccal. stuffing of the tissue. If there's any unrecognized hematoma or untreated hematoma, can happen, and mostly happen in the post-auricular because of the thin flap of the skin, and the supplies depend from the distal segment. We have scars like this, hypertrophic. We have an ear deformity as a complication, parotid, some cases. So all of this complication can happen. Post-operative, as post-operative, but the important is the lighter dress we have to place. Patient should not flex his neck yet. So we don't need patient to place any pillow under his head. Back sutures removed between 7 to 10 days. And the key sutures, I always keep them for 14 days. Patient can go back to the work after 3 weeks. Physical activity like yoga or stretching can be started after 4 weeks. So heavy after 6 weeks. This is one of the challenging case. I treat her. She had a history of surgery outside of Kuwait, and she presented with a ugly, hypertrophic, pixie ear. Still, there's some areas didn't lifted. So the indication of deep facial left is for such cases. So we can see the difference, This is after, before, it was obvious. However, she still have a deformity on the tragal. I gave her an option to do a surgery, correct it, but she's happy now with the result. So staying up to date, that happened by reading, updating on the new technology and new techniques, attend conferences, take advanced courses to improve your skills. Thank you for time and for attention. By the way, this is the Abraham Oka, the guy I take training with him during my presentation in Sao Paulo. Thank you very much.
Thank you, Dr. Ahmed, for your informative lecture. Now I'd like to open the floor for any questions. If anybody has any questions. Dr. Ahmed, I have a question. If someone is interested in pursuing the field that you're doing, how would they go about what pathway should they take?
Okay, so as you know, it's a purely cosmetic surgery. So in the government, we do it for specific cases. We do it for the cases with infected filler. So most of my cases I did, all of them, they have fillers in the face. But in the private, yes, we can do it in the private. But again, dealing with such cases, it's not an easy. I recognize the advice of my mentor, Dr. Abraham. He told me, don't push yourself with the deeper plane or aggressive. Start with a minimal. And with the time, you will understand your techniques, how you meticulously deal with the soft tissue. And after that, go deep. So it's not an easy. Most of the cases, unfortunately, because our style of life come with the complication like the scars and all of this. Expectation is an important. So you have to realize that what exactly I can provide you. I should give you, in the definition I said, it's reducing, not removing. So some patients are coming to me saying, doctor, I want to be like the filter in the snap. How come? And this is, it's a red flag. A patient say like this, push her away. Don't do any procedure.
They have to be realistic.
Exactly.
Okay, thank you very much for your presentation. And we'd like to provide you with a small token of our appreciation.
Thank you very much. Thank you.
Okay, I'd like to invite everyone to go to the opening ceremony. It's in Badriya Hall downstairs. So please make your way down. Thank you. Good evening, everyone. So thank you for joining us for our last session this evening. So today we have Dr. Yaqub Al-Abo. He is a assistant professor in the Kuwait University in the Department of Dental Practice. He is also a diplomat of the American Board of General Dentistry and also a diplomat of the Oral Facial Pain. He will be joined this evening by Dr. Muhammad Anous. He's a consultant in oral maxillofacial surgery and he's working in Farwaniya Hospital. So please, if we are ready, we're going to start this evening. My name is Fatma Sarraf and I'll be joined by Dr. Razan Al-Hajri for this evening for the chair session. Doctor, you have the floor.
Assalamu alaikum. First and foremost, Dr. Mahmoud and I want to thank you for being in here. It's the last session of the day, and it's the end of the day. It was a long day. Instead of going home, getting some rest or having fun for the weekend, you guys made it in here. So we really appreciate it. Not just that, you guys are taking your time and effort to be in the conference during the weekend. This is a good thing. This is a testament to your dedication toward enhancing the quality of dental care in Kuwait, because you want to be on top of the most recent dental knowledge and the evidence-based dentistry. And that's how we grow our community. So let's keep our dental community in the best shape with the best knowledge to deliver the best treatment to the patient. As you can see, the topic will be temporomandibular disorders management, but this is impossible to cover it in only less than an hour. So first we're going to give a brief introduction to this topic, and then we'll discuss a clinical case that's the most common TMD condition, and we'll go through it, and we'll show you how at the beginning, if the case is acute, the treatment would be really simple. It could be patient education, for example, but if the case became chronic, and that chronicity can be in the TMJ complex, like more deterioration, then we might end up needing a surgery, like total joint replacement. Or the chronicity can be the central nervous system, like, for example, cortical plasticity, and then you need centrally acting medication to control these conditions, like serotonin reuptake inhibitors. And once you reach that level, then the management of the case would be really complex, and the outcome won't be that promising. So the key message is, the earlier the management, the easier it is, and the better the outcome. And we'll start with brief prevalence of the disease. Looking at all these epidemiological studies, and looking at this few meta-analysis and systematic review, according to these numbers, if I examine 10 people from the audience, how many of these 10 will have signs and symptoms of TMD, according to this epidemiological evidence? Any guess? Any number out of 10? 7? No, it's 3. So 30%. Like the average in any given population is the third of the population. So it's really common. And as you can see, the age is middle age from 20 to 40. And like for gender, it's female, more prominent, like around, it's like the ratio 3 to 1. Okay, can I apply this number to the Kuwaiti population? Does it apply to the Kuwaiti population? Well, there is one study done by our colleague Kuwait University where they examined around 200 patients randomly. They are coming for dental examination and they did TMJ examination. And guess what's the percentage of people having signs and symptoms out of these 200? It was 27%. So it's close numbers, around this number, okay? So it's really common. There's another study we are conducting still. I didn't publish it yet. What we're doing, we're making it like bigger sample to avoid the errors for the previous study, more than 1,000 patients. And we're focusing on adolescents. We know the most common age is 20 to 40, but what about teenagers? Do they have that TMD symptoms or not? Because if it is, we need to spread awareness about it for earlier management to prevent complication when they get older. And hopefully once we publish it, we'll share it with you. Okay, what's the classification of TMJ disorders? You can see there is a long list. To simplify it, we can divide these conditions into 3 main categories. One is myogenic, that means affecting the muscles, like in the condition of myalgia and myofascial pain. And the other is arthrogenic, that means it's affecting the part of intra-articular complex, like affecting the disc, like in disc displacement with reduction or without reduction, or affecting the condyle, like in idiopathic condylar resorption, or osteoarthrosis, and so on. And the last one is headache attributed to TMD. And these diagnostic criteria was established in 1992 by the IIDR, and the point of it, so all the clinician and the researchers would have consistency in diagnosis. So, and then once we have consistency, then the treatment that we study can be validated. So that's the point of having diagnostic criteria. And you can see after the diagnostic criteria was established, then this field became more organized. And it's easier to diagnose the case and easier to assess. Why? Because they came up with a special examination form for the clinic, and also they have diagnostic decision tree. You can that can help you come up with the diagnosis. So comparing to like 10 years ago, the area of TMJ disorder wasn't that organized. That's one benefit of having diagnostic criteria. And also in 2020, another diagnostic criteria was established. But this one is ICOB, International Classification for Orofacial Pain. So instead of only focusing on TMD, there are other orofacial conditions, orofacial pain conditions, and now they included in this diagnostic criteria to be broader, okay, and for the same purpose. And the question, do I need to know all these diagnosis criteria? And in TMD, we all think, oh, it's simple, صح? Yeah, muscle, yeah, joint. So is it that simple? Can I go ahead and treat any condition if it's like any TMD related? Well, like diagnosis is really important. It's the most important part in our field. يعني imagine we are dentists, صح? يعني تخيل patient comes to you with maxillary molar pain. You think, oh, this tooth is painful, I need to do root canal treatment. However, the diagnosis was maxillary sinusitis. Then you did an RCT on vital tooth. So we call this what? Mistreatment. We call it iatrogenic harm. فأنت you did what? Malpractice. تخيل. All of this because of what? Misdiagnosis. Yeah, and you one step, the first important step, you missed it, then you're screwed. So that's why diagnosis is really important in our field. So yes, we need to know the diagnostic criteria if you want to take care of the TMJ disorders. And the question is that we have to take care of it as a dentist. When we graduate from dental school, do we have the basic knowledge to deal with the or at least the simple cases of TMD? Yeah, this is speculation. How would I know? Of course, you run a study, صح? فهذا we're doing multiple studies الحين. Will point of it to collect the information if the recently graduated dentist, do they have enough information or not? So one of the study, we're doing retrospective study regarding the pre-dental clinic, if they can manage simple cases. And so many other studies regarding collecting the information for the senior dental student, do they have the information or not? And once so far the preliminary data is not promising. And it's not only from Kuwait University, I'm collaborating with other schools, as you can see, Duke University, University of Toronto, ميغيل, جامعة قطر والشارجة. كلنا نبي نشوف, do these institutes do they give enough information for the students so they will be able to handle simple TMD cases? If not, we are coming up with a simple lecture form and video demonstration and examination form so the student can follow. It's really simple. So at least they can know how to examine and diagnose the simple cases of TMJ disorders. And hopefully once we come up with the result, we'll share it with you. And that's how we spread awareness about TMD for the public. Of course, we start with where? With the dental schools. انزين خلينا ناخذ this clinical case. 34-year-old female patient present to the clinic with I have pain, most common pain. I have pain around my jaw, and I hear sounds when I open and close in front of my ears. Okay? We don't have time to go over the details, but we did the examination, and we took the detailed history, and the diagnosis was what? Myofascial pain and disc displacement with reduction. Okay? What does myofascial pain mean? Pain in the muscles, the whole muscle mass. The difference between myofascial and myalgia is just a focal point in a specific muscle. In here, she has myofascial pain, that means the whole muscle mass, in the bilateral, in the masseter temporalis, and the lateral pterygoid against function, against resistance. So that's the diagnosis for her condition regarding myofascial pain. For this displacement with reduction, we can just go over the basic anatomy, just a review for you to refresh your memory. ما في pointer, good. Guys, شوفون البينك هذا المفروض represent the articular disc. What is it supposed to be? The normal position on top of the condyle, right? That's in the rest position. What about during function? It's still on top of the condyle. So they move concomitantly and smoothly, so the position remains the same during rest and any functional movement. That's in healthy people. So what about in this condition? As you can see, this is the disc. Instead of being on top of the condyle, it's being displaced anteriorly. So that's this displacement. What does with reduction mean? It means that when the patient is moving, the disc will reproduce back or like reduce back to its normal position on top of the condyle, so the patient can go ahead and move normally. There's no restriction in movement. So when do the articular disc move back to its normal position? Once they want to move past the articular eminence. And that's when we hear the clicking during opening and closing, during the translation, around 20-25 millimeter. Okay, so just in short, that's the condition of the patient that we have. And then, شنو history مال chief complaint? She said the pain started 2 years ago. It was like started with mild pain, something like is bothering her around the like the joint around the face. And she said she didn't give any attention because something, and I didn't need to worry about. It's not that of much of pain. However, after almost a year, then no, it became more frequent. And now she said the pain comes around 4 to 5 times a week, and the pain lasts for 3 hours. And that pain, I can describe it as dull, like I feel tension. Okay, no. Wait, okay. إنها مو شغال خلاص. I feel tension around my cheek. وحتى شوية up to my head. And for the history of the treatment, and it's been 2 years, and I just saw her. So what's the history of the treatment? يلا إن شاء الله خلق قاعدين بس. إيه. Treatment received was a closal guard, muscle relaxant, soft diet, but actually she said like all after a year of experiencing the first pain, she went to a physician, then who like did some, I gave her some analgesics. It didn't work. Then she was referred to ENT. He did some examination. Everything was within normal limits. And then she saw the dentist at the end, where like he started doing some treatment, and these are the treatments that was received. Okay, occlusal guard, muscle relaxant, soft diet. And she said now she was referred to an oral surgeon for like a further treatment. And I think خلاص now the non-invasive treatment has been done. That's what the dentist think. And then it's time for further more aggressive treatment. So the question, do we agree with that? لأن the patient didn't feel any better, and she's going to the oral surgeon. يعني هم قصدهم إنه it's time for surgery or something more aggressive, maybe erythrocentesis, something like this. فالحين خلينا نقول ليش what's supposed to be maybe done any better way to confirm that we existed all the possible treatments that are non-invasive. Okay, so I'm going to give you an example as a dentist. Events like steroid injection will be given by a surgeon. So once you refer it, you're going to do something شوي aggressive, more just simple treatment. So the question is, if you, as a dentist, patient comes to you with multiple caries lesion, and his chief complaint, I have caries. You can see the discoloration, and food gets trapped because all the caries lesion. So what you do is you do the ideal restoration needed. Okay, you restored all the teeth, and patient is happy. If the patient comes back in 5 years, who think that this patient will be caries-free or no problem? محد? Then who think this patient will come back most definitely with some caries or some problems? هم محد؟ كنا نايمين؟ إيه يعني then why definitely this patient will come back with after 5 years after doing just restoration and he's coming back in 5 years that mostly he will have some caries lesion. Why? Exactly. يعني السؤال شنو etiology؟ انت شفت في caries سويت restoration and then that's part of the treatment. But what caused the caries? يعني the bacterial load of cardiogenic bacteria is high. Why? Oral hygiene is bad and cardiogenic diet. Did we address that? We didn't. What happened? Patient will come back with more problems. Exactly the same thing for the TMD or any other disease. Once the patient, and even that's, I want to show you that this simple treatment that dentist did was the ideal treatment as non-invasive. That's a good way. Alhamdulillah ما سوى شيء aggressive. And then بس بعدين he referred the patient to a surgeon. احنا خلينا نشوف شنو what can do better hopefully would affect this patient to relieve the symptoms. إنزين فأول شيء قلنا احنا بنسويه إنه what's the point, what's the idea? Stop the progression of the disease. We have to look up for the etiology, not just alleviate the symptoms. We should know what's going on with the patient, what caused this condition, and let's try to control it. Okay, that's the first thing. We need patient to be really cooperative for the treatment to be successful, because at the end it's the patient compliance that would make the treatment successful. And as we said, it's عندك caries, so with restoration, no good oral hygiene, your restoration, even if it was a textbook restoration with the best restorations, but they will fail in the future. The same thing, we start with patient education, patient awareness, self-care. They would know what's their condition. We explain to them, that's our diagnosis, what happened. And now we should look for the etiology. What caused the problem? Let's try to stop it. That's the first thing we try to do. So the next step after we do the patient education is what? Find the etiological factor. What's maybe is causing this problem? Let's go and discuss these risk factors. Age and gender we talked about, and we have no control. We can't do anything about it. Okay, what about systemic disease? We should investigate more about it, doing blood tests and more examination. With this patient said she was healthy and she's young, so no problem. For example, if the patient has rheumatoid arthritis, how would you be suspicious? If she has pain somewhere else beside the joint, right? And for example, then you need to run do blood tests, rheumatoid factors, and so on. Well, this patient was healthy, so we eliminate that. Sleep quality. Any sleep has been shown to affect any pain, especially chronic pain. So if they have trouble sleeping, then that means affecting the condition. Or whatever you do, the sleep, inappropriate sleep will affect your treatment. So we should take care of this. How, as a dentist, can we take care of that? We only do some examination and a questionnaire the patient needs to fill, and we look at the result. If we are suspicious about poor sleep quality, then we refer the patient to the pulmonologist or ENT. It depends. Is it the examination, there's something wrong with them, or the sleepiness scale we suspecting, then we refer them to a pulmonologist or sleep medicine. For this patient, she was okay. She didn't have any problem. She didn't report anything. For trauma, no major trauma. Any trauma, two type, either macro trauma or micro trauma. Major trauma, she didn't report anything. No accident, no whiplash or any sports injuries. And then we look for micro trauma, like oral parafunction. The most common one is bruxism. Looking intraorally, she didn't have any cupping, any wearing facets, so we might exclude that. But how would we know if the patient didn't report any parafunctional habit? Then how can we confirm it? خلاص we confirm that it doesn't work? She said no, according. Yeah, she doesn't have attrition. So يعني, I didn't find anything. So how to look up, and the patient is not helpful, then we should give the patient a homework. I will show you like a diary she needs to fill to see if she's doing anything wrong with her jaw. يعني trying لأن ما في شيء clinically والhistory ما في شيء any risk factors. And we'll talk about it later in a minute. حلو. Psychosocial factors, you know, lifestyle stresses can cause depression and anxiety, and if the patient personality is somatization, then we're in trouble. So how would we know as a dentist? Also, there is a simple screening form, it's called PHQ-4. We'll let the patient fill it. If there is any, we're suspecting, or the patient fill with some psychological problem, then we refer the patient to a psychologist or psychiatrist. Patient didn't say anything, she put all the zeros, so according to her, everything is normal, she has no stress in life and no depression. And then the next is the anatomical factors. What has been shown in the literature, يعني, it's a correlation, not causation. Really major, like occlusal discrepancy. It's like condylar asymmetry, major class 2, major class 3, like lateral crossbite, severe open anterior open bite. That has been shown to contribute to TMD. So the question is, لو patient has severe class 2, what's the treatment for it? And also TMD symptoms. What's the treatment for severe class 2? Orthodontic surgery, right? Even severe, and you need surgery. So the question, if it's a risk factor, if you or any of these, most of these are severe discrepancies. Yani most of it they need orthodontic surgery, not just ortho treatment. So if it's a risk factor, if you treat one of these, do you think the symptoms will go away? That's why we call it more causative, correlative factors. It will help because there's a few RCT studies doing surgeries with patients. Like for example, I came across a class 2 with TMD symptoms, and they did orthodontic surgery, and not all of them, their symptoms enhanced. There's some where their symptoms was the same, and like little, their symptoms got worse. Yani that's why you cannot promise the patient, oh, you know, you have TMD and you have severe class 2, we'll do orthodontic surgery and your symptoms will go away. You cannot promise the patient. Yes, it's a factor. It's better to correct it. Why? Why it's better? It's a severe class 2. If it's not causative, we cannot confirm doing the surgery will prevent further deterioration. As a dentist, why you want us to do orthodontic surgery? To restore function, right? So you can, of course, promote that. This for sure, their function will be better. Even their sleep will be better, severe class 2. So there are things that we know for sure it's going to be enhanced, and we hope it's as a factor, and it might help, but because TMD, multifactorial, not one. If you can give me an example, if there's one treatment can fix it all, please let me know. I will apply it. That's why it's multifactorial. There's multiple treatments you need to do to control the case. So that's why class 2, don't tell them, okay, orthodontic surgery will solve the problem. Tell them it's a part of the treatment, and it will enhance your function and your sleep. Let's do it, and we'll control the other factors, and hopefully your symptoms will get better. And for example, that's the patient. You can see, what do you think about, what the first thing we look at? They can TMD. Look at the condyle and the articular eminence. What do you think? And that's the patient X-rays, the recent one. Okay, is it symmetrical? ولا في شوية different? Different. What about the condyle? Is it oval? No. فحين what do you think? we're looking at some abnormalities. شنو في asymmetrical, the head is not oval. So what do you think? We're supposed to systematic. We did all the blood tests needed. She was healthy. She didn't major trauma there wasn't. There's something صح؟ وهذا recent. بس would you do refer the patient for a surgeon because there is some abnormalities? ولا what do you think needs to be done? Exactly. Is it normal variation or something new? How would we know? We need history. So that was taken 2014. This was, she gave me another old x-rays that was taken 2010. What do you think? Almost exactly the same, صح? So it's 14 years, صح? يعني 14 years. We'll look at the, this is 2010. This is 2024. It's almost the same. معناته it's normal variation in her condition. Nothing is going on. If it is something going on, you would have seen much different, صح? فخلاص معناته إن this normal variation, maybe that's why she's having this dislocation because of the abnormality in the anatomy. That could be a reason, صح? Anything to correct? You have a surgeon. Anything you can correct it regarding this abnormality? So far, يعني, we don't recommend any surgery to correct this minor abnormality, okay? And especially, what about her symptoms? What do you think? Looking at this abnormality and her symptoms. Who thinks her symptoms are يعني, severe and need to be something immediately need to be done? No one, صح? يعني إن شاء الله we can control it. That's why she doesn't need to be referred to يعني, to do a surgery. الحين the question احنا looking at the risk factors, we're doing the examination, we didn't find anything يعني. كان شو نسوي؟ تروح البيت. فعشان كذا نسوي more investigation and we're trying to see يعني يعني last thing we're left with is parafunctional habits and the psychosocial factors. Maybe يعني patient is unconscious about it, so let's try to يعني to look it up. And what to do? We ask the patient to write anything abnormal that she does with her jaw. And then, so how can she write? What does she need to write? We need first to explain to her the normal movement of the jaw, right? So all of these are normal movement. If you do anything beside these, then you need to write it down, please. Write the dates, the time. I want to see you in 3 to 4 weeks, and I want this to be filled for almost 24 hours. I want to know every hour. If you notice anything with your jaw, you're holding it really hard, you're biting too hard, you're يعني what else I can think of? يعني abnormal. Maybe you sleep, you put your hand against your jaw. Anything and you do beside these, please write it down. That's one thing. You can ask your family and a friend to pay attention, to write it down too. And also, beside that, even eating and yawning are normal, but يعني eating, how long, يعني if you count the time you eat, how long do you eat a day in 24 hours? For the 3 meals and 2 snacks or whatever, how many meals you eat. يعني the total كم؟ صح؟ يعني there is no way it can reach 3 to 4 hours, صح؟ Insane. What if the patient is eating gum for the whole day? Maybe she's gonna think it's normal habit, صح? So you have to tell the patient, okay, eating more than like 2 to 3 hours, that's abnormal. So if you're watching TV and eating a snack all 2 to 3 hours, that's abnormal. If you're moving too much. If you're eating like the gum for the whole day, that's abnormal movement, okay? So if it is, you need to write it down. And beside that, we need to write pain details, okay? Not just the activity, because she said, يعني, regarding her pain, comes 4 to 5 times a week, 3 hours, okay, what's the time exactly? Okay, we need to write the details so we can match the activity with the pain. Do they relate or not? And so we can say, okay, maybe this is the correlation factor, okay? So far, we give patient what? أعطيناها بس محاضرة و homework. يعني no one will like that, صح? Patient, especially as a dentist, when they come to the dentist, what do they want? Immediate treatment, صح? What can we do in here? في something it's more يعني immediate is what? Is trigger point injection. Why? It is something just when you numb up the muscle خلينا نقول مو trigger point لأن she has myofascial all over the trigger point. So we numb up the muscle to confirm that the source of pain is the muscles. So once we trigger point to the muscle where she felt pain, and what we did is يعني الإكسترا يعني we approached extra oral just like infiltration around the muscle. Okay, we use for extra oral like 5 millimeter syringe, 27 gauge needle, 1.5 inch, and if you can see lidocaine 2%, without epinephrine. Never give like the muscle with epinephrine. You don't want to constrict the blood flow in there. صح? That's what we did. We gave her tegarbot injection. What about and if you examine intraorally and you press against the medial side of the ramus, what are you pressing against? Most of the TMD, orofacial pain patients, the muscle pain, they would jump when you press against the ramus, and especially if you go coronally toward the coronoid process. Why? What do you see in here? Pterygoids toward the pterygoid plate, صح؟ toward the skull. We're pressing against the ramus. What it's shown in here. أي هذا part of the temporalis, صح؟ هذا tendon. So if it's painful in here, معناته it's part of the myofascial pain of the temporalis. So we infiltrate also around this lidocaine, around this area to numb it up. وبعدين how we can intraoral injection of lateral pterygoid. That's the we don't have the time, and also we can reach it extraorally, but you need to use electromyograph to be more precise because there's no anatomical factor, يعني nothing to hit, يعني مثل bone. So you have to be precise, so it's better to use electromyograph. إنزين شنو الpoint of injecting all of these muscles? As we said, to numb it up, and we confirm the diagnosis, the myofascial pain, because the pain with palpation was 7 out of 10. Once we numbed the muscle, the pain was reduced dramatically, 1 out of 10. So we confirmed the pain. She said even not just with palpating was 1, and also يعني, the spontaneous pain was 1. She came with the clinic around 4, she said, but now after the injection it was 1 out of 10. معناتها most of the pain, okay, she has arthralgia, some inflammation around the joint, but most of the pain coming from muscles. So in this condition, is it hard or easy to treat? يعني المفروض انه يصير easy. It's only muscle. So إن شاء الله إنه this is a simple case to treat. So to confirm, as we said, خلاص الحين we numb her up. To make the muscle still relaxed, we gave her muscle relaxant, the maximum dose, okay, for the next 3 days, and then taper it down. I will see in 3 to 4 weeks, but we cannot give her muscle relaxant for the whole month. We don't want that. We told just it's going to help reduce the muscle tension, do physical therapy. طبعا ما راح تروح كل يوم مثل ما اللي شاف دكتور علاء مسوي. يعني no way someone will go to physical therapy daily for massage و يعني laser therapy whatever لأن المشوار وهذا طواله. We tell them to يعني there is a instrument they can like facial massage. They can use it. They can use warm pack. Anything to reduce the tension on the muscle. And I want to see you in 3 to 4 weeks so we can follow up with the homework that we gave her. And this is the trigger point injection. This is the review of the literature. It is helpful, and that's what we did. And follow up, that was she said. She came with said, okay, I noticed that most of the time, all day, I'm biting against my teeth. And that's why we don't see any attrition, because she's not proxing, she's just clenching. Okay, so that you won't see any obvious cusping. And she said that when she's driving, cooking, or teaching her children, she noted that she's biting her teeth. معناته احنا we call it what? During stress, she's biting. So that's a habit. And here comes the CBT. What's CBT, cognitive behavioral therapy? It's psychological treatment. It's simple. الحين أنت as a dentist, she's telling you, I'm biting my teeth almost all day. What would you tell her? شنو treatment? I'm biting. شنو treatment? احنا treatment إنه she doesn't bite, صح؟ فاحنا as a dentist we tell her, you know, this habit you have to stop it. إنزين شلون we follow up, we confirm. مفروض ها؟ Night guard during the day شلون تتكلم شلون تاكل؟ يعني no need in this condition لأنه مو at night. She can't control. So she need to adjust this habit. Exactly. احنا مو المفروض إن psychologist do this treatment. It's cognitive behavioral therapy. But as a dentist, because I had chronic pain management rotation with some psychotherapy exposure, we can start the CBT. بس شلون? We might have to make sure that their personality is not catastrophizing, and there's no depression, no anxiety. Then as a dentist, you can start it. So in CBT is supposed to be minimum 6 sessions. And each session, the first 2 sessions, you give them an alternative to their activity. Another activity they can do instead of biting. So and for example, we told her, instead, when you're driving, when you're cooking, and your stress, instead of, and one of the treatments is shown to be effective, is to have a small talk. And to yourself, instead of biting, when you concentrate, try to talk. ما نبي هذا more activity على الجوين ما نبي. فعشان كذي move your they say يعني هناك psychology try to talk to yourself. احنا نقول اذكر ربك. يعني همهمه يعني شويه عشان you make sure you're not biting. That's one thing. You can the other thing, you can put your tongue between your teeth. So once you bite, then you stop. يعني that's the another we're trying to break the habit. That's the first 2 visits. Then we need to see her every week to make sure how is she following up with the instructions. Okay, that's simply the CBT. And the question, how long will it take for the CBT to work? يعني احنا قاعد نسوي another study. خلصنا يا دكتور محمود. فبس الحين يلا دكتور محمود take over. الحين سوينا CBT. How long will it take the patient to go with a new habit? Even more, صح? So during this time شنو نعطيه كله muscle relaxant? What to do during this time? minimum راح تاخذ 4 to 6 months to adapt to a new habit. وبعدين for the body to يعني adapt or to heal, it's going to need another few months. So during this month, what can we do? If it's simple muscle problems, give Botox to the muscles, okay? But Botox by itself, it won't help. Well, it will help, then and it will paralyze the muscles, but هذا short term, صح? And then if you don't stop the habit, as we said, if you don't stop the course of the disease, it won't be helpful. It will be just يعني during this time, but in the future, it will come back. So the question, with the CBT, we give Botox injection, and we follow up. Hopefully, she stops that habit, and the Botox will help to relieve the disease. So we alleviated the symptoms with the Botox now, and we give her the CBT to follow up, and hopefully, she breaks down the habit. So what if this doesn't work and the condition became chronic? Dr. Mohammed Anous, inshallah, will take over to talk about this part.
Thank you. Okay, good evening, everybody. افتح. Okay, can you hear me? No. Yeah, it's working? Okay. It's not. And now it is. Okay. Okay, good evening. Now, what I want to say, now it's too late, and thank you guys for being here, and I'm sure this is a subject that's very dry, but that you guys also want to be capable of helping and treating your patients, especially that these people are in real misery because of what they're having, and it's a very well-spread disease, especially in younger female population, okay? First of all, what do you guys think of this picture? It's a very nice picture. It's a neonatal histo photograph of the TMJ, okay? okay? I don't think the pointer is working, okay? But what do you guys think this is? The disc? What's above it? What's that white thing there? Okay, so above, so the disc is between two compartments, two fluid-filled compartments, the upper compartment, upper joint compartment, and the lower joint compartment. The importance of that is when we want to do some minor surgical interventions, this is where we're going to be aiming for, okay? Now, my objective today is to tell you that when we need to treat these patients, our aim in treating these patients is what? Give me two important aims to treat these patients. So relieve pain, number one, restore function, okay? So it doesn't matter what the patient have. If the patient have rheumatoid arthritis or if the patient have just musculomyofascial pain, okay? The aim in my treatment is I just want to improve this patient pain and I want to restore their function. So if they're doing well, there's no need to aggravate the treatment or go for more invasive surgical management, except if they have a pathology or something that we do have to intervene. Now, when do we have to intervene? We have to intervene when we deplete all conservative management options and the patient is not responding, and we've tried several times and the patient is not responding. And sometimes we have to intervene immediately. In a case like the anchored disc phenomena or something that we call acute closed lock. Now, who's aware of that condition? Tell me. Again, you? Okay. Okay, so what she's saying is this patient wakes up in the morning and they cannot open their mouth because some sort of a negative pressure or a negative suction happened inside the joint that sucked the disc inside and the patient cannot open their mouth anymore. Now, sometimes it becomes unilateral and sometimes it's on both sides. Now, they usually don't respond to anything. They'll come to you as an emergency. They'll come to the emergency department with acute closed lock, and the treatment for that is we take them immediately. The treatment for that is we take them immediately and we do something like arthrocentesis to break the negative pressure and to open the adhesion. Now, an active arthritic disease, so someone who's with a rheumatoid arthritis, someone with psoriatic arthritis, there are different types of arthritis, systemic lupus, any of the diseases that affect joints, we probably are going to need to go one day and do surgeries from, at this case, if the pain and function are not restored by other options. Now, systemic internal derangement that does not improve in conservative management, ankylosis, just like you guys know what a tooth ankylosis is, the joint as well could ankylose. Ankylosis could be just a fibrous ankylosis, so fibrous tissue that preventing the joint from moving or the head of the condyle from moving, or it can be complete bony ankylosis that the whole TMJ becomes one bony mass. Trauma, of course, joint hypermobility, so people that dislocate a lot, they keep dislocating their joint. Pathology or neoplasm, so they have a tumor in their joint, and something called active condylar or hemicondylar hyperplasia. So they do have one of their condyles growing more than the other, and they have asymmetry. You can notice it at their chin. And when they have acute or adolescent idiopathic condylar resorption, where for no reason, idiopathic, they're having one of their condyles resorbing slowly. And of course, other congenital abnormalities. When we have one of these, we buckle up and Dr. Yaqub sends us his patients and we operate. Now, one more thing I want to tell you about operating on the TMJ. Operating on the TMJ depends a lot on the skill of the surgeon. Not every surgeon knows how to do all the procedures. Not every surgeon is trained to do all of the procedures. So sometimes you'd refer me a patient to do, for example, one of the surgical procedures, but I haven't done them a lot or I'm not comfortable with them. For example, to replace the whole joint with a prosthetic joint. That's something that we don't do often, okay, and that has a learning curve to climb, okay? So sometimes the surgeon will pick the surgery according to his comfort, You know, he's comfortable doing this surgery, and it works as well. So they'll do other surgeries. Now, when we do these surgeries, there are principles that we want to keep in mind. We want to do the least invasive surgery to accomplish the best results. The procedure should be aimed to remove any pathological tissues, aimed to reduce synovial inflammation, and surgery should also result in maximal preservation of the tissue, so you don't want to do harm. And whether you're doing these surgeries, if you're doing these surgeries under general anesthesia, make sure that you give local anesthesia as well. So, what is synovium, or what is the synovial membrane, and why is that important? Now, this joint that we saw that has the glenoid fossa at the top, it has the articular eminence, it has the retrodiscal tissue, it has the disc, it has the condyle, superior, inferior compartment, and they're all engulfed in what? How do we keep this fluid inside? A capsule, okay? Now, this capsule could be inflamed. We call that what? Capsulitis. And the synovial membrane that produces the synovial fluid could be inflamed, so we call that synovitis. But also synovitis is when we have pain inflammatory mediators inside that joint, and those cause continuous pain, and they pile up, and they change the medium of that joint. That's where we want to change that synovium. We want to change that medium. We want to get rid of the accumulation of these inflammatory mediators. So we can do something like arthrocentesis that could change the whole medium of the TMJ, and can also break some adhesions by putting a fluid pressure all the time on them. Now, a step further is to do arthroscopy. So go with a scope. You can visualize your joint. You can make a diagnosis, although diagnosis doesn't have to depend on us visualizing the joint immediately or at the same time. And if all of these fail, we have indications to operate. Okay, so arthrocentesis, it's fast, it's easy. You can do it under local anesthesia. What you do usually is when Dr. Yaqub depletes his options, you've done everything, and you've done Botox. And what I usually do when they refer me a patient, I do like to do my conservative management myself. So yes, let's say this doctor right there, she sends me a patient, she said, I tried to do conservative therapy with her. I'm a big believer in conservative therapy. I'm a huge believer in Botox. I think it helped most of my patients, okay? But when all of that is done, I do arthrocentesis under local anesthesia or under general anesthesia sometimes, okay? So it changes the synovium medium. That helps a lot. It breaks adhesions. That helps a lot as well, okay? But it does not change the joint morphology. It has limited capabilities. Okay, now if you look at that picture there, what we usually do to landmark and to be able to do this is we draw a line from the lateral canthus to the mid-tragus, okay? And now literature has different approaches, but this is one of the common approaches to do it. We go about centimeter from the tragus, and then we drop down a little bit. We make our first point, and then we go 2 centimeters, we drop down a little bit, and we make the second point. Now, one point is in-port, where you push fluids, and the other one is an outport where the synovial fluid, the infected synovial fluid leaves from. I usually use something called lactated ringer, and I add heparin to it, so we call it heparinated lactate ringer. I usually use about 200 cc's to wash a joint. 200 cc's is 200 ml. And I use other stuff when I finish also to improve the joint. Now, that's not the greatest video, but it's one of my videos, so I want to show it to you guys, okay? So that one I'm using right there, that device is the one-port device. So I don't need to have 2 points to wash my joints. 1 point, it has an input and output, okay? And as you know, which joint space am I entering? No? Superior joint space, okay? And after that, I inject some stuff. Now, arthroscopy, which I don't do, but we do in Farwania Hospital by Dr. Ahmed Al-Kandiri. He's, I think, the one and only to do arthroscopic surgery. Now, I've done a lot of arthroscopies in my residencies, but most of them, they used to be called diagnostic lysis and lavage. So what we do is we just enter, just like arthrocentesis, we do visualize the joint, but that was for insurance purposes, okay? And we push fluids and we push other medications in order to change the synovium. Now, in diagnostic lysis and lavage arthroscopy, the also thing that we use to benefit from is the metal part that you go with. It's a little bit thicker, and we used to sweep it all up around the glenoid fossa to break any adhesions, or that's what we think, you know, and it used to help a lot. Now, the success rate is about 85%, and the VAS, or visual analog scale, reduced by 4.6. The mouth opening improves by about a centimeter. So it's very, very promising intervention. Now, that's diagnostic lysis and lavage arthroscopy, and there's the interventional, where they go in, they can visualize, they can take a biopsy, they can remove redundant tissue, and you can always, of course, correlate that to your clinical and radiographical examination. It's also used in severe degenerative joint disease, and some people, they can do disc repositioning or cauterization or shrinking that tissue. Now, whether you're doing an arthrocentesis or you're doing an arthroscopy, lysis and lavage, what you do is you enter the upper joint space, which is about 2 cc's. You have to inject local to encephalate the joint so you can have more working space, just like when they do abdominal surgery and they encephalate with gas, okay? You want to go aim for the zygomatic arch and just go from there, do 1 puncture to the capsule. Try not to do more than 1 puncture so you don't have spillage outside that area, and start your fluid injection. Now, there are 7 points they talk about when they look at the joint in an arthroscope, and each represent something and helps in diagnosis, but it doesn't really change the management. Now, this is one of the cases that we do in Farwania Hospital by Dr. Ahmed Al-Kandiri here. Okay, you can see we have screen here that we're watching, all of us are watching while this arthroscopy is going. Sometimes he does lysis and lavage, sometimes he does more interventions, okay, where he manipulates the disc or put it back in place. Other things that we do when we do arthrocentesis or when we do arthroscopy is that we can inject stuff that can help us a lot. For example, one of the doctors earlier here said steroids, and that's one of the steroids that we prefer to inject in somebody's joint. Why? What does a steroid do? It's the biggest, most potent anti-inflammatory that could stop all the inflammation that's happening there or reduce it at least. Okay, we also inject nowadays something called hyaluronic acid. Yes, we do inject them as facial fillers, but we also inject them inside the joint. Okay, and that helps a lot in lubrication. Hyaluronic acid is a subunit of collagen, and it helps the improvement of synovial fluid. Researchers on using PRP, platelet-rich plasma. Some people, they inject botulinum toxin to the joint in order to try to catch the lateral pterygoid attachment. And when patients have the hypermobility or the dislocation, the recurrent dislocation, we also inject sclerosing agents. So so people with hypermobility that they dislocate, and sometimes they dislocate more than once a day, okay, they have to stop having that happen. And one of the minor interventions that we can do is to inject their capsule with sclerosing agent or inject it in their own blood. They call it autologous blood, and that should toughen the capsule a little bit and preventing the joint from dislocating. 5 minutes? I need half an hour at least. No, you do want to go home? No, they want to listen. Come on. You can go home. Huh? Okay, we'll go really quickly, okay? Now, there are limitations to arthrocentesis and arthroscopy, like disc perforation, and it's symptomatic. It doesn't matter if it's perforated or not. It matters that they have pain and they have limitation of function, as we said at the beginning. So whether they have disc perforation or not, if they're pain-free, we know this may worsen with time, but if they're pain-free, we don't want to do much about it. Bony changes like arthritis, ankylosis, where they can't open their mouth, and overlying skin infection, we don't want to go through an infection. Now, complications of arthrocentesis and arthroscopy is nerve injury, for example, to the facial or to the trigeminal nerve, okay? Some people perforate, that's one of the common ones when you talk about complications of that is perforating into the middle ear or tympanic membrane, okay? When that happens, we know how to treat it, or we send it to ENT if it's really a big tear in the tympanic membrane. Glenoid fossa puncture. So as you see here, it's very close to the base of the skull, and yes, it happened, and I lived that experience. When I was a resident, I saw that happening. You can have epidural hematoma, and the patient can die from it. It's a safe procedure, but these are, when we talk about complications, these are the complications that you can encounter, okay? An infection of the joint, and if you have joint effusion, that means the joint is surrounded with fluid and the condyle is not in place anymore, and instrument breakage or foreign body reaction. Now, when do we open the joint? Absolute indication is what? Pain function, again, okay? Absolute indication, the patient does have pain, does have limitation of function, and we depleted all other options. Now we're gonna go to absolute indication of open joint, fibrous or bony ankylosis. These patients cannot open their mouth at all. Okay, pathology. What's the most common pathology of TMJ for the dental students? They're fresh. Which one? What is the most common pathology of TMJ? So I think osteochondroma is one of the most common pathology of TMJ, and if that happens, you have to go and you have to remove it. Condylar hyperplasia, if it doesn't stop by itself and the condyle keeps on growing, then orthognathic alone cannot help. You have to go and you have to shave that condyle, okay? And if you have recurrent dislocation, as we said, the patient is dislocating all the time. I've injected them with autologous blood and sclerosing agent. It still didn't work. I put them on MMF, maxillary mandibular fixation, for 4 or 6 weeks, and that didn't work. Then I have to open and I have to surgically intervene. Okay? Now, one of the procedures that we can do for these patients is something called intraoral. There is an extraoral variant, but we usually do the intraoral vertical ramus osteotomy. So how they found out about this? When patient with known TMD that weren't resolving with all management, they had condylar fracture because they fell or they had a fight. They found that those patients had their pain relieved after they have the condyle discontinued from the rest of the mandibles. Someone thought about it, and I can't reference that right now, but they thought about that and they said, okay, why don't we deliberately make a fracture, a vertical fracture in the middle of the mandible, and not fixate it and just allow the tissue to build back itself. And after you do that, you have them fractured like this. You don't leave them, but you put them on heavy elastics. We used to put them on wires, wire shut for 6 weeks, but now we just put them on heavy elastics and they heal very well. And the cases I've done, they're like complete success. Now, when you have disc derangement, when should you operate, okay? Now, I put this because I really want to tell you about it, whether it's in dentistry or in surgery. Okay, a good surgeon knows when to, how to operate. A better surgeon knows when to operate, and a best surgeon knows when not to operate, okay? It's very important to keep that in mind. Now, American Association of Oromaxillofacial Surgery in 23 put indication to when to operate on disc derangement. So they said, again, if we have pain and limitation of function, and failure of milder intervention, persistent moderate pain, limitation of movement, and imaging that show that we need to operate that coincide with everything else. Now, we can do discectomy. We can just remove the disc, replace it or not, depends on the case. We can do discoplasty, where we repair the disc, or we can do discopexy or imbrication or application of the disc. Now, that all depends on what? On the condition of the disc, the surgical preference.
Thank you so much. We have to wrap it up.
Okay, I'm sorry, I tried. Okay, can I show them one slide only? Okay. Okay. Okay, so we usually go through a preauricular incision. That's the incision that we usually go through. Now, sometimes you can go from behind the tragus, and some surgeons, they have more conservative management. When you want to put the disc back, this is one of the ways to put it back. That's called a mitic anchor. You can put it in the posterior part of the condyle and just tie the disc to it, okay? Eminectomy is where you remove the eminence, either to have access to do some disc repair or also for hypermobility. So someone that dislocate a lot, if you remove that eminence, they will not dislocate anymore because there is nothing to dislocate from. Now, for ankylosis, I just want to show you, when patients have ankylosis, so they have their joint fused, okay, the blood supply and the anatomy there changes. So we always like to get advanced arterial images so we can see what arteries are around there before we operate, okay? And that's how an ankylosed joint look, and of course we take thing. Now, thanks to Dr. Ahmed introduced me to piezo. I used to do this in a different way before, but now I'm doing it with piezo. So that's how we look. It's completely bone, you know, and we have to go and remove that bone, okay? And then the last part of that, we probably won't do it with piezo. We'll just try to finish with an osteotome and just open that ankylosis. Now, sometimes we just do nothing and wait a little bit and then reconstruct, and sometimes people reconstruct immediately. Now, the goal of that is to restore function and decrease the chronic pain for the patient. In some cases, in adolescents, and we've done that many times before, we take ribs to reconstruct the, and yes, we do it, nobody does it. The maxillofacial surgeon takes the rib and puts it instead of the TMJ. Okay, now there are limitations to that. We like to use, when we do temporomandibular joint restriction, we like to do the custom-made one, the one that's designed for the patient itself. It's usually all titanium, and I'll show a small video here that shows you from an ankylosis case how they take a CT scan, they do a VSP, and then they just, I'll finish in a minute, 1 minute, okay? And they just do that joint thing, okay? Now, the aim here, this is AI-generated image, I love it. Okay, he looks like I said TMJ relieved pain, and it gave me this image. Now, the criteria of success is to have this device stable inside to biocompatible, withstand loads, and thank you very much.
Thank you very much, Dr.
Thank you.
Mahmoud. And Dr. Yaqub, if you'd like to come to the stage. Small token of appreciation.
Questions? Question? Okay. Okay. Thank you.